Ladies and gentlemen, a very good afternoon. I'm Dr. Kinju Adhikari, Intuitive Fellow in Uro-Oncology and Robotic Surgery in HCG Cancer Center. I'll be your host today, this afternoon, for the inauguration as well as ordination ceremony. I'm much delighted to offer you a hearty welcome in this inauguration program of SOGOCON 2022. We all know Uro-Oncology has been ever-evolving branch, and with the advent of robotic surgery, urologists are more alert to it. There was no organization dedicated to Uro-Oncology, thus the formation of the Society of Genitourinary Oncologists in 2019. SOGO has been aspiring to disseminate the knowledge through various platforms, one of which is the conference. On behalf of SOGO, we are proud to commence the first ever annual national level conference in Bangalore. We are honored to be witnessing a high level of participation in this event. We are joined by renowned faculties and distinguished delegates, both national as well as international. To begin with the program, ladies and gentlemen, I would like to invite our following dignitaries to the dais. Dr. Shekhar Patil, Organizing Chairman, SOGOCON. Dr. Raghunath S.K., Organizing Secretary, SOGOCON, Secretary, SOGO. Dr. Ginil Kumar Puleri, Treasurer, SOGO. Dr. Sudhir Raul, President-elect, SOGO. Dr. Jagdish Kulkarni, President, SOGO. Thank you very much. As a part of our culture and tradition, we commence any auspicious occasion with the divine blessings, and the light is the testament of assuring positive energy for the same. So let us start by inviting all our dignitaries to please proceed towards the lighting of the lamp. Thank you for doing the honors. Let us hope the light of knowledge is abundant today, tomorrow, and every day. Without further ado, to welcome all of you with his welcome speech, please join me in inviting Organizing Chairman of SOGOCON, Dr. Shekhar Patil.
Good afternoon to one and all, and all respected senior teachers on the dais. First of all, I would like to thank the Society of Genitourinary Oncology, the organizing committee, for having given us this opportunity to host this first annual conference at Bangalore under the leadership of Dr. Raghunath. And in order to see that that conference scientific material is taken care of, Dr. Raghunath, along with his scientific committee, organizing committee of the scientific chair, he has brought out so nicely all the contents of the involving the multidisciplinary approaches, involving the medical oncologist, radiation oncologist, psycho-oncologist, pathologist, radiologist. So almost all the specialties were involved in these multidisciplinary discussions. And yesterday's workshop was worth looking at it, involving the pathologist, the psycho-oncologist workshop. It was a radiation oncologist workshop on the SPRT and cyberknife was really good. And the Society of this Genitourinary Oncology, which has been installed about only 2 years back, and they are doing a great job. I feel that the way they are working with such an enthusiastic team in the organizing committee, I see that this is the most evolving specialty, and they are encouraging so much the youngsters to take up this specialty. I see that so much of outcomes are improving because of the multidisciplinary approaches, and they are doing a great job as far as I can see in the last 2 years. Just as a general oncologist I can talk of. And this conference with so much of attendance, and I think it will help us in disseminating the knowledge and exchanging our ideas, and also to network and collaborate and do some good research work in the coming days. And I think all the best for this first conference, annual conference, which is held under the aegis of SOGO. And all the best for the conference, and welcome all of you for this particular meeting. And I hope that you learn a lot and carry some sweet memories about our hospitality, and also the knowledge what we are going to gain out of it, which may help in your day-to-day practice. Thank you one and all for the things.
Thank you, sir. SOGO takes pride in felicitating Dr. M.R. Kamath and acknowledging his pioneering contribution to the field of uro-oncology. While he is unable to be with us today, Dr. Jagdish Kulkarni, President of SOGO, and Dr. Ganesh Vakchi, Council Member of SOGO, had the privilege to visit him in Mumbai and bestow him with his honor. I now invite Dr. Jagdish Kulkarni to do the honors of delivering the citation.
Good afternoon. Thank you very much. It gives me great pleasure in felicitating my mentor, with whom I shared about 14 years of my younger days in uro-oncology. In fact, he was the one who inspired me to get into that. But traditionally, it is always there that we should give him what was his curriculum and other things. I have to tell you that he was born in a small village near Alibag in Maharashtra on 6th May 1934. He had a primary schooling in Alibag. Later on, he went to Pune and had a medical education in GS Medical College with merits. He finished his MS, and then he went to US, where he was trained under Dr. Willett Whitmore, which again he says that he's inspired him to take up uro-oncology. Later on, he completed Diplomate of American Board of Urology and returned to India in 1970. Again, he joined Tata Memorial in 1970 as a staff surgeon. Later on, to be forming a department of uro-oncology in 1973 till he retired in 1993. During his 20-year-long career as the head of urology, he did several things, new things in oncology in India, and he inspired so many of us as well. during his illustrious career, he had so many new operations, new protocols, of course. And when I asked him that, can you come and address us, he said, I am indisposed at this point of time. I would not be in a position to make it. So governing council advised me to visit his home and take his blessings for the Uro-Oncology Society, or SOGO. Can we have his video now?
On 19th August 2022, on the advice of Society of Genitourinary Oncology Council and SOGOCON conference, to felicitate Dr. M.R. Kamat, who is the pioneer uro-oncologist in India. Thank you.
Thank you. I am honored.
This is the memento which has been given by SOGO.
Initially, I must explain the background of cancer as a specialty which did not exist at all in the past. At this time, some general surgeons who were attached to the teaching hospital connected with the medical colleges, none of them were involved in treating the cancer patient. With the progress in surgery, various subspecialties slowly evolved. Urology was one of them. Without going into details, initial urologists were trained in UK, were doing open surgery, and cystoscopy was done by battery operated light. No one had operative skill to do surgery through urethra. In 1971, when I returned from USA, there were only 2 or 3 urologists trained at the university hospital in America or Canada who knew how to do the transurethral resection, briefly called TUR, of the prostate or bladder tumor. Each one of them got attachment to the large hospital, and I was lucky to have selected full-time cancer surgery in Tata Memorial Center, or TMC. In a couple of years, director of Tata Memorial Center made the divisions of units, and I became chief of uro-oncology, the subdivision of urology that I was interested in. I must go back a little since I was the first uro-oncologist in India. My inspiration came from Dr. Willett Whitmore, the father of uro-oncology in America. I was his resident then in 1966-67, Memorial Cancer Hospital in New York. He was very humble, great academician, had excellent operative skill, and his lectures were attended at the national level by all urologists. If that was my initial inspiration, my further stimulus in uro-oncology was from my junior colleagues in Tata Memorial. In fact, I chose my resident fellows with prior interviews and trained them adequately. 2 of them took over my position after my retirement, remaining trained in my unit, took over from the operative technique and discipline that I was practicing. In my unit, I started review of charts of the treated patients. Since all treated cancer patients, the follow-up was important to know the recurrences and its treatment and success with the survival in terms of years. We also started general club in my office, attended by my residents, fellows and fellow urologists in Mumbai. We also started monthly urology meetings for urologists and their residents in various hospitals to present their clinical work. This created a bridge between the urology and uro-oncology, which was appreciated by our hospital, but by other disciplines also in the city. In addition, me and my junior associates put together our experience and new innovations, wrote papers which were published in national and international journals. It will not be out of place to mention few innovations that we did. Debunking large metastatic nodes from the testicular tumors adherent to the major blood vessels retroperitoneally was managed by a technique evolved by us. The nodes that were stuck to the major blood vessels we operated without the help of a vascular surgeon. The malignant tumors of kidney, for doing partial nephrectomy, we introduced that to in suitable patient. Third innovation was radical cystoprostatectomy for carcinoma of the bladder muscle invasive, where we started new bladder using ileocecal segment connecting to preserved prostatic cuff, which improved the continence and continence. We are not claiming absolute originality in the world, but certainly in India. At this stage, there are enough urologists practicing uro-oncology all over. Besides, like other cancers, urological cancers are also treated by combined modality of surgery, radiation therapy and chemotherapy.
Thank you, sir, for your thoughts and blessings. And we're looking forward to the society, the progress, and we'll keep you informed. Once again, thank you very much, sir. Thank you so much.
Thank you.
Thank you, Dr. Jagdish Kulkarni and Dr. Ganesh Bakshi for doing this honor. Moving forward, may I invite Dr. Sudhir Raul, President-elect of SOGO, for his address.
Good afternoon, dignitaries on dais, President SOGO Dr. Jagdish Kulkarni, Organizing Chairman Dr. Shekhar Patil, our Secretary and Organizing Secretary Raghunath, Treasurer Dr. Ginil, my teacher Dr. Ganesh, Dr. V. Srinivas, Dr. Mahesh Desai, and friends like Badri, Dr. Singh, and Anish, other friends are there. So may I take this honor to address you. This is in the first SOGOCON, which actually was the natural inception when you see the subspecialty growing. It was not like we wanted to do it for some other reason. We thought that as the number of uro-oncologists focusing on uro-oncology, urologists focusing on uro-oncology, and medical oncologists, and also radiation oncologists focusing on urological cancer, we thought, let us make a society which will actually further take it for the younger urologist. If I go back in time, because in 1996 I joined Rajiv Gandhi Cancer Hospital, but before that I was doing MCH from CMC Vellore, and I saw one video from Dr. Srinivas. This was in the library of CMC, and that showed how the cystectomy is done, and then ileal conduit, how to take care of ileal conduit. So I came to know about Dr. Srinivas there. He was CMC graduate also. And when I came back to North, which was my decision to come back to North, which Dr. Ganesh did not like, because he said, you are going in private practice after studying so much, that's not a good idea. But then by luck, I landed up in the cancer center, which by also serendipity, not luck. It was not my choice. I never wanted to be a cancer surgeon in my life. I wanted to be a transplant surgeon. But then in whole of Delhi, I did not get any job except this place, which actually got because of Dr. K.K. Pandey. He's no more, and I worked with him before going to Vellore. So he said, can you join this place? I thought I'll join this place for 2 years and leave this place and go to my general urology. But after 2 months, I realized that this is the probably best place for me, because I love doing challenging surgery. right from the beginning. Even in Vellore, I will scrub up or roam around the cases which are complicated, especially when Dr. Ganesh will do renal revascularization surgery. So those were the dream surgery. And it was so, humble that center was, that when I got married, I was in CMC only, and my wife came to CMC. So we were operating with cystectomy. So she was surprised that you guys do cystectomy in this country, because she has never thought. She was in BHU as a medical student. But then how the things had evolved that everybody does these things. So with that, I joined this place, and after some time, I got a lot of young urologists coming, and my first, not fellow, rather observer, who made his career into uro-oncology was Ginel. He came for 15 days in the hospital, and at that time he came to learn the radical prostatectomy only. And luckily we got everyday radical prostatectomy in my OT, and I showed him the open surgery. That time I was doing open surgery, and then many people came, Raghunath and a lot of doctors from even Nepal, Robin is there. So things, they evolved into a lot of urologists becoming uro-oncologists. And that is why we landed up in this society, because this society was not, it was just a natural event, which Raghu told me in Lucknow when we organized one conference in Lucknow with Pahwa and Dr. Anish. He said, sir, we should do this, you should do this, you are one of the first one. So I said, okay. Then I talked to Dr. Kulkarni in Calcutta, and he agreed. Then I had to take permission from my senior, Dr. Nitin and Dr. Ganesh. So everybody said, you should do it. And that's what it happened. But a lot of hard work has been done by everyone involved. I will say the name Raghunath, Ginel, Vedang, Raghavan, and many others who are actually, I may be missing a lot of names, but they have worked hard for this. And we actually planned first physical meeting in 2020 in April. And, and we had a annual day conference in TMH. There we decided that because of the pandemic, the society was made in January 2020, and the physical meeting was supposed to happen in April 2020. But because of the pandemic, we thought, let us call it off. And we were not sure what will happen. And Badri and Manoharan were supposed to come. They were ready. And they were rather disappointed. Why did you call it off? And in March 20, you had Janta curfew, and next day you had lockdown completely. So for 2 years, we could not do anything. Rather, in late 2020, we had one webinar, first webinar, where Chris Wood joined us from MD Anderson. He's no more, unfortunately. He had some cardiac complication or pulmonary embolism. He was a great surgeon. He touched many lives here, right from the young urologist to me. He got trained a lot of people from Rajiv Gandhi in MD Anderson, as Badri has always supported our program. So, but he's no more now, but otherwise he would have been here. So with that, we did, I think, multiple webinar after that, and we made a structured program where Raghavan is the in charge, and now they are working on how to go into research as a SOGO. Now, because we were looking for funding in this society, hopefully we will get good funding so that we can support our research, trials, and maybe some later on the journal. I remember Dr. Kulkarni, he actually, in 1997, he organized one UCCon. And I was in 1996 in Rajiv Gandhi Cancer Hospital. So my radiotherapist was Dr. Hukku. And he told me that Dr. Kulkarni has called you especially because when I told him we have a urologist working in a cancer center, so he said, send him because at least someone from North is doing this thing. Because there was only 4 uro-oncologists in the country, Dr. Srinivas, Dr. Murali Kamath, Dr. Kulkarni, and Hemant in the TMH. Mine was a private institute, but then it was a cancer center, pure cancer center. So I joined there, and then I could get a lot of support from Dr. Ganesh, Dr. Gupta, and Dr. Kulkarni also, even Dr. Kamath. Wherever he will see me, he will catch me, and he will talk to me. And at one point of time, he dropped me to airport when actually we both were attending a conference. And with that, things evolved. And after this SOGO, we formalize everything, we have everything done. Then we thought of organizing this first SOGOCON, which actually focusing on all the aspect of uro-oncology, say the surgical, medical, radiation, uropathologist, psycho-oncology, and the molecular, we have molecular pathologist scientist also the member of this society. So with that, I'll say that I'm looking forward to have a great learning through this conference when we will do the events, and we will be having, we would like to have as much as possible to focus in a subspecialty rather than roaming around all in the all the urological field, because that does not take you anywhere. In future, rather than uro-oncology, what will happen? I probably will end up with one organ. Maybe after 5 years, I'll say, I'll not do anything, I'll do this. So that's what we are looking for in future. With that, thanks a lot, and thanks for coming and making this conference successful.
Thank you, sir. May I now request Dr. Jagdish Kulkarni, President of SOGO, for delivering the address.
Again, I'm standing in front of you. Okay, good afternoon. Dignitaries on dais and dignitaries on the floor, and all the delegates, not only urological delegates, but also uropathologists and radiation oncologists, medical oncologists. It gives me great pleasure in addressing first SOGOCON and a SOGO meeting. I'm extremely happy to have my mission is fulfilled to felicitate Doyen of Uro-Oncology, Dr. M.R. Kamath, and second Doyen, Dr. Srinivas, who is going to give an oration. So I think I'm feeling very proud for that. Having said that, Dr. Rawal has already made my job very simple. He actually gave us the idea, how did we conceptualize it. If you have to go back to the history, and Dr. Badrinath Koneti is here, 1986, I was in the US with Dr. Donahue, who was the first president of Society of Uro-Oncology, and who was the secretary, Dr. Donald Skinner. And then you have Dave Paulson. And one of the council members was Dr. Patrick Walsh. And I had that kind. When I was there, and I always felt, now, do you think we will be ever having this kind of facility in India? And yes, when I talked to Dr. Donahue, then president of SUO, he said, you will have a lot of difficulties in the beginning, but you will be in a position to overcome. And when I asked him, how did you decide to get into Society of Uro-Oncology? And he said, it is an NCI project. NCI had requested urologists to now form a society so that people and patients would know what is called patient data query, to note the whole thing. And that's how the Society of Uro-Oncology first started in 1984, had a formal inauguration in 1986, and there you are. And this is exactly what we were conceiving. And then 90s, when I came back, Dr. Nageshwara was the one who started sectional meetings of the uro-oncology, and then in around 2000, Dr. Ginil and others will remember that we started a COPE meeting, which of course did not last long. Dr. Rawal was also in that COPE meeting, which didn't last long, and we were just wondering whether we will be in a position to, till this happened, and ultimately the dream came true. Now, what is SOGO? Society of Genitourinary. I would say that this is a society with a difference. And what difference it is? Society of Urologic Oncology in US is perhaps concentrating most of urologists. I think I'm now told that some medical oncologists have been included, but this is the society. We are starting with a multidisciplinary tumor specialty. Like you have a pathologist, you have a radiation oncologist, we have medical oncologists, and also several psycho-oncologists, and so many things. So, as the urological oncology patients are, requiring so many multidisciplinary approaches, we thought this is the society which we will have. Now, what are the aims and objectives? Obviously, any society when you form, the aims and objectives are clinical, research, education, and not to forget about commitment to the society. And what do we mean by commitment to the society? Conducting camps, awareness programs, and also going to the, helping to the people in terms of lifestyle management and also palliative care, or end management also. So I think this is where we are concentrating into this. Of late, we are now using a social platform, which is becoming very important. And yesterday, when at a council meeting, we decided that we will have 4 social platforms being used. First is a website. It will be very active, live, and I would request all the members who are sitting here and who are the members of this to kindly participate and put in their activities, upload their activities. Having said that, Facebook Live, we have a LinkedIn, we will also have other activities like, of course, Twitter accounts, which are there. So these all can be used. So social platforms will be used, and it will be two-way communications as well. So that's where we are. Now, when I say all these things, it looks very interesting. And if I have to give you the demographic information about there are over 100 cancer hospitals with a dedicated urological specialty available. So you will have that. You have 900 or 1,000 corporate hospitals which are having urology departments. We will now slowly get into uro-oncology. So it's a big, big number you will have in years to come. So we will have no dearth of uro-oncologists in the country. So there should be no problem at all. Now, having said that, what are the challenges? And challenges are to attract non-clinical people into this. And that is what I mean by that. I mean, non-urological people like radiation oncologists and medical oncologists. And Dr. Patil, I would request you to kindly help the younger medical oncologists to participate this. I do not know whether they will be in a position to do 100% or so, but not necessarily. But even if you have some kind of things happening, would be a good idea. Also, pathologists. Yesterday, I was attending a workshop on pathology. I was flabbergasted. Pathology is now almost breathing down onto urological necks, that they are going to be the part of clinical work. And of course, technology is going to be adding to that. Lastly, I have to say, and that must go into the record, that we are not trying to balkanize the parent body of Urological Society of India. We are just trying to make a society where we will have all the multidisciplinary approaches to have a common platform, common language, and which will ultimately help in society, patients, and their progeny as well. With this remark, I would thank you all and for coming here and attending these things and making us proud. And we will certainly looking forward to more interactions as the days go by. Thank you very much.
Thank you very much, sir. Moving forward, before the vote of thanks, we would like to distribute mementos for all our dignitaries. I would request Ms. Samreen to kindly do the honors. Dr. Shekhar Patil, Organizing Chairman, SOGOCON. Dr. Raghunath S.K., Organizing Secretary, SOGOCON, Secretary, SOGO. Dr. Jagdish Kulkarni, President, SOGO. Dr. Sudhir Rawal, President-elect, SOGO. Dr. Ginil Kumar Puleri, Treasurer SOGO. Thank you very much. As acknowledgement and being grateful is one of the most important aspects, may I request Dr. Raghunath S.K., Organization Secretary of SOGOCON and Secretary of SOGO, to deliver his vote of thanks.
Thank you, Dr. Kinju. Before vote of thanks, I have an announcement. It's my pleasure to announce the best 3 abstracts. We received around close to 20 abstracts, out of which 4 judges, that is Dr. Indranil Banerjee, Dr. Robin Joshi from Nepal, Dr. Vikram Maya, medical oncologist, and Dr. Sai Vivek, Vikram Maya, radiation oncologist, and Dr. Sai Vivek, medical oncologist. These were the 4 judges, and they have announced 3 best abstracts. The first abstract is Dr. Ravi Tavori. He secured 86.25%. The next best abstract is Dr. Ravi Mohan, secured 82.5%, and Dr. Dirush Kannan, who secured 80%. So I request all these authors to present their abstracts tomorrow. The time is mentioned in the scientific program. So very good afternoon to everyone. Dignitaries on the dais, off the dais, senior faculty members, senior uro-oncologists, urologists, and specialists belong to various other fields. My teacher, Dr. Mahesh Desai, sir, and my family members. It's my proud privilege to thank SOGO committee members, Dr. J.N. Kulkarni, sir, Dr. Raval, sir, and my dear friend, Dr. Ginil Kumar, for giving a lot of support, who stood behind me to organize this event. I thank Dr. Shekhar Patil, organizing chairman. Without his support and guidance, probably this conference wouldn't have been possible. I also thank the scientific committee members. I must name them because they deserve to be mentioned here. Dr. Raghavan, Dr. Ganesh Bakshi, Dr. Ginil Kumar, Dr. Vinit Talwar, and Dr. Vedang Murthy, and lastly, Dr. Sanjay Edla. We are missing Dr. Sanjay Edla here. And special thanks to Dr. Ganesh. He was coordinating between all the international national faculty how we should conduct this program. Single-handedly, Dr. Ganesh managed all these things. And on the floor, when we were operating yesterday, Dr. Ganesh, Ginil, and Raghavan and other his team members managed this seamlessly. And I also thank all the 4 hospitals. They participated in our yesterday's live workshop, that is HCG Cancer Center, Manipal Hospital, Sri Shankara Cancer Hospital, and MS Ramaya Hospital, who actively participated during the workshop and supported throughout our live operating sessions. We showcased around 10 cases. A couple of them were robotic, laparoscopic, minimally invasive, and even MR fusion guided biopsies. They shown performed by 100% by Indian faculty. That is unique session yesterday. All the patients are doing well, and we thank all the patients and their family members for giving their consent to undergo live telecast. I also thank the conveners of pathology, radiation oncology, psycho-oncology for conducting their respective sessions. Yesterday's psycho-oncology session, I should mention, the hall was full. Thank you, Brunda Madam, for this. I also thank Mr. Anand and his team, AV. They are doing a wonderful job as always. And event management team and GHA. Anita Madam, Kiran Sir, Mr. Vignesh. You know, Vignesh is sitting behind. He was single-handedly coordinating with you all to get your tickets on time, to get your, cabs on time. And his team, the back-end team is very big. I must thank them for excellent coordination in bringing all the faculty seamlessly. I also thank the media for the support. I thank Hotel Conrad for providing this excellent venue. They went out of the, way to support them. You are witnessing this excellent venue in Bangalore here. I will be failing in my duties if I do not thank the delegates, faculty members, both international and national faculty, my department team members. There are 5 uro-oncologists are there in my department. I should mention them. Without their support, they used to relieve me. You go and manage the organization aspects. We will take care of that. So it's difficult to mention their name because of paucity of time. I must thank them, without whom it would not have been possible. Last but not the least, my parents who are here and my family members, without the support, and they bared with me from last couple of months to organize this. Thank you, and I thank you one and all. If I may be missing anybody, particularly the trade, there are, you see, all outside. Without their support, it's very, very difficult. That too, post-pandemic, so many conferences are happening. It's very difficult to mention each and every trade partners. They're all mentioned here. You can see. Because of paucity of time, I'm going to wind up. I thank everyone. Thank you one and all.
Thank you very much, sir. Ladies and gentlemen, it is now time for the national anthem. May I request the entire gathering to rise for the national anthem. Thank you. This concludes the inauguration program. We now proceed on to the first SOGO oration program. May I request President of SOGO, Dr. Jagdish Kulkarni, and Organizing Secretary of SOGOCON and Secretary of SOGO, Dr. Raghunath SK, to please stay in the dais for the oration program. I request dignitaries to kindly take back their seats. We will be proceeding with the first SOGO oration. May I now request Dr. Ginil Kumar, Treasurer of SOGO, to kindly escort Dr. V. Srinivas, who is the first orator of the SOGO oration, to the dais. May I now request Dr. Ganesh Bakshi, Council Member of SOGO, to kindly read the citation.
Thank you, Kinju. So good afternoon all. Dr. Varadachari Srinivas is a consultant urologic oncologist and robotic surgeon at PD Hinduja Hospital at Mumbai, where I am also currently attached. So sir has been born on the 3rd of November 1949. He has done his medical graduation at Christian Medical College, Vellore of the 1966 batch, being a postgraduate in MS from Bombay University and later MSc Medicine from Memorial University, Newfoundland, and then later on into MSKCC. Sir has acquired his urology further in Bombay Hospital and then again gone back in 80-82 to Canada, Newfoundland in Canada, continued with MSKCC and then returned to India. He has been a member of various organizations in India as the ASI Urology Society of India as well as American Urology Association, Fellow of American College of Surgeons, Dr. Srinivas has been bestowed with several awards, including the Pinna Menani Vijayawada Presentation Award, also the Gold Medal from West Zone Chapter of USI, as well as the Urology Society of India in 2007. He has presented more than 80 scientific papers in peer-reviewed journals and presented many others at national and international conferences. Also, he has written a couple of books. He has written a primer in uro-oncology long back, and of recently he has written Tale of Two Medics and Tale of Two Homes. We extend our hearty gratitude to Dr. Srinivas sir for his exemplary contribution in the field of uro-oncology and a clinician par excellence, a teacher for many young fellows over the past 5 decades. We acknowledge his contribution to treating uro-oncology patients and giving a gift of quality of life to many. Good afternoon, sir.
We now move on to the most awaited moment. Ladies and gentlemen, let us invite Dr. V. Srinivas to kindly come forward and deliver the SOGO oration.
Thank you. Is this oh, what about the light? Okay. Okay. Thank you. Thank you, ma'am. Mr. President, Secretary, ladies and gentlemen, at the outset, let me thank Dr. Jagdish Kulkarni and the organizers of this conference for having invited me to deliver this prestigious oration. I'm really honored and I feel humbled to be given this opportunity. So I was going to talk about my personal experience, personal perspective of uro-oncology over the last 5 decades. And I think this is more a Bombay-centric talk because I practiced in Bombay, did most of my work there. So I may not talk much about other cities because I'm not so familiar with what happened there. But anyway, I'll go ahead. When you go for a movie, the first thing that comes out on the screen is a disclaimer. Smoking is injurious to health. So my disclaimer is, I'm no more a regular uro-oncologist. I'm what you call a gentleman farmer. I spend more time in the Nilgiris, relaxing. So I come to you as a very reluctant speaker, very similar to this patient who's going for a prostate exam, very reluctant patient. But let me start this talk by talking about uro-oncology in India, the past, the present, and the future. I think the past is very important because that's what gives you what's happening at the present and what's going to happen in the future. So this is about uro-oncology in the past, or what urology was in the past in the 1970s. So this morning I just wanted to check, what is the age group of this audience? And I think many of you were still in school in the 70s. Some may not have been even born. So this may be something interesting for you to know what we did those days. So I'll just go through the different malignancies which we managed then. CA kidney, there was no ultrasound, no CT scan. IVP was what was done, and in some centers, if angiogram was available, that was done. So you could see the kidney tumor, and angiograms show that. There was no treatment for metastatic kidney cancer. The treatment was you do a nephrectomy, and you wait for this tumor the metastatic disease to sort of disappear by itself. And that was what went on. CA bladder, hematuria, investigation of choice was IVP. If it was a big tumor, okay, you could see it on the IVP. Small tumors, you had to do a cystoscopy. Cystoscopy, the vision was very impaired. The lenses were very poor. You could sort of see the tumor there. Resection was difficult. You may end up with a perforation. Tumors in the dome and tumors on the anterior wall, you had to really strain your neck because there was no television screen to do it on. So I asked my junior registrars the other day, if you went into a hospital in 1970s and saw 10 doctors standing in line, how would you diagnose who the urologist was? None of them knew. The answer was the guy would be wearing a cervical collar because they all had cervical spondylosis because of the resecting angle acrobatics they had to do. So in Bombay, if a patient had an invasive tumor of the bladder, the treatment of choice was radiation. This I'm talking about the 70s, or refer them to Tata Hospital, where Dr. Murli Kamath and Dr. Jagdish Kulkarni as his assistant were doing cystectomies. There was no radical cystectomy or radical surgery being done in any other hospital in Bombay or in Maharashtra or maybe even in Gujarat. Many were referred to Tata Hospital for these treatments. So this was the situation in the early 70s and mid 70s. CA prostate, there was no PSA those days. These patients were invariably found in the orthopedic ward, cord compression, fracture femur, operated for this. The chips came back, the biopsy came back as positive. The treatment then was orchidectomy. So much so, when a patient underwent a TURP for a benign disease, or if he went an open prostatectomy for a benign disease, something came back as positive showing adenocarcinoma, the treatment was orchidectomy. So in exams, CA prostate, treatment orchidectomy. That was the standard those days. CA penis, early disease had a good prognosis, but the Jackson staging system was used for classification. Stage 3, lymph node metastasis, poor prognosis, 10 to 20% 5-year survival. They were all lumped together. CA testis, the testicular mass was tackled by general surgeons. Metastatic disease was fatal. If you can recollect, cisplatinum was FDA approved only in 1978. So before that, there was really no chemotherapy and patients used to die. So what was the training we got those days? In the 70s, late 60s, 70s, MS general surgery was generally the key. General surgeons managed urology in most departments. MCH was there in a few centers, CMC, Madras Medical, AIMS, PGI. And there was no DNB in urology. So you can imagine there were just 1 or 2 MCH students coming out every year from these different centers. They had to fight tooth and nail to get a urology department set up when they went to another center. If they were in the Vellore or AIMS, they would have a urology center, but when they went to Bombay, there was no real urology center in the general hospitals. It was the general surgeons who were doing it. So what was the experience then as a trainee or when you were working there? So most of the consultants who were the general surgeon professors in the teaching hospitals in Bombay and Maharashtra were trained in UK. In UK those days, the coveted FRCS, everybody wanted an FRCS to come back to India and practice. And in UK in the 60s and 70s, the treatment for urological malignancies was radiation. And so these people, when they came back, they wouldn't do any radical surgery, radiation. Every patient would go for radiation. There were some doctors who went to USA. I think a large number went to USA to train. But USA was the land of milk and honey. Nobody came back. I don't know if it's still the land of milk and honey, but this is what it was those days. There were few exceptions who came back. Dr. Murli Kamath, he started the uro-oncology in Tata Hospital. In Bombay, Dr. Ajit Fatke and Madhav Kamath started TURPs. In Vellore, Professor H.S. Bhatt, Roger Barnes had come there, and then he went to Loma Linda University and came back and started the great department of urology there. And we had Dr. Bafna in Chandigarh, Dr. Gangwal, Tripathi, few of them in few places they started. So generally it was the general surgeons who were taking care of this. So as a trainee in Bombay, we had very limited exposure to radical surgery. All the radical surgery was being done in Tata Hospital. So when we were doing general surgery in a teaching hospital in Bombay, I remember we had one cystectomy because the general surgeons were doing urology. The operation went on for about 10 hours. A lot of blood, lot of feces, lot of urine, everything mixed on the pool. Nobody knew what was going on. Patient ultimately died. So then the registrar job from then on was any patient who came for a radical cystectomy, the night before operation, he would go and tell the patient, do you know what your operation is? Of course, the patient doesn't know. And then he'll start in his filmy Hindi language. Your urine is going to be removed from below. It's going to be put on your stomach. Your clothes are going to smell of urine. Nobody is going to come near you. Immediately, patient signs discharge against medical advice and disappears. So that was what we saw, radical cystectomy. Few cases, never saw them at all. So once I finished my urology training, so it was MS general surgery and 2-3 years urology in a hospital where you do pylorothotomies, ureterothotomies, and a little bit of TURs. You think you're a urologist, it's time to start practicing. I mean, that was the trend those days. Fortunately, I had a good mentor in Dr. Ajit Phadke. And he said subspecializations are going to come into India sooner or later, and you have to subspecialize. Urodynamics, pediatrics, transplant, oncology, these were the different things he taught. So I was keen to do uro-oncology, and he sort of pushed me on the direction. And the question was whether to go to UK or US. All of us were, had studied Bailey and Love for MS general surgery. So we were familiar with UK and FRCS, but not many of us had gone to US and come back, you see. But he did say that the only place to learn uro-oncology was US, because they were way ahead. There were 3 places where fellowships were available. Memorial Sloan Kettering Cancer Center, where Dr. Whitmore, the pioneer of uro-oncology, was the chairman. MD Anderson in Houston, and Roosevelt Park in Buffalo. So the plan was to go to MSKCC because Dr. Pramod Sogani was there from Indore. He was associate to Dr. Whitmore. He could get a job go there as an observer. The plan was to go and spend 2 months as an observer, observe these operations, come back and start uro-oncology in Bombay. But after I went there, I realized watching these pioneers operate on these complex cases, just watching it for 2 months is not going to help. You have to get your foot in the door. You've got to operate over there. You've got to learn what's going on. And the other aspect, which we were not really exposed to that much in Bombay while we were training, was paper presentation and publications. I think in the teaching hospitals like Vellore and all, it was way ahead. But this is something I saw there. And I felt that you got to stay on. So I approached Dr. Whitmore and asked him whether I'd get a chance to do a fellowship. So he very clearly said that we have only 4 fellowships available per year, and we have to give it to American students and American board certified. But if you're going to go back to India, I may give you a fellowship, provided you go back and practice or teach what you've learned over here. So that was a handshake contract. I think very different to the contracts many of you have signed with corporate hospitals nowadays, where there's 10 pages of fine print. And at the end of signing those 10 pages, some part of your genitalia is caught in a vice-like grip. Yeah. So after my 2 months became 6 years. So after 6 years, it was back to Pavilion, back to Bombay Hospital. Fortunately, by then, they had started the DNB program, and we had a lot of junior doctors, registrars working who were very keen to see these major surgeries being done, which they read about in the textbooks. So we were able to train a lot of residents. We also got them into the habit of presenting papers, publishing papers, and pushing it across. So this is some new aspect we got done. One of the problems of practicing uro-oncology in Bombay was the only place where uro-oncology surgery, advanced surgery was being done was at Tata Hospital, like I mentioned earlier. So to attract patients to a private setup was difficult, to a private hospital. So we had to tour the districts, give lectures, and tell them we could do the same sort of operation in a private setup and in a teaching hospital like Bombay Hospital rather than going only to Tata Hospital. So this was a problem we faced. Also went to different parts of the country to demonstrate surgery. I remember I went to Madras Medical GH, did a radical cystectomy, I think in 87, 88. And many years ago, many years later, I met one of the registrars who was there washed up, and he said, we have really taped your surgery and we have been following it now, and we have been doing the radical cystectomy. So this was very encouraging. But on the other flip side of the coin, I did go to do a radical prostatectomy several years later as a demonstration and ran into an intraoperative complication. So after that, I decided it's no point going elsewhere to demonstrate your surgery. You may as well ask the people to come to your center to see how you operate in your own familiar setup. I think this may be useful for you juniors. So once these things started going around, we said it was time to arrange a uro-oncology workshop. So we tried to, this was one of the first uro-oncology actual workshops, arranged in 1987. And the person we called was Dr. Willett Whitmore. I mean, we said, who else to come and take part in this conference? Dr. Willett Whitmore and Dr. Sogani came down from MSKCC. It was an excellent conference because there was a good interaction between the juniors, the seniors, and Dr. Whitmore, and he spent a few days here. And I think we enjoyed the conference. He also enjoyed the conference because, like any good American, he finally got to see the famous Holy Cow. That was the highlight of his visit. So now that we are on the topic of the cow and all that, I think let's move to the present era. I think it's very heartening now to see several uro-oncologists in different places. All the major hospitals in Bombay have a uro-oncologist or somebody who's really interested in uro-oncology, and this is great. Even the smaller towns. Now we have had uro-oncologists trained in Bombay and gone out. Dr. Kochikar is doing such a good job in Sangli. We have people in Pune, Dr. Kashyapi, and people have gone on to different places. So much so in the past, we used to get a lot of patients referred to Bombay for radical surgeries from the smaller towns, from other parts of Maharashtra, Gujarat, Rajasthan. That has all dried up now because we have good uro-oncologists in these distant places who have been trained, and I think that's very encouraging. They've also been presenting papers in international conferences, papers are being published in journals, and our consultants are being invited on panels as experts and on editorial boards. So things have really improved. And I think I should not forget to mention our Indian American colleagues, the urology group which has gone to the US. Many of them have become very seniors, they become chairmen, and they've been running programs, and they've been very helpful in getting our juniors to go across, learn some of the new techniques, giving them an opportunity to do a fellowship, come back to India to practice what they've learned over there, robotic surgery and other things. So this is something that really has helped us a lot. So what is the treatment now in the present era? I showed you what was there in the past. So now CA kidney, routine ultrasound, CT scans, you're picking up early small tumors, nephron sparing surgery has become routine, targeted therapy for metastatic disease is there, IVC thrombus is being tackled quite easily. CA bladder, hematuria, ultrasound is the first line, better endoscopic vision, you're able to resect the tumors well. I think Morales in 1976 in Canada wrote his first paper on BCG, and I think you're going to have a debate on that later on, but it's been helpful. Radical cystectomy has become standardized, stoma care has improved, chemotherapy, immunotherapy have made things much easier for us to manage bladder cancers. CA testis with the advent of serum markers, and like I said, chemotherapy in 1978, FDA approved cisplatinum. It's a dramatic change. Patients are all cured. Things have really changed in that. Now, one word about CA penis. As I mentioned earlier, the Jackson staging system was used. And when I went to Memorial, Dr. Whitmore did mention that there is something wrong in the staging system. All patients with lymph nodes do not have such a poor prognosis. The bulk of the work, the bulk of the cases of CA penis were in Asia and in South America. We didn't have so many cases in North America. So I had to pull out all the MSKCC work cases of CA penis for over 30 years. And we came out with one of the best papers at that time, or that penile cancer, minimal nodal disease has a good prognosis, whereas if there are multiple more nodes, then the prognosis is poor. This was one of the first papers on that. So while I presented this paper, there was a gentleman in the audience who asked a lot of questions. So at the lunchtime I spoke to him, and that was Dr. Cabanas. Many of you may have heard his name. Some of you may not know, from Paraguay. He was the person who first wrote about the sentinel lymph node biopsy for CA penis. So after that, we came back to India and got our juniors to do some work on sentinel lymph node biopsy and got a paper published out there. CA prostate. What has changed? PSA has dramatically changed everything on CA prostate. You're getting more and more localized disease. Patients are undergoing radical prostatectomies. And with robotic surgery, the complications or the morbidity has come down quite a bit. So everybody is doing robotic surgery these days. But I have a word of caution here on robotic surgery. I think what has happened is now many hospitals are getting a robot. And the hospital feels, if I do not have a robot, I'm going to lose patients. But the problem is, this is a very expensive device, and you've got to do a large number of cases to meet your economical goal. So what is happening is they're pushing their juniors who, like I said earlier, they've got on the contract in a vice-like grip to do more and more cases. I only hope it doesn't reach a stage where you do a robotic hydrocele also. So I think be careful of this. The second thing is, I think anybody doing robotic surgery should be trained in open surgery. Because if you run into a complication during your robotic surgery, you should be confident enough to open up and take care of the problem. I remember in 2011, the first robotic machine came to Bombay. And Dr. Jagdish Kulkarni and I used to work together because there was no senior robotic surgeon who was trained, who was there, so we would help each other out. And once while doing a nephrectomy, the clip on the vein slipped, and while the vein was cut, the blood pressure dropped from 120 to 60 in a matter of seconds or minutes. But since we were both confident in open surgery, we had no trouble opening up the patient, packing and taking care of it. But we had been sitting there waiting for somebody to come and do the open surgery. We would have lost the patient. So I think this is important for the younger generation to learn open surgery first before you move on to robotics. The third thing is, I find nowadays with this robotic machine in every hospital, there are many doctors who are experts in stones, experts in strictures, experts in various other things, suddenly becoming robotic so-called uro-oncologists. They do one nephrectomy and they call themselves robotic uro-oncologists. I think this trend is bad. It should be the real uro-oncologists who take up robotic surgery and do it, or you get a junior trained and who works with you and thinks like a uro-oncologist, because the thought process is very important and indications for surgery, etc. are very important. So now, having said this, let's look into the future. We finished the past, we present, and now into the future. So radical mastectomy has moved towards lumpectomy and radiation therapy. Similarly, in urology, radical surgery is now moving towards organs-preserving surgery. Recently, there was a paper in Lancet from MSKCC, MR-guided high-frequency ultrasound for localized prostate cancer. Targeted therapy, immunotherapy, chemotherapy, radiation, all these things have come into focus. So the cooperation between the subspecialties and a combination therapy is what's going to work in the future. And I must say, this conference is actually in the future. We are in the present, but you have gone into the future, and I must commend the organizers for thinking years ahead and taking a leap forward, because this is what is going to be, a multimodality treatment for all sorts of malignancies. So, having said that, let me leave you all with 2 or 3 small bits of advice. So, advice for the juniors. Those who are interested, please stick to uro-oncology. But keep abreast with the latest developments. Keep reading, keep attending conferences, keep publishing papers, because this is an excellent field to go in. But above all, practice ethical medicine. Remember, there's always a pot of gold at the end of the rainbow. Now for my advice to the seniors. Train the juniors to think uro-oncology. Explain to them the advantages of this career. Guide them in surgery. Surgery is something you cannot learn by reading textbooks. It's something you got to practice, something you got to be guided, something you learn. And help them in their career paths. Now, especially with our North American urologists and the people in England helping you, coming for these conferences, I think you could help the juniors to go abroad, spend a year or two, because spending some time abroad really opens your eyes, makes you a different person. Encourage them to publish papers. But I think one point is, think about retiring, not when people ask, why is this guy retiring, but when will this old codger go and retire? Remember, there's a life after retirement. Like I said, I'm a gentleman farmer. I can drink my beer, rain or shine, no problem at all. And if I'm not interested in writing any more textbooks in uro-oncology, I can go and write some novels and attend literature festivals. So there is something different you can do. And let me end with a small anecdote. There was this general surgeon in Bangalore. Since I'm in Bangalore, I may as well talk about him in Bangalore. At the age of 92, he was still actively operating. And he was a retired professor of surgery and retired from some civil hospital. So he had a large patient clientele coming to him. So he lived, I think, in Jayanagar maybe, 2-story house. Upstairs he used to live, downstairs was the operating theater. 7:30 in the morning, one day a young patient was taken in for a hernia, bilateral hernia repair. 7:45, doctor came down, operating started, everything. Relative sitting in the side room. Suddenly around 8:15, 8:20, a lot of commotion. Everybody running around, nurses, new ward boys, some more doctors, pandemonium going on. The family got a little worried, what's happening, what's happening? 15 minutes later, a nurse came running out, beating her chest, crying, Mar gaya, died, Mar gaya. So the the father of the son went running to the nurse and said, "Madam, my son walked into the operation theatre 20 minutes, 1 hour ago. How could he have died? What happened?" So the nurse just stared at him. "Arey, not the patient, doctor has died." So it's the doctor who died. So my friends, enjoy life while you can. Thank you very much.
Thank you very much, sir. Your presence amongst us is much valued and is highly appreciated. We now move forward to the felicitation program. I request Dr. Raghunath SK to kindly felicitate Dr. V. Srinivas. I request Dr. V. Srinivas to kindly take the seat forward in this stage. Thank you very much. We have now reached towards the end of the oration program. There is another session by Dr. Yuvaraja on prostate cancer before the lunch. We have wonderful sessions lined up today and tomorrow. Wishing all of you a very fruitful day ahead. Thank you for joining us.
It will be a pleasure and honor to invite Dr. Yuvaraja, senior to us in many ways, a fantastic robotic surgeon, uro-oncologist, has made a huge mark in what we all do today. He's going to give his talk on the role of LHRH antagonist in the management of metastatic prostate cancer.
Thank you, SOGOCON and Dr. Raghu for inviting me for this meeting.
So I think all of us are hungry now, including me. So I'll just try angry also, okay? He's angry also. Okay, slide. I'll just go through the role of antagonists because now we have so many molecules in treating metastatic prostate cancer, especially hormonal therapy. So we have been bombarded with newer molecules. This is one of the not a very new molecule, but we have been using since years together. So let us just go through the brief outline and where do we give this molecule for our patients. So just to have the introduction to these topics, we know that prostate cancer, especially metastatic prostate cancer, we are seeing more and more patients. However, in India, so now prostate cancer has moved up to the second position now, from 9th position, most common male cancer. So that means somewhere we are having more and more cases. We do not know the cause. We do not know whether we are identifying the old cases which are there in the pool or there is increased incidence. We don't know that. But still, so we are seeing more and more of CA prostate patients. And if you see this population of patients who are going to receive hormonal therapy, it starts from localized to metastatic castrate-resistant prostate cancer. In all spectrum, hormonal treatment makes the backbone of the treatment. So we can use it judiciously. So we know that this ADT is the mainstay in the treatment of metastatic hormone-sensitive prostate cancer. All of us are aware of the pathways, the reason why we use this. But what is the difference between the antagonist and the analogs? The reason is that, so the antagonist acts centrally at hypothalamus and blocks the GnRH. By doing so, the FSH-LH decreases significantly. Contrary to that, when we use GnRH, there will be increase in FSH-LH, at least in a pulsar-like manner. So, and there will be some surges in between when we are using these molecules. So that is what has been told. So initially, we may have increase in the level of testosterone, and especially when we start the treatment. How do we choose this ADT? There are many factors. We have so many molecules like agonist, antagonist, and in addition to that, we have the standard gold standard, that is archidectomy. Now, when we consider efficacy, we consider safety, we consider the ease of administration and the cost. So out of all these things, most important comes the cost, because once in metastatic prostate cancer, this is a lifelong treatment. So that is the reason we take the cost as an important factor. So how this antagonist fares over agonist? So there are so many studies. So one of them is, this is one of the first study where they compared degarelix with leuprolide and over a period of 1 month. And I am not going to the detail of that. The conclusion is that the degarelix provides rapid testosterone suppression. That means the day when you give it, within 1 to 2 days, you will get the testosterone level which is equal to castrate level. If you see the other graph, that is leupride, although it takes days together, but by the time it comes to castrate level, it makes almost a month. That means the idea is that if you require a rapid testosterone response or a PSA response, so better to go with an antagonist. Similarly, so we can correlate with the PSA control. So naturally, the PSA also goes down rapidly once you use this molecule. So when degarelix provides 29% higher PSA progression-free survival, so over a period of 1 year treatment. That means even in a longer period, you are going to get a response. The thing is, this one more study where this is called as a crossover study. That means the patients who are already on leupride, when they switch over to antagonist, so then there is a response still. That means even when there is a crossover, so there is a response. So our question is that we have a reverse crossover. In our patients, we start with antagonist and then we may use agonist because they are unable to afford, or it may be a long standing, so that then we don't have a study to support that, although we use it clinically. So what is the use of this molecule? So the main thing they always say is that cardiovascular risk. Our question is that whether this cardiovascular risk is significant in this population. So if you see here, cardiovascular assessment, this is one of the area we have seen in our patients. Many patients with a long-term ADT die of, so the main cause of death in prostate cancer metastatic is prostate cancer itself. The second most common cause is cardiovascular event. That we ignore it as clinicians because we don't give concentration Nowadays, because the patients are living longer and they are on ADT for a longer period of time, so there is a more chance that these people may develop cardiovascular side effects. That is an indirect phenomena because the patient develops hyperlipidemia, hypercholesteremia, obesity, glucose intolerance. Because of this, they develop cardiovascular side effects. So the NCCN guidelines, American Cancer Society guidelines, even American Cardiac Society, so they give a warning that you have to inform the patients if they are using for a long-term agonist, so they have to have a cardiac profile done and monitor the cardiac side effects as well as the lipid metabolism. So even there is a FDA safety announcement, all patients should be told, especially if the patient already has a pre-existing cardiac condition or a cerebrovascular condition, to be aware of this situation. So then, how does this antagonist is going to prevent cardiac side effects? All are theoretical. Not one reason, but the most common explanation for this is that there is an immediate suppression of FSH and LH, that is acute pituitary effect, and a chronic effect is a prolonged suppression of the same hormones, and there are no microsurges. That means there is something with the FSH which is going to be make a pivotal role in this situation. So, what is the relation between the FSH and adipogenesis? So, the stimulation of FSH receptor possibly alters the endothelial function, lipid metabolism and fat accumulation. This is a possibility. They have done a study with a mouse model, and you can see that, and they have found out the atherosclerotic plaque which is formed after antagonist is a very thin, small, when compared to a loop, right, it is a thick plaque, and it is a rapid development of a plaque in a mice. It's a very well controlled study, all the old study. But now we have some proof that FSH is one of the causative agent for increase in cardiovascular risk and altered lipid metabolism in these patients. So when the effect of ADT and FSH level, and Degarellis group was associated with a better control of FSH levels, and difference in serum FSH levels are reflected in the difference in testicular weight also in the mice group. So now, if you see this atherosclerotic plaque remains in mice treated with Degarellis as a small. It is a very small. That means it doesn't induce atherosclerosis in a fast level. So, if we see that even the FSH receptor are distributed equally even in metastatic cancer cells in so many sites, that means they can become activated even in the fat cells. They can become activated with the presence of FSH. That is the another theory. So, if the patient have a low FSH, have got significantly longer time to castrate resistance. So, this is an indirect evidence that is published in 2015. If you measure the FSH level, if it is less, that means these people are going to get a castrate resistant at a later level. So, faster and more sustained FSH control with Degarellis is seen with the use of this antagonist. This is a study. So then what is the safety profile? So in 2014, European Urology published, that means, so there is a decrease in the incidence of cardiovascular events or death in all patients when treated with Degarellis when compared with an agonist. So you can say that almost 50% risk reduction in cardiovascular event or a death rate. That means we have got some safety profile. The only thing is, as urologists, we should not neglect this patient. So there is something called as American Cancer Society scale available in the app. We always put BP, cholesterol level, and make out whether these people are going to get the cardiac event in future. Based on that, we give the patient an idea that this molecule is better than the agonist. So this is another a study where in which in 90 days there is a difference in hyperlipidemia and a cardiac therapy when compared to this one. So it is significantly different. And also, if the patient already has a cardiovascular or a stents inside or the surgery done or a history of TIA, so this patient did significantly better in these two studies when compared to using agonist. So NCCN guidelines, what does it say? So you give this adverse event complications to explain to the patients, and then make them understand that So by using antagonist, so there is a risk reduction in all these things. So what is the ABCD of patients whenever we see clinically? We always should be aware of this side effects and BP monitoring, cholesterol assessment, diet management, exercise. So all these things has to be managed as clinician because we are the primary caregivers to metastatic prostate cancer. So what is the other advantage? So another advantage clinically where we use if the patient has got a imminent obstruction to the urine, that is urinary obstruction, we use antagonist, and then we have a spinal compression is there, we do use antagonist, we don't wait for anything. And intermittent hormonal therapy, again it is coming up in a big way, especially when you are giving a hormone for a longer time. The advantage of using this molecule is that there is a rapid suppression of testosterone, and when you stop it, rapid increase in testosterone. That means there is no prolonged delay here. So there is a 2 trials going on with the intermittent therapy with degarelix. So what are the issues with that? Does it answer every question? No. As clinician, we should be really choosing this molecule for our patients. The problem is monthly dose. Our patients hardly agree with that. So generally what we do is in an initial phase where there is an extensive volume of disease, then we start with that, and then they have a choice either to undergo orchidectomy or going to the other molecule. Cost is an issue. Although the Indian generic medicine came, but none of them were successful, and we were also not happy with molecule because patients were not, we are not getting the same results. Injection site problem. This is one of the problem we always see. There is a lump with the injection site, pain, and the patient also develop fever for 1 or 2 days. These are the problem with antagonist. So to conclude, so usually we advise this molecule in a patient with a high burden of metastatic disease and a pre-existing cardiovascular disease, or they are going to high risk to get cardiovascular events in future, and in the patient with LUTS or outlet obstruction or even spinal cord compression. Thank you so much.
Thank you so much, sir. Any questions for sir? I think it's time to call it a day and join for lunch.
Thank you.
I request all of you to join for lunch. In view of the paucity of time, we are just going to shorten the lunch time. And 2 o'clock, the sessions will start one more time. Please, thanks.
We are going to start the post-lunch session. So in this session, we are starting with the localized bladder cancer. So with me, I have Prashant Kulkarni to convene the session, but Dr. T.P. Rajiv couldn't come. So I request Prashant Kulkarni also to join the chairpersons along with Dr. Giri GV and Dr. Nishchit. I invite Dr. Giri GV, Dr. Nishchit D'Souza to the stage for chairing the session and start the proceedings. Also, please, Prashant. I request the chairpersons to invite first two speakers and start the next session.
Good afternoon, everyone, and welcome to the post-lunch session. It has been an extraordinary COVID period where a lot of our bladder cancer patients who are undergoing BCG therapy had very difficult time in procuring the BCG as well as the adequate dosing. A lot of publications came up regarding the various dosages of BCG during this time. And our conveners have made a very excellent session on localized bladder cancer with a very interesting range of topics. To start the proceedings, the first topic is the days of intravesical BCG are numbered. We invite Dr. Vivek Venkatramani to present his topic, Yes, Newer Agents Are Better.
Can we have the slides? So good afternoon, everybody. Many thanks to the organizers for this opportunity. So we all know that BCG was introduced almost 50 years ago, and it is the intravesical treatment of choice for intermediate and high-risk NMIBC. So why exactly are we really debating this topic today? So this is basically the outline of the talk. There are some problems associated with the use of BCG. Do we have any viable alternatives? And can we predict the response to BCG? So we'll go through a bit of all this and see why I believe the days of BCG are now numbered. So the first major problem with BCG is its erratic supply. There is really no incentive for companies to manufacture this particular molecule, and especially in the West, this has caused a lot of delays in supply. Most people don't get a maintenance BCG, and the use of lower and lower doses has been studied so as to allow more BCG to be given to the same number of patients. And in fact, this is a letter from my hospital about 2 or 3 weeks ago. We got it in the email to all the urologists that Onco BCG has been discontinued. It's not available in the pharmacy, and this is the forwarded message from Cipla saying that we have discontinued this product. So, you know, even in India now, we are going to be facing more and more of this problem of BCG supply. Also, next thing I wanted to just highlight with a little bit of a case is a 54-year-old guy with a high-grade tumor, T1. He was advised hyperthermic chemotherapy somewhere else, but I convinced him, no, BCG is better, let's take BCG. He did his induction cycles pretty well, and after the first dose, fever, malaise, cough, and a miliary kind of picture on the chest X-ray, needing ATT, stopping of further treatment. You know, so BCG does have a lot of toxicity associated with it. about 30% do have systemic side effects, and there is a significant non-compliance with maintenance treatment. And I'm very happy that I get to say a lot of results from papers from members of SOGO, because this was one of the papers showing the toxicity of the Moscow strain, which showed almost 40% discontinued maintenance, 20% needing ATT, and 11% needing a cystectomy for the severe side effects of BCG. And in fact, probably the first thing anyone studies when we design a new molecule or bring it into the market is what is the dose. So do we even know the correct dose of a Moscow strain? And this editorial in the journal, Indian Journal of Urology, again by stalwarts from SOGO themselves, have shown that what we have probably been doing with the Moscow strain is really overdosing a lot of our patients, and we really may not be even knowing the accurate dose of this particular strain of BCG. Of course, we have all faced these problems of patients who fail to respond to BCG, who may progress and recur from the disease, and there are a number of problems associated with this, and these are the commonly used second-line options, and now a lot of them are being studied even in the first line. So what are some of these options? We'll go through that and whether they are viable for this particular treatment. So bladder cancer is the prototype for immunotherapy. We've been using BCG for close to 40 years, and aggressive tumors are associated with an overexpression of PD-L1, and these kind of receptors are more common in high-grade and post-BCG recurrences. So it's a natural target. And these are some of the current immunotherapy options which are being investigated for bladder cancer. Pembrolizumab has been approved for BCG unresponsive disease, and Adstiladrin, which is interferon alpha with an adenovirus vector, has been fast-tracked by the FDA for approval. So these are, and the others have shown good early benefit, but there is still further, further studies are required. And these are some of the trials in the BCG naive population, which is what we'll be focusing on subsequently as well. And a lot of immunotherapy options will probably come into the picture in the next few years. Intravesical treatment with pembrolizumab is again being studied, and that may also show something which is much easier to administer for us as urologists. We are not comfortable giving it IV and monitoring that, so this may something prove to be a little bit more of a game changer in the future. So the problems with alternatives in BCG naive disease is that BCG itself has a high initial response, and so we need to show non-inferiority at least, if not superiority for oncologic endpoints, and a better toxicity profile along with a good ease of administration. So I was lucky that this paper came out in the current edition of the Journal of Urology, just in the nick of time for my debate, and this could be the real game changer. Again, Dr. O'Donnell's group, who had shown intravesical GemCis doublet for BCG unresponsive disease, now studied in BCG naive population, 107 patients, and really a pretty phenomenal response of almost 82% relapse-free survival at 2 years and 100% cancer-specific survival, which is as good, if not better, than BCG itself. So that prompted, an editorial in the Journal of Urology saying that this may actually lead us to break the chain and get rid of the yoke of BCG that's around everybody's neck. And this will now be studied in a prospective randomized trial, intravesical BCG versus GEM-DOSI doublet, and I think that will also give us a better idea in the future. Hyperthermic chemotherapy is another thing that has been studied, which has some randomized data as well in the BCG naive population. It shows a pretty good response for HIVEC, and this is all from a Dutch group, which also shows a good long-term response in retrospective papers with epirubicin or mitomycin of almost 2-year relapse-free survival of 56% and 37% at 5 years. So these are just some of the other chemotherapeutic options which are in line in the second-line treatment. And the same way everything in prostate cancer moved from castrate-resistant disease to hormone-sensitive space, it's quite logical to think that these would also be effective if they are effective in an unresponsive state to a BCG naive state. So we will have a lot more options is what I feel in the next few years. Finally, just a bit on biomarkers. We had Dr. Conetti's talk. in the morning, we will be able to assess whether a patient may be able to respond to BCG or whether certain other treatments, intravesical or otherwise, are better in that particular situation. So once this is available, we have alternatives. I think there's really no question that the days of BCG will be numbered. So just to conclude, supply shortages are becoming a reality even in India. The Moscow strain is a different beast. It has significant toxicity. We don't even know the accurate dose. Biomarkers may allow us to predict the response to BCG and in fact use alternatives. GemDosi has now shown us a real good alternative, and HIVEC is also available here. And this suggests that we're going to, and with all the research going on, there's really likely to be new alternatives in the future. So thank you so much, and I'm pretty sure I've convinced you that the days of BCG are numbered. Thanks.
Thank you, Dr. Vivek. Crisp and wonderful presentation. Yes, we have got few newer agents apart from BCG, but still why BCG is best even date. I think Dr. Anand Raj will speak now. We have got 8 minutes time.
Yeah. Thanks to the organizers. Thanks for calling me here and allowing me to speak on something that is very close to what I really think. So are the days of intravesical BCG over? It's an unequivocal no. And I'm very thankful to Vivek for having, brought about a lot of points, but we'll go about, we'll look at them in a little more closer detail. So to be very honest, we are talking only about the BCG naive population here. We are not talking about the BCG recurrent or the failure or with prior BCG treatment. So there's an old adage, don't try to fix something that is completely not broken. BCG works and it works wonderfully well. So don't try to fix. Don't create a problem where it did not exist. BCG worked in the past, it works now, and is going to work in the future. The biggest example is, this letter was written by the daughter of Morales, who 60 years after her father invented BCG, got bladder cancer and was cured of it. So this letter, she's written it to Morales, sorry, she's the daughter of Guerin. So what better? The treatment of BCG naive tumors, what are the recommendations here? Look at AUA, look at ASCO, look at NCCN, intermediate risk, high risk, whatever risk stratification that you want. Everybody says it's BCG. This was in the past. The AUA 2022, the state of the art lecture. Look at the last line highlighted in red. Even in 2022, BCG still remains the treatment to beat. Look at the Potomac trial. We'll just come to that in a bit. What was the Potomac trial? They tried to compare BCG with durvalumab versus BCG, but the results they've kept on postponing the results at all. Why? Because the events are so low in the BCG trial, in the BCG arm, that the trial has not reached any significance at all. A recent paper published who says in the very high risk group receiving adequate BCG, the overall progression rate was 4%. The 5-year progression rate was 5.3%. I mean, it doesn't get better than this. Yes, duration of BCG is an issue. People want 3-year maintenance versus 1-year maintenance. We published our own data of 6-monthly maintenance. People keep talking about compliance. The withdrawal percentage in our own study was only 17%, a far cry from the 70% and the 60%. The treatment interruptions in our own series, the treatment interruptions rates were very, very, very low, even though the altered schedule of BCG was there. And even with these altered outcomes, altered schedules and altered doses, our series showed that the recurrence pattern, progression-free rates and were comparable with the best. So our progression rate is 4.2%. The treatment completion rate is 79% with BCG at a much abbreviated dose. It doesn't get better than this. The toxicity, this is a very old paper. Look at the lines again highlighted in red. This is published way back in the 80s. Overall toxicity were always mild, self-limited, and toxicity could often be easily compensated by a reduction in the dose or temporary interruption in treatment without compromising oncological outcomes. This is the adverse reaction to BCG in our own study. No side effect in 40% of the patients and class 1 side effects in 32% of the patients. I mean, what more would you want from an intravesical agent? And are the other agents better? I mean, there are very little problems with BCG which can easily be tackled. And again, thanks to Vivek for pointing out this PD-L1, PD-1 conundrum. So the important factor here is that the expression of PD-1, PD-L1 in bladder cancer itself is extremely low. the expression of PD-1 and the PD-L1 gets upregulated to a point that you can target it with the PD-L1, PD-1 inhibitors as pembrolizumab only in the presence of BCG. If the BCG is not given, then the upregulation does not happen. So none of these PD-1, PD-L1 will work if BCG is not given. What is the evidence? Look at all the trials that are currently running on immunotherapy. Look at the trial. Trial 1, pembrolizumab, it has an intravesical BCG arm. The sasanlimab has an intravesical BCG arm compared to BCG. The atezolizumab has an intravesical BCG compared to only BCG. The durvalumab arm has an intravesical BCG compared to only BCG. And the pembrolizumab also has an intravesical BCG arm compared to the novel agent there. So where is BCG gone? BCG is very much there in the picture. All that you are trying to do is improve on the results of BCG. That does not mean that BCG goes out of the window. And the phoenix, BCG again, rises from the ashes of phoenix, like a phoenix, to say that it is not gone, it is still very much here. People keep talking about targeted therapy, it's the next big thing, so on and so forth. But look at all these on the right side. Look at what are the endpoints. They are all phase 1 studies or phase 2 studies where there are no oncological outcomes. They are not even looking at oncological outcomes. They are looking at, change in urine quality, change in whether cell shedding is there or not, changes from baseline is there or not. I mean, these are the parameters being looked at. Not even relapse-free survival or overall survival is the far cry. So, based on this, are we going to say that BCG is out of the window? Again, certainly not. People keep talking about newer agents, genes, gene vectors and vaccines. So, anywhere in oncology and everywhere in oncology, these genes, vaccine and vector have always delivered, have always promised, but they very failed to deliver. There is not one malignancy today, including melanomas, where the clinical utility is there in a very big way. So also there in bladder cancer as well. The biggest, the gene vector vaccine that is, playing a very big role is the BC819, which is a recombinant DNA plasmid. But there also, it is a phase 2 trial. But even in that, there is the intravesical BCG, which is compared to the BC819 arm compared to only BCG. The ICAM1 targeted immunotherapeutic coccicidiovirus, which is under a clinical trial, again had BCG as one of the arms. The TY1A, which is again being touted as very promising, it's studied only in mouse models now. A single center trial is underway, and the VAX14 again, which is touted as something big, is only in the preclinical phase. So there is something called as the test of time. The BCG has stood the test of time in the past, in the present, and I hope in the future also. We should not jump into new drugs. They may look very exciting, but you should never forget, what happens to durvalumab, where it got accelerated approval and then had to be withdrawn. So a word of caution there. And with this, I rest my case again. And all the three things that Vivek had said, are there problems with BCG? Yes, there are some problems in terms of dosage or delivery, but nothing that can't be encountered. Certainly, there is nothing there on the horizon that compares with the oncological outcomes of BCG. Are there any viable alternatives? Unfortunately, as of now, there are no viable alternatives, and any viable alternatives that are there are trying to improve upon the results of BCG by having an intravesical BCG arm. So that's nothing is there. And I think I'm completely out of time. I have a minute left and I'm finishing with this. And is there anything to predict response in clinical utility today? No. BCG supply shortage, yes. So that doesn't mean that in today's BCG supply is not there, so you shift to something that is probably inferior. You try to improve on the supply and try to increase on it. So that's it. I rest my case with this. Thank you so much.
Excellent rebuttal, Dr. Anand Raja. I think being from Chennai, you are very close to the mother plant of production of BCG in
So
India.
one of the advantages that the second speaker has is that he has the first speaker, the talks that he can rebut. Unfortunately, that benefit is not there with the first speaker.
So we had an emotional connect too. Wonderful.
Thank you so much.
We'll go for the next talk. This is by Dr. Srivatsa. And this talk is on imaging in CA bladder. I think he's going to clear many doubts.
Yeah, very good afternoon, and at the outset I would like to thank the organizers and conveners for this opportunity. Imaging in bladder cancer it's slightly different from imaging other cancers because of certain specifics, like the outcome significantly differs if the stage changes even by slightest of things. So this is a challenge in itself. And we also know that the incidence of synchronous tumors in the entire of urothelial, upper urothelial tract can be as high as 5%. So panoramic evaluation of the entire urinary tract is also necessary. Local staging has conventionally relied heavily on the surgeon's TURBT, which is not amenable to objective documentation. And we all know that, I mean, this can be challenged, but we still know that TURBT typically tends to understage the localized disease by a considerable extent. Coming to CT, CT has remained the workhorse evaluation for localization, loco-regional staging, and detection of distant metastasis in bladder cancer. Historically, the radiologists have used the split bolus evaluation, which delivered low radiation and low contrast, because a substantial amount of patients also come with compromised renal function in this setting. But this has been now replaced by the better triple phase evaluation for a higher diagnostic yield. The best part about CT is that it has a very high negative predictive value, meaning to say that if the CT says things are normal, there's very less chance that, we are missing something very serious. CT can also differentiate reasonably advanced tumors better, but the sensitivity drops considerably when there is an active ongoing hematuria. Coming to the lymph nodal evaluation by CT, CT depends heavily on the size criteria. Initially, the significant size was mentioned as 10 mm. Now it has been reduced to 8 mm. And the recent papers say that with the 8 mm cutoff criteria, CT can be as sensitive as the other modalities of evaluation. The challenge with CT with lymph nodes is not the identification. It typically overstages nodal positivity, which happens mostly because of various other factors like post-TURBT inflammatory changes in the lymph nodes, so on and so forth. The other problem with lymph nodes and CT is that CT cannot evaluate micrometastasis, especially in nodes which are less than 8 mm. For distant metastasis, CT is still good. The pickup rate is more than 91% sensitive and about 83% specificity. These are the pitfalls of CT, mostly with interpretation errors. Post-treatment changes actually is a considerable challenge for the radiologist to identify a new lesion. Flat urothelial lesions can obviously not be picked up on CT. So to summarize, CT urography will continue to serve as the workhorse evaluation for diagnosing bladder cancer because of its ease of access, rapidity of screening, very minimal inter-observer variability, and high diagnostic yield. CT imaging, according to me, is best useful for locally in assessment of higher staged and larger tumors and concomitant screening of the upper tracts, loco-regional assessment of nodal disease, and evaluation of distant metastasis. These are few exploratory CT techniques that that have been evaluated. Virtual cystoscopy is not new. It was initially published in 1996. For some reason, it has not gained traction. It is dependent on creation of virtual reality imaging obtained via 3D volume rendering methods with rapid acquisition. There are several ways to do this. I will just skip this. It just suffice to say that it is easy to actually capture the images. It just requires one additional software to do virtual cystoscopy. Most of the CT scanners available in Metro CT Scan actually do virtual cystoscopy. It is minimally invasive. It enables the bladder to be totally visualized internally. It permits navigation to sites which cannot be accessed by conventional cystoscopic methods, but it cannot detect color changes in the mucosa and obviously can't take a biopsy. This is another interesting technology that I came across, CT texture analysis, which bases itself on the fundamental principle of entropy. The quantitative CT texture analysis has proved to have a significant role in discriminating the low-grade from the high-grade bladder cancers. Lower entropy signifies lower-grade bladder cancer and a higher entropy signifies higher-grade bladder cancer. MRI is the next. I think the superiority of MRI is, in bladder cancer staging is due to its increased soft tissue contrast resolution. There are several problems with MRI. The first challenge being that 3 Tesla definitely outscores 1.5 Tesla in diagnostic imaging. The availability of 3 Tesla MRI is not uniform in the country. Briefly coming to the components of multiparametric MRI, both the anatomic as well as the functional parts. Anatomic T2 weighted imaging shows the depth of the cancer or the tumor infiltration. The muscle invasive tumors have an interrupted SI line, which is suggestive that it could be more than T1. Diffusion weighted imaging depends on the cellular density of the tumor substance, and diffusion weighted imaging along with combination of T2 weighted imaging can actually discern T1 tumors from T2. This is the third component of multiparametric MRI, the dynamic contrast enhanced imaging. Again, this is based on the vascularity principle. So whenever the tumor is hypervascular, there is a higher propensity that the tumor is more infiltrative than not. So based on the multiparametric findings as well as the T2 weighted imaging, like BI-RADS and PI-RADS, BI-RADS was first reported in 2018. There are 5 BI-RADS score, 1, 2, 3, 4, 5, 3 being equivocal, 4 and 5 with a higher certainty of infiltration into the detrusor. But I can just tell you at this point in time, BI-RADS is not standardized. It has not withstood a large volume evaluation. So I can just say that this is probably investigative at present. I just skip this. The part about nodal staging in MRI is that it has limited accuracy with lot of false positive results. And these are the pitfalls. If there is air in bladder, then immediately after cystoscopy or catheterization, then the MRI can be wrong. If there is purulent urine, MRI typically overstages the problem. And even in patients who have received BCG, there is a problem with discerning T1 from T2 lesions in MRI. Coming to the last PET, it has definitely higher sensitivity and specificity, typically for evaluation of distant metastasis. PET does not contribute to accurate local staging of the disease or loco-regional staging of the disease. It is best suited for evaluation of distant metastasis. The PET is useful not only in distant metastasis, also to discern small lymph nodes with metabolic activity which could potentially have micrometastatic disease. PET is also the best tool to assess disease response to NACT, and especially in patients who have residual asymmetric bladder wall thickening and some small burnt out lymph nodes which are metabolically not active. These are last 2 slides. These are the advances with PET-CT, immunotherapy and PET-CT. What has now been shown in this paper is that if the uptake value on PET is higher than 20 SUV, there's a very high chance that these tumors are highly expressive for the PD-1 and PD-L1 markers, and therefore might have a positive impact in clinical treatment with immunotherapy. This probably will be the future PET MRI. Availability will be a challenge, interpretation will be a challenge. And last is the role of artificial intelligence and neural networking. It's all happening. So there might be a day when the AI and neural networking can, in combination with radiomics, tell us not only the histological type of the tumor, the depth of the tumor, the status of the lymph nodes, and response to therapy. Thank you very much.
Dr. Srivatsa, wonderful presentation. Actually, it is very shortage of time to cover all the investigation in one talk. Will you be able to tell which one investigation is required for which stage? Like one indication where CT, MRI or PET is required in CA bladder?
So typically, sir, ultrasound scan will do to diagnose the bladder tumor. But if you have to look at the local stage, there are certain indications where we may have to rule out based on imaging T1 from T2. That is where MRI will come into picture. For overall staging of the disease in a documented T2 disease where you are contemplating further treatment, I think PET scan outscores all other treatments. When the patient presents with hematuria, I think the first line of investigation should be CT urography.
Okay, thank you. This is open for discussion. Somebody is there too. If anybody has got doubts, I think he's cleared all the doubts. Thank you.
Thank you.
With this, we come to the big daddy of the conference, a debate on whether to preserve the bladder or not. We have stalwarts in their fields to discuss about this, and true to our SOGOCON, where we have oncosurgeons as well as radiation therapists and medical oncologists. This will be a wonderful debate. We invite Dr. Gagan to present his view on radical cystectomy for T2 bladder cancer.
Thank you very much. It's indeed an
Welcome,
honor.
Dr. Gagan, to Bangalore City.
Thank you so much. Thank you so much. And great to be here, and thank you for the opportunity. So let's jump straight into it. Firstly, I would like to confess that I don't have any relevant disclosures, but I'm a surgeon and I love to operate. Secondly, I think we have to be very clear about what kind of disease we are talking about. Muscle invasive bladder cancer is a deadly disease. 25% of all bladder cancers are diagnosed at this stage. About an equal percentage of bladder cancers which are non-muscle invasive will become muscle invasive in the course of their treatment in spite of BCG and in spite of alternatives to BCG. Once it becomes muscle invasive, the 5-year survival even after treatment is about 70% at best. And if it becomes T3, then you're talking about a 5-year survival which is about half of 70%. If it becomes metastatic, we are looking at a median survival of maybe about a year, give or take a couple of months. So there's absolutely no doubt about it that delay in treatment is one of the main important factors of mortality in muscle invasive bladder cancer. And this is proven very clearly by papers which suggest that if you wait for more than 10 weeks after a neoadjuvant chemotherapy dose to do a radical cystectomy in a muscle invasive bladder cancer, then that is associated with a worse survival as compared to doing it within 10 weeks after completion of neoadjuvant chemotherapy. So essentially what we are speaking is that we have one good shot at the MIBC. And if we tinker around, waste our time, do stuff which may not be very effective, then ultimately it's the patient who will pay the price, and that price will indeed be very, very dear. What about, this debate is about muscle invasive, or you can say T2 bladder cancer and multimodality or a trimodality therapy in that particular situation. But how do we know whether it's a T2 or a T3 disease? And my friend Srivatsa has spoken very beautifully about the various ways to stage muscle invasive bladder cancer. And one thing that is very clear is that no method is completely accurate. So you can't really make out from imaging whether it's actually a T2 disease with a 70% chance of cure or a T3 disease with about a 38% chance of long-term survival. And of course, he also mentioned about the VIRAD scoring, and he also mentioned in his own words that this should be considered experimental. And even if it is not, this scoring system, the VIRAD scoring, is essentially designed to distinguish between stage 1, which is T1 versus T2, or muscle invasive versus non-muscle invasive bladder cancer, and not really to distinguish between T2 and T3 disease, which is what we are talking about right now. So if you're going in with a trimodality therapy or a tetramodality therapy, essentially you are operating with your mask pulled right up to your eyes. We all understand that when we talk about trimodality therapy, it is limited in scope in the best of circumstances. So in T3, T4, node positive disease, I don't think even the most ardent supporters will call it the standard of care. Patients who have upper tract obstruction, decreased renal function, who are ineligible for cisplatin, multifocal large tumors, and even patients with significant voiding symptoms where radiation is going to ruin their quality of life are not patients in whom you can consider radiation therapy. And this is a large chunk, especially in a country like India. And this large chunk can just be set aside, and they can be told that surgery is the best treatment for you. I'm sure the NCCN guidelines will be quoted by my worthy opponent in the next talk, where there will be a talk about the fact that it's now a category 1 recommendation according to NCCN. Well, I agree, but not everybody agrees. For example, in the latest EAU guidelines, which were published in 2022, this year, it clearly states that even in T2 bladder cancer, it is an alternative and not the standard option, even in T2 N0 M0. And it should only be considered as an alternative in selected, well-informed, compliant patients in whom radical cystectomy is not an option or is not acceptable. 2022 European Association of Urology Guidelines. Even if you say that the retrospective studies from the National Cancer Database definitely can be biased because of selection bias, with the worst patients being taken up for radiation, with the best ones being taken up for radical cystectomy, which is partly true, it is clearly, even by using propensity match techniques, it has been found that the survival of radical cystectomy has been shown to be better as compared to the trimodality therapy. This is another study from the National Cancer Database involving literally thousands of patients, where with propensity score matching analysis, the survival of cystectomy has still been found to be better as compared to TMT. There will be question marks on these papers, I agree, but one thing can be sure, that survival with trimodality therapy will never be better than cystectomy. It can either be equal or it can be a little bit less. We don't really know about it, but there is an element of doubt. Now suppose we go ahead and do trimodality therapy. Again, according to a latest publication, in this publication about 20%, in others up to 30% of patients will actually require a salvage cystectomy. And once you end up doing a salvage cystectomy, the rate of complications is significantly higher, and especially in young fit patients who deserve to be given the best quality of life with an orthotopic neobladder, you end up doing an ileal conduit, because these patients become ineligible for a continent urinary diversion after a cystectomy. So surely, if there are so many disadvantages and problems with trimodality therapy as compared to cystectomy, it must definitely be cheaper. We must be saving on some money. But all of us know with the studies that it's actually significantly more expensive on a number of different fronts. And this new study actually says that within 1 year, in the West, you are going to be spending about $130,000 extra for a trimodality therapy as compared to a radical cystectomy, including all the issues with complications and readmissions and equipment and everything. And this cost difference just keeps on increasing. At 2 years, the cost difference is about $150,000, $160,000. At 5 years, it's almost double or a little less than that. So obviously, as long as the patient is alive with an intact bladder after a trimodality therapy, he or the healthcare system is spending a huge amount of money to ensure that the patient is being able to retain the bladder initially. So, to sum up everything and to put it all together, we have issues with complications of radiation therapy, which no matter how wonderful a radiation oncologist you are, you can't really avoid completely. You have issues with prolonged chemotherapy, which may be required in a trimodality therapy, a need for a close follow-up, an extremely compliant patient, repeated procedures, cystoscopies, biopsies, and all those things, the financial implications of the aforementioned issues, the possibility of a poorer survival, and then ultimately the last straw to break the camel's back is that in 30% of the cases, you're anyway going to remove the bladder after all this. With its attended higher complication rates, with its attending elimination of the option of an orthotopic neobladder, and possibility of a poorer survival in this situation as well. So, is trimodality therapy really better than radical cystectomy? I think you'll have to take that final call. Thank you very much.
Hello, Dr. Gagan. Dr. Gagan, I have got a question. I would like to know, in your experience, the one determinant factor which will dictate that patient after radical cystectomy have done well, one determinant factor which have not done well. In your practice, what is the important factor?
Probably the age and the comorbidities. Probably that would be because even if some complications develop, and none of us here can deny that radical cystectomy is associated with a high rate of complications, the younger, fitter patients are able to overcome them and bounce back, whereas the older patients are at greater risk.
Thank you.
Thank you.
The jury is not out, and to rebut that, we have a distinguished speaker, Dr. Ananya Chowdhury, to tell her view that it's not radical cystectomy that should be done.
About a week ago. It's looks like they can't find my presentation, so I'll start by introducing myself. I'm Ananya Chowdhury. I'm Professor of Clinical Oncology in Manchester, and I'm delighted to be here with you today. Thank you so much for inviting me. Okay. So I'm here to rebut the idea that radical cystectomy is the best treatment for muscle-invasive bladder cancer that's confined to the bladder. I've got to admit, I decided that this debate was actually about comparing surgery with radiotherapy, and I'm not here to try and convince you yet that it's the best treatment, but that it's actually a very good alternative treatment, an acceptable standard of care and suitable for many patients. And certainly what I think we should be practicing as a multidisciplinary specialty is allowing patients to know about the options, empowering them to make the right decision for them, given their various circumstances, and then providing the best treatment for the patient sitting in front of us. Found it? Excellent, thank you. I have to admit, a lot of my work has been done for me already this morning by both Professor Canetti and Professor Srivas, who have outlined the history of uro-oncology from the past to the present. And I was very pleased to see them both telling us that the role of bladder preservation for muscle-invasive bladder cancer is an accepted alternative for patients today. So these are my conflicts of interest. And I'm going to start with a look back in time. Many of these cancers, anal, head and neck, glioblastoma, and prostate, have come forwards from the past with organ preservation at their heart. Decades ago, all these 4 cancers were treated primarily with surgery, and now in this day and age, it is accepted that actually organ preservation and the better functionality that comes with it is the way that we should be proceeding. There is a myth that surgery is the gold standard treatment, and this is a myth that my opponent has told you all about today. But I do believe it is a myth, and I think the evidence is in my favour. Because when you look at outcomes, no matter which way you cut it, apart from if you look at overall survival, and we'll come to that shortly, outcomes with radical cystectomy are equivalent to that of trimodal therapy. Again, we keep being told that surgery is the gold standard, but whether you look at propensity scored matched analyses from high volume centres, whether you look at population outcomes based on epidemiology, or whether you look at the only meta-analysis that has been published to date, there is no difference in outcomes between trimodality treatment and surgery. The only time you see a difference in outcomes is when you look at overall survival as the endpoint, and that's because many of the patients who are treated with trimodality treatment right across the world are patients who are older and often unfit or unsuitable for surgery. So if you have an overall survival endpoint, then obviously those patients are going to die earlier than the patients being treated with surgery. All of that data that I've just shown you is a few years old. So what about now? What about the most up-to-date data that we can find? Well, if any of you followed GU ASCO this year, you will have seen a multi-institutional comparison of surgery versus trimodal therapy presented. And once again, even when you do a multi-institutional comparison, trimodality therapy is at least as good as surgery, and actually there may be some hints that it could even be better. And some of the data that we've seen even today for patterns of recurrence from patients treated here in India do suggest that there may be some advantages from trimodality treatment. And we can talk about why that is. Could it be that there's an immunogenic outcome from radiotherapy that allows better treatment of systemic disease? Who knows? But it's certainly intriguing. And as my opponent quite rightly said, I am going to refer to the NCCN guidelines, because the NCCN guidelines are the guidelines that many people follow outside of the USA, and they're often seen as the standard of care, even above guidelines from other organisations. And I was very pleased to see in the 2019 version that consolidation, trimodality treatment, and trimodality treatment as primary treatment is now seen as an acceptable alternative to cystectomy, and that even people should be giving neoadjuvant chemotherapy prior to trimodality treatment, which is something that we've been doing in the UK for many years. So why don't we do a randomised controlled trial to settle this question once and for all? Let's compare radical cystectomy with bladder preservation. Well, we tried to do that in the UK over 15 years ago now. We tried to do the SPARE trial. It randomised 1-to-1 cystectomy versus bladder preservation after neoadjuvant chemotherapy. And the reason why we tried to do it was because every time we stood up and talked about treatment for muscle-invasive bladder cancer, people told us it was retrospective data based on population databases, it was apples and oranges and limited by confounders. So we tried to do the study and it failed to accrue. And it failed to accrue for a number of different reasons, but interestingly, one of the most important reasons was when patients understood that we didn't know the answer to which was better, surgery or radiotherapy, patients actually didn't want to be randomised. They wanted to have their bladders preserved. But what SPARE has allowed us to do is it's allowed us to look at things like quality of life within a randomised control setting, something that we haven't been able to do with any other sort of data. And as you can see from all these quality of life graphs, actually surgery and radiotherapy are very, very comparable, apart from two things: body image and male sexual health. Patients who have bladder preservation feel more comfortable with their body image because basically externally nothing has changed, and as has been referred to already today, impotence and the ability for men to get an erection is more likely to be preserved with radiotherapy. And certainly that's still quite important even for some of my elderly patients. There is other data, apart from the SPARE trial, comparing quality of life within radical cystectomy and trimodality treatment. This is data from the US, and what you can see here is that actually a lot of things are very similar, apart from things like body image, appearance concerns, and impact on quality of life. But what I think is particularly important is providing patients feel that they're making an informed decision, then they are happy with the decision that they make. We've already talked about salvage cystectomy after bladder preservation, and as with any surgical technique, and to a certain extent radiation oncology as well, there is a lot to be gained from experience. And the more experience a department has or a group has, often the better are their outcomes. So if there's not a lot of bladder preservation going on, then I can totally appreciate that the salvage cystectomy outcomes are not going to be excellent. But this is data from the surgical team in Manchester, and what it showed that in the modern era, 5 to 10% of patients treated with trimodality treatment required cystectomy, nowhere near the third that some people report, and that the cancer-specific survival, remember, overall survival is often not a good endpoint, is similar to that of primary cystectomy. So certainly there's no doubt within our multidisciplinary team that patients get the choice. If they choose to have trimodality treatment, we preserve their bladders, and for the small number of patients who require cystectomy, they go to excellent surgical care and have robust outcomes. But could trimodality treatment actually be better than cystectomy? So this, I think, is actually where the debate will go in the future. The data that I've shown so far, a lot of it is data that has older radiation techniques and older surgical techniques behind it. It doesn't always have the optimal staging, as described by the previous speaker, when we're looking after patients. And so there are many areas in which we are improving year on year. But if we give more neoadjuvant chemotherapy, and there is data out there to show that neoadjuvant chemotherapy improves outcomes prior to bladder preservation as well as surgery. If we hypofractionate, so we give our radiotherapy in 4 weeks rather than 6.5 weeks, thereby reducing the overall treatment time. If we use excellent radiosensitizers, not just chemotherapy, which is not suitable for some patients, but also radiosensitizers like carbogen and nicotinamide, which can be used in low-resource settings and in patients who cannot tolerate chemotherapy. If we can use predictive biomarkers, whether they are based on molecular subtyping or based on immunohistochemistry, then I think we can do even better for our patients and improve the outcomes further than we do already. After all, I think there's no doubt that if you have a well-functioning bladder, then the best bladder to have is the one that you're born with. Thank you.
I think that was an excellent rebuttal, Dr. Ananya. Wonderful speak. Just a couple of questions. How do you counsel your patients in the NHS, in the tumor board, and how much of the patients are moving towards trimodal?
So, according to our national guidelines since 2015, all patients who are suitable for radical treatment must be seen by a surgeon who specialises in cystectomy and also by a clinical oncologist who specialises in bladder cancer. I guess one of the advantages that we have is that as a clinical oncologist, we can counsel the patients about systemic treatment as well as about radiation. So it doesn't mean that there has to be multiple appointments. One appointment with a surgeon and one appointment with a clinical oncologist suffices. And then the patients are often seen by a specialist nurse as to help them come to the right decision for them, which takes away some of the bias, I think, that both surgeons and non-surgeons like myself have.
Very nice. I think that's why you are so well prepared for this talk. You must be having a lot of such debates in your meetings too.
I have to admit, my surgeons have stopped trying to debate it with me. So going back to your other question.
Dr. Gagan, what do you say? The one word from him, yes.
Well, I'm just glad that I didn't know about her reputation before I went on the stage. And secondly, I would also like to say that I didn't delete your presentation. though if I knew that this is what you were going to do, then I would have probably done it.
So just to answer the other part of your question, in our practice, more than half the patients opt for bladder preservation, but we do have the largest bladder preservation practice in the UK.
The audience, please.
Yeah. So the question of the bladder preservation versus the... So when we go for a radical cystectomy for any disease which is beyond T2, we used to give neoadjuvant chemotherapy. So what I feel, and we discussed multiple times in the JC, that why not to give neoadjuvant chemotherapy and then try for bladder preservation? The result might be better. The OS advantage of a chemotherapy which is not in the bladder preservation alone. So if we plan NSCT followed by CTRT vis-a-vis only CTRT, that may do better, the survival might be better.
I agree with you completely. Actually, our standard of care is neoadjuvant chemotherapy followed by bladder preservation.
So even for a T2 N0 M0, you prefer to go for a NSCT followed by bladder preservation?
Yes, we do.
So our own data, 35% patients without bladder preservation. Even at TMH, Amit, when we looked recently, 35% of our patients before bladder preservation have had NACT. And those are the only ones who are actually fit.
Others are not fit for neoadjuvant chemo, so that's the one that we get. And I think the uptake for neoadjuvant is the same for surgery as well.
But there is as such no randomized trial which has shown the CTRT vis-a-vis NACT for...
No, I think there is not randomized data, but you mentioned that NACT helps.
Yes, so the randomized data that's out there comes from a very old trial called the MRC BA06 trial, which is a trial from the 1990s, which actually randomized patients to CMV chemotherapy versus no neoadjuvant chemotherapy followed by radical treatment. And that radical treatment could either be surgery or radiotherapy alone. And in that final analysis that showed the overall survival advantage of CMV chemotherapy of, I think it's about 6% at 10 years, there was almost equal proportions of patients having surgery and radiotherapy, and there was no interaction between the advantage of neoadjuvant chemotherapy and the radical treatment option. So we have used that data as a basis to recommend neoadjuvant chemo.
Just if I may add, our own data that is just going to be published soon, about 180 patients of trimodality, 30% having neoadjuvant. The only two factors that came out significant prognostically in a multivariable analysis are age and neoadjuvant chemotherapy. So that I think is very strong data from our own center that it is important to do NACT even before TMT. A good point.
Madam, basically we know that in CIS patients having CIS, trimodality may not be, it's a relative contraindication when you know that the CIS is existing upfront. And if you actually talk to a pathologist, at least in TMH in India, nearly 20% of the patients of cystectomy specimen would have extra finding of CIS which has not been reported in the earlier TOBT specimens. So that 20% patients which we are kind of missing out on the initial evaluation, if they get subject for TMT, how do we ensure that they are not the ones which should be getting TMT and going for cystectomy? So that's a small spectrum though, but a relevant spectrum.
So that's a really interesting question, and I think different MDTs do things differently. In our MDT, CIS is not a contraindication to trimodality treatment. Neither is hydronephrosis, neither is tumour size, neither is bladder neck or trigone or any of the other things that some people consider to be contraindications. We see those as poor prognostic factors and we counsel the patients accordingly.
Thank you, friends. Do you have okay, last one.
So you partly answered my question, but also is of consideration is the variant histology. We see that variant histology does not do as well both with chemotherapy and for that matter even surgery. So where do you position radiotherapy and outcomes in the, because close to about 40% of patients can have variant histology, either reported or unreported. So where do you place the outcomes with trimodality therapy in these patients?
So all of the UK studies that have been published have never excluded patients with variant histology. So all the data that you have seen that you know so well from UK studies includes variant histology. My personal opinion is that there are variant histologies that are effectively have a poor prognosis, whether those patients go on to have cystectomy or trimodality treatment. We will never have data, I don't think, that will allow us to be able to do anything other than subgroup analysis, which will never be conclusive, so we don't treat those patients any differently.
Okay. Thank you, madam. Wonderful presentation. Thanks a lot. Now we are going to have a talk on post-radical cystectomy complications and their management by Dr. Aditya.
At the outset, I'd like to thank the organizers of SOGO for giving me this topic. I'm speaking on complications, most of which Dr. Conetti and some of the earlier speakers have already mentioned. So we know that there's an increasing trend to use the robotic approach when we are doing a cystectomy. Also, we are aware that there's a long learning curve, especially for the reconstructive part. The extirpator part is relatively simple, but when you're doing the reconstruction, that's where problems arise. We spend a longer time when we do a pure robotic approach, but we obviously encounter less blood loss. So whenever data regarding complications is looked at, you need to see which center is reporting the complications, what is the volume of the work, and how many years since adoption of the robotic approach are they now reporting their data. Recent reviews on complications basically focus on these factors which we have seen since morning. Elderly persons, more complications. Obesity is associated with higher risk of complications, as is the Charlson Comorbidity Index. Smoking also bears a significant weightage, as also the use of neoadjuvant chemotherapy, which seems to predispose patients to develop more complications. So let's look at where we stand today. How have we mitigated our rate of complications? Does doing a diversion intracorporeally versus extracorporeally, does it make a difference? And well, simply doing a simpler operation, a conduit, does it help compared to a neobladder? So all the data which has been presented here is only of the last 2 years. The best source to know where we stand is this, a systematic review published last year. And the data is sobering. We have today approximately 35% of patients while in hospital landing up in some form of complications. Approximately 40% would land up in complications within a month. And by the third month, approximately 60% will have some complication. So this is really sobering data for us to keep in mind. Mortality also is not insignificant. We have about 2.4% early mortality, and it goes to almost 5% by the third month. Let's look at how successful we have been. Dr. Conetti already mentioned this. ERAS, yes, ERAS does help. It helps a lot. This is an article published by a multi-center group reporting retrospectively on 150 patients. In the early course of this study, no ERAS was used. February 18 onwards, until the time of publication in 19, they switched to ERAS. In the earlier phase of the study, most of the surgeries were open. Later, when they started doing ERAS and they had adopted the robot, most of their surgeries were robotic and with a neobladder. This is their final analysis. Complications, the early complications with and the late postoperative complications, you see the total number of complications when ERAS in the red bars have been depicted, the complications were less, whether you take the minor complications or the total complications. However, the number of major complications was not significantly different. And they attributed to the lesser complications in the ERAS group, specifically being identified on one factor, which is earlier recovery of ileus. Next, let us see whether doing a diversion purely intracorporeal versus doing it extracorporeal, does it really make a difference? This data already has been shown by Dr. Conetti. The IRCC published their data recently on this matter. Like others, they also were late starters in doing extracorporeal diversion to an intracorporeal diversion, and also the majority were conduits. So the data again tells you that complications actually were similar but a little more when you do an intracorporeal diversion. The hospital stay was a little longer. Number-wise, not very, very different, but still the number of complications were more when you do intracorporeally. The high-grade complication rates were less. They were similar. The IROC trial data has been presented. I'll just talk very briefly about their data. And this is an important study because this is the only prospective data that you have. So those patients who were dealt with robotically spent lesser time in hospital. They had better recovery in terms of quality of life and activity levels. And so the IROC trial also concludes that the robotic patients have a faster recovery, which squares off at about 3 months. So complications seem to be similar, whether you're doing your procedure intracorporeally or extracorporeally. Why not just use the simpler conduit? Is it better than doing a neobladder? Way back in 2003, Hartman showed us that a neobladder is better. What does our data tell us today? The comparison between these two methods in the early, intermediate, and late, none of them showed a difference. So whether you do a conduit or you do a neobladder, your complication rates seem to be similar. Let's look at some of our steps. How do we reduce complications? We deal with urotracheal strictures only because we have no time to deal with the rest. So strictures encountered approximately 10% of the patients in up to 2 years, and most are on the left side. Some of us have adopted the use of ICG. How effective has it been? So the USC group reported their data on 179 patients robotically done intracorporeal neobladder, and their results were dramatic. They could reduce, their data showed a 10% before ICG to nil by using the ICG. So I think that is very, very stimulating data for us to also use ICG. What about stents? Do stents actually prevent a complication or do they treat them? This is data from the MSKCC, which actually found that when use a stent, they found that the risk of complications is higher. So avoid using a stent or remove a stent actually seems to help. How do you manage strictures? Most of us would actually look at an endoscopic view approach. 60% will work. The balance have to be corrected. This is a major undertaking. Doing the anastomotic revision by open surgery is difficult. However, if you are experienced, you can get good results if you do it robotically. And Guru's group has presented the data showing equivalent results. So I'll conclude my talk here by saying that even today, complications after cystectomy are common. Thankfully, most are minor. Those complications are reducing by using ERAS. However, the data seems to suggest whether you do your procedure entirely intracorporeal or you do an extracorporeal, the complications remain the same. Increasingly, evidence tells us that doing a neobladder in favor of a conduit is probably safe. The complications are going to be similar. There are some ways like using ICG and reducing the usage of stents, which may help us to improve our results. And with this, I'd like to conclude my talk. Thank you.
Thank you, Dr. Pradhan. Now it is open for discussion.
Good review, Aditya. A couple of things. I think if you look at the entire story, even Badri also talked about it, we haven't been able to reduce the significant number of complications rate in cystectomy because we are talking in general across the data and multi-institutional studies and meta-analysis what you show. I think the trouble is it should be done in a high volume center. People talked about time and again that if you do less than 20 cystectomies in a year, probably one should not be doing a cystectomies. And probably that holds true for a minimally invasive surgery. So the important issue here is people who do less and less, I don't think they should be sort of doing the cystectomies every now and then. The other thing we are forgetting that apart from 30 to 40% of sort of complication rate, I disagree slightly in a conclusion. Majority of them are minor. I think some of them can be really sort of fatal and can be challenging situations. The another thing is a lot of patients come back for readmissions in first 3 to 6 weeks time, and our focus should be on that also because that also should be in perioperative complications. People come with dehydration, constipation, electrolyte imbalances, obstructions, and sepsis, stent-related problems. So overall, I think it's a major task, and people who do large volume, only people should be taking to avoid the complications.
Completely agree with your comments, sir.
Thank you. Thank you, Dr. Aditya Pradhan, for a wonderful talk. And we had a wonderful talk so far, which comprised intravesical BCG, imaging, the excellent debate, as well as the complications of a cystectomy. And with this theoretical knowledge, how do we apply it across various case scenarios? And we invite Dr. T.B. Yuvaraja to conduct this session on case discussion on localized bladder cancer. Yeah, we also request the panelists, Dr. Badrinath Koneti, Dr. Ganesh Bakshi, Dr. Harvinder Singh Pahwa, Dr. Francis James, Dr. Vijay Agarwal, and Dr. Jay Shah to come over to the dais. Thank you.
Good afternoon once again. I think there are a lot of deliberations about managing bladder cancer. So let us see how we do it in practical way. So how do we manage our patients? So we have eminent panel, Dr. Badrinath Koneti, who is an authority in bladder cancer, Dr. Ganesh Bakshi, Dr. Pahwa, Dr. James, and Dr. Vijay Agarwal. I think Jaisha is from US, he is not able to join. So now I request all the panelists, please be brief because time is limited. So let us try to cover as much as possible. And also I will request the delegates, you can ask pertinent questions, 1 or 2 questions. In between you can interrupt, but not to have any long questions or long opinions. So I'll just straight away go to the case scenario. So let us see how do we manage, and if there is anything left out, you can ask the question. 47-year-old gentleman complains of painless hematuria, 6 months, associated with clots. Performance score is good, non-smoker, diabetic. Diabetic from 3 years, it was actually 3 years duration. So with this history, how do we investigate this patient? Ganesh, what is the next investigation? You do it in your clinical practice. So let us go from simple to complicated for everyone.
Hello?
Yeah, go ahead.
So patient complains, presents with hematuria. We do the routine blood tests concerned CBC basic and do a sonography.
Fine. So generally we end up in doing a sonography which showed a small mass around 25 to 18 millimeter. So cauliflower-like growth. So prostate was normal in this patient. So what is the next investigation we do? Dr. Pua? The questions are all very simple, straightforward.
So as diagnosis is already confirmed, like there is a papillary growth with ultrasonography. So in this 25 by 18 growth, we can plan for cystoscopy along with TURBT, I think.
Fine.
Yeah.
So do you agree with this, Dr. Badrinath? So you want to do any cross-sectional imaging, or should we go ahead? This is the common scenario, especially even in the exams. So they will ask you whether you want to investigate further or you want to operate now.
I would say in the US, the practice would be to get some sort of imaging, such as a CT scan or CT urography, mostly to make sure there's nothing in the upper tracts. Also, before you do a TURBT, you can get a better assessment of wall invasion if you need to, and and if there's anything else, nodal enlargement, etc., you'll find out. Kidneys, I know it says it's normal here, but sometimes it's more sensitive. So that's
Okay. As an investigation for hematuria, so CT scan, I think nowadays we are doing for every patient as a protocol. So I don't know in the guidelines what is given, I don't remember, but I think for a practical point of view, we get CT scan for almost all patients who shows a mass on sonography or hematuria.
So point here I would like to add on, like as per NCCN guidelines, there's definitely routinely we should go for CT scan in each and every case. But at the same time, European guidelines says if like tumor is more than 3 centimeter, it looks like high grade. If it is in trigone area, so we have to scan upper tract also.
Correct. So there are,
so we can.
Earlier we had this issue, but nowadays I think the things are getting settled now. I think we are going towards cross-sectional imaging because this is not the only bladder. We have to look at even the upper tract. So everything we can have, and we know that ultrasound is not a good investigation for smaller tumor. We miss it. At least we have in our mind what we are going to do for this patient. I think it gives a lot of information. So even I believe to do CT scan before doing TURBT, not after doing TURBT. Fine. So what is the role of MRI? You can say, Dr. Francis, do you do MRI for these patients?
MRI is fairly useful to know the depth of infiltration, and definitely if large nodes are present, it will be picked up.
Yeah, I think Gagan is here. Gagan Prakash is not here. So they are doing a study in Tata to know whether the value of MRI in bladder cancer. So anybody can add up.
But Ganesh, you can give an opinion. So is it really going to change?
Right now we are not totally gone to MRI, although MRI as an imaging in bladder cancer is evolving. We already know about the versions of IRADs which will evolve probably. It's basically would be good probably to differentiate T1 and T2. The T3, T4, I think CT scan is as good, and I think very CT ineligible patients probably today will do MRI.
Okay, so now the reason is that every time radiologist and comes center, we are showing better picture with MRI. Please do MRI, please do MRI. So I think the final opinion from Dr. Badrinath. So in US, what is the trend? Are they doing regularly MRI scan or only in select patients?
No, in select patients, because practically, I don't know how I'm going to use the information from the MRI to make a different decision. Even if we show different depth of invasion, I don't think we're going to be convinced enough. The real answer is going to come from the TURBT or the pathology. So, and it's expensive. I mean, an MRI costs $5,000, so it's really hard to justify it in every case.
Fine, thank you. So I think it is not, but now I can show you in this case what happened. This is a real case. Urine cytology, what is the role of urine cytology, Ganesh?
I would do in all patients presenting with a bladder mass at the beginning, urine cytology.
Fine, agree with that, all the other panelists?
Roll high grade 86%, low grade chance is about 12 to 16% being positive.
Okay. When there is a mass already, is there any role of doing NMP22, Dr. Badrinath?
No, I don't think so.
No.
I don't.
Okay, fine. So now, again, we'll discuss little later, but I can tell because many patients who come with a bladder mass, so-called cancer, so they ask for PET CT. So usually we don't advise, is there any role of PET CT? And if it is so, which patient you will order PET CT, Ganesh?
These early patients, I
so
would
pardon me, medical oncologist, it will get a question.
I would not advise PET CT in these. I would always keep a term, advanced bladder cancers, I would do a PET CT if at all.
So in this case, it's not necessary, right?
Not necessary.
Okay, so now let us ask Dr. Badrinath Kote. In US, do they do PET CT for bladder cancer at all?
I do, but it's still very controversial, and certainly not at this stage. Typically, it's when you're decided if it's a muscle-invasive bladder cancer, when you're trying to see if you want to give neoadjuvant chemotherapy, assess response. But even there, it's very controversial.
Okay.
And we did a study which looked at the impact of getting PET CT versus just a CT scan for staging. About 17% of the time, you will change your decision based on the PET CT findings. Some people say that's not high enough to justify it in everybody.
Fine,
so
thank you. At least in muscle invasive and advanced cancer, we can get a PET CT done, because when we started doing this in everybody was telling that it is no need to have a PET CT for bladder cancer. Now the trend is changing for advanced cancer, so we are going towards the use of PET CT. In this case, patient underwent MR urogram size. If you see, it looks like blood-based in this film, although, and the VIRAD score was 5. So, can anybody radiologist here? I don't think so. So they said that it is involving the muscle, so it is VIRAD score 5. Do you agree, Ganesh?
Yeah, means VIRAD's 5 is like that. I don't know about this one.
But incidentally, I don't have the cystoscopy picture, but I can tell what next. Okay, anyhow, so I'll discuss that.
If the T2-weighted image shows the line which is concerned, supposed to be muscle, then they would report like that.
Fine. So what next, Dr. Pua?
So definitely in this case, cystoscopy followed by TURBT.
I think all of us know, so let us not go in any detail of cystoscopy TURBT. So just is that, to mention, so either we can do en bloc or fractionated. It depends on whatever the energy source you have. And the question of random biopsy, Ganesh?
There is no straightforward role of random biopsy today. In case of multiple tumors or visual CIS, which we sometimes would suspect, or then that cytology related problems.
Cytology
in
positive.
That the random biopsy comes later, but otherwise these are the few scenarios only. Otherwise it's given up.
Okay, so Dr. Badrinath, so do you do random biopsies?
In some cases, as you mentioned, cytology can still be falsely negative, very small, about 10% of the cases. But in most of these patients, routinely we use blue light cystoscopy. I don't have as much faith in narrowband imaging. But if blue light shows something, we'll certainly biopsy that. But typically you don't. About 7% of the time, you will find that information on random biopsy that will change or impact your management. So again, those are large, all the large studies from Europe, the EORTC trials, they all did random biopsies, and now they've gone away from that.
Yeah, so not for everyone, in select patient it is advised. So the question is more said than done. Examination under anesthesia, that is bimanual examination. Dr. S. Singh always asks for this one in the exam, right? Examination under anesthesia for these patients, with the candidates. So how many times do we do this?
Can I make a comment on this? I have a particular gripe with this exam under anesthesia.
Yeah.
With so much sophisticated imaging, with MRI and all PET scanning and everything, to say we are going back to the Stone Ages to do ballotment of the bladder to tell us extension is really quite sad. I think that we should stop asking that question in exams.
I think even
it's really ridiculous.
Time to progress now.
Yeah, I think we have progress. I think let us not do it unless, when I do it is like, if it is fixed to the lateral pelvic wall, just to know mobility after chemotherapy, whether it is operable or not. Only one situation I will be able to do it. Otherwise, routinely we don't do that. I think, many times the candidates, especially in the exam, being asked this question. So now, en bloc or a fragmented this thing, there is no difference. You can do both of them. And biopsy from the urethra, if there is a carcinoma in situ, 5 and 7 o'clock. These are all the guidelines. And so all this evidence is there. So monopolar TURBT, the patient did a monopolar TURBT. Actually, this patient did the TURBT outside and completely resected, deep muscle biopsy taken. And so with this patient, suppose if you are managing Dr. Pava, so do you do intravesical immediate mitomycin? And how do you decide that? Because many times the candidates ask me, many residents ask me, so sir, there is a large mass we have resected, looks like high grade on cystoscopy. What is that look which says that we should not do mitomycin?
So generally, as it is said, like I'm routinely using this mitomycin C, and it is said like in low grade, definitely we are going to take advantage of this. But as a routine practice, beforehand we can't find it out. So it is routine practice. I'm using.
So now,
this.
what do you feel is that any tumor which we resect, we are going to do intravesical?
If it is very obvious, very large mass, and we are planning for
so large mass, solid mass, or on cystoscopy, we think that it is infiltrating into the muscle. So then we can exclude this patient.
Exactly.
Am I right, Dr. Konetti? Yeah.
Do you not use gemcitabine here very much? I mean, we have switched almost completely to gemcitabine.
So you use gemcitabine?
Yeah, instead of mitomycin, because it has less toxicity, less irritation, and it's cheaper also, to be honest.
Okay, I think even mitomycin is cheaper here. So we use generally mitomycin. Anybody is using gemcitabine for immediate intravesical? Why not mitomycin? No, till now, is there any randomized trial to prove that mitomycin is? No.
Is that right? So otherwise, gemcitabine is preferred now.
Okay. Okay. Is there in the guideline? I don't know. Not yet. Okay, fine.
The guideline recommends gemcitabine as the first line therapy along with mitomycin.
No. That is for the 6-week installation. That is fine.
Immediate perioperative mitomycin and gemcitabine both are considered first line as per the NCCN guidelines. But that
anybody? Sir,
no, it's considered as first line. So that actually came up from the study where gemcitabine was compared with the normal saline.
Okay.
So there was no head-to-head trial between gemcitabine.
So you are comparing with gemcitabine with mitomycin.
Yes.
In NCCN, it is mentioned like mitomycin and gemcitabine, and gemcitabine is first line preferred. This has been added. What he's trying to point out.
Because of the lower toxicity, actually.
Yeah. But there is no head-on comparative trials.
So now see the histopathology of this patient. Low grade. Lamina propria free, muzzle is free, normal, there is no other variant like squamous differentiation or adenoid differentiation. So look at the MRI report and the biopsy report. So this is what happens when we do MRI and completely rely on MRI and start doing any surgery head. So this is, the biopsy report was twice reviewed and this is the final report. So now what you will do, Ganesh?
So we risk stratify basically. Lamina propria is negative, low grade, so 2.5 centimeters, so low risk. We have probably we have given IV intravenous intravesical mitomycin. So follow-up cystoscopy at 3 months.
Fine. So now we don't do anything, just follow up, right? Fine. So how do you risk stratify? I think everybody knows about it, but still you can give a opinion. How do you do it clinically by remembering everything, Dr. Badrinath? So generally when you risk stratify, so we don't look into the tables. Just give a overall view clinically how to make in front of patient.
Yeah, I mean obviously this patient is easy. It's low grade, single tumor, primary, so that has to be low risk. So if this was a recurrent, then I would immediately would go to intermediate risk, even if it's low grade. High grade would be intermediate risk. Then anything that has CIS or T1 would be automatically high risk. So it's usually if you have CIS, they go to high risk. If you have low grade, they're low risk. Anything else is in between.
Fine, thank you. So I think we have all the different risk groups: risk, intermediate risk, high risk, very high risk. I think now they are coming with a very high risk also. That includes more than all 3 risk factors: high grade lesion with carcinoma in situ. Most of the time, so it is associated with carcinoma in situ. So AU also has its own risk stratification. So different way of describing the same thing. So then we have a table which is an app available. You have to just put the feature. It will show you whether it is low risk or intermediate. We need not think about these things. So probability of progression or recurrence, you can say that we know that almost in a high risk, even if it is non-muscle invasive, almost 50% progress. And in a low risk, the incidence is very less. That means the patient has to be told that in future the patient may have progression, to be very careful for follow-up. So this is the stratification. Based on stratification, how the flow chart is there, that will come to little later. So now at 3 months cystoscopy of the same patient was normal, but at 6 months again the patient developed small 2 centimeter solid lesion. Histopathology after TURBT was low grade but T1. So what to do now, Ganesh?
So T1 changes.
So do you call this as a progression?
Recurrence.
No. Recurrence, so definitely. Progression from TA to T1.
To T1.
Fine.
So it goes to T1, that low grade. Again, I would check the pathology because 95% plus is associated with high grade. And
I agree with that. So now what he is saying is that if there is a T1 lesion, low grade is very rare. T1 lesions, majority of them are high grade. But that was generally when there was a low, intermediate and high grade. But now intermediate group, few are put it in high grade, few are put it in low grade. So that is the reason we are seeing even in low grade T1 lesion. Correct. So the intermediate risk has been divided into 2. Few of them have gone to the high grade, few of them gone to low. These intermediate group we see sometimes as low grade, but it is a T1 lesion. Yeah, okay, tell me now.
So again risk stratify. And then here if like you as high volume center has done this, otherwise if this kind of thing comes from outside, I'll do a re-TURBT.
Fine, okay.
And then,
I agree with that. Re-TURBT if it is from outside, but if you are, so now I'll ask Dr. Badrinath Koneti, how does he practice this? Suppose you are done a TURBT, you are sure that you have removed the tumor, it is a T1 lesion. Let us assume that this is a high grade, because this is clinically important. Do you really do a re-TURBT for all patients like this, or you will do it only for a patient who are referred from outside?
Good question. So I used to not do that, and then I started doing PDD or blue light cystoscopy in everybody, and then we were able to pick up a few patients in whom, even if we did the TOR, there still is residual tumor. So now, if we do blue light cystoscopy at the first TOR, and that shows that there's complete clearance, and there is no detrusor involvement, we typically don't. So I don't rely just on white light. If I'm doing blue light, then I'm more confident, and I don't need to do a re-TUR.
Suppose if we don't have blue light now, so we have only white light, what should we do?
I would recommend re-TUR. I mean, because you can also be wrong about 10% of the time at least, and so there's good data to support that.
Okay, thank you so much. So Ravi, what do you do?
So I think I will agree with Sir's point. Although we have a publication from our center where we looked into the need of reach stage TURBT in Indian setup, and it did find out that if the lesion is solitary, done from the same hospital, even if it is high grade, there was no extra. None of the patients actually were upgraded on a reach stage. So we actually concluded that there is no need. But subsequent to that, we have been seeing that most of the TURBTs are done by residents, and there are situations where they would have either not seen properly.
No,
or
no.
missed something.
Any second person doing it, I don't agree.
So
if you yourself have done, you are sure that you have removed all the tumor. Even a resident say that he has tumor, so we don't believe it. That's fine.
If it's a less than 3 centimeter, I would not do a restage. But if it's more than 3, definitely I would still do it, because even if you have done a complete TURBT early on, there won't be some areas which I might not have taken a deep biopsy. But less than 3 centimeters solitary lesion done by me, I will not do it.
Fine. So you can choose patient, but majority of times we are going to do it. Dr. Badrinath, you want to have a point?
One thing that you have to keep in mind is you're not doing the re-TUR only to find an upgrade, right? You want to make sure you've more completely resected everything, because all the data suggests that if you give BCG after re-TUR, the response rate is much better than in patients who have BCG without a re-TUR. So there is some benefit to maximal debulking of the tumor too.
So the point is very well taken. What he says is not only just to prove that muscle invasion is there or not there, not to miss any tumors, because BCG acts only in the absence of the tumor, not in the presence of tumor. So that is the reason. Yeah.
So in this particular case, does the depth of lamina invasion will also going to predict it? Because recently few papers have come where they are commenting that T1 should be further divided in TA1A and T1B. And second, the LVI. So if LVI is there and if it is T1B, then I think it is a more of an aggressive disease and we should treat it aggressively.
Agree with that.
But still our pathologists are not reporting like T1A.
We have to ask them. Yeah, because many times they don't do it, like what sometimes we also miss so many things. We have to tell them, ask them, then they will do it.
I think redo TURBT, I think we were emphasizing because the quality of TURBT was not so good. But now we realize what's its importance. People across the world are now saying don't overdo it. Because we can unnecessarily delay the intravesical treatment, because you do it and leave it for another 3 to 4 weeks time. We do not lose on time.
Yeah. Practical question, Ganesh, you are done TURBT. After how many days you are going to do TURBT?
I would advise 2 weeks to 3 weeks at least. 2 weeks.
Now what if I do it after 1 week?
It is okay. 1 week I would rather do if I sometimes know, or it's a very large tumor.
So we don't have one answer, but generally I just do it whenever it is comfortable. Sir, Dr. Badrinath.
I prefer to wait at least a couple of 2-3 weeks, because some of that inflammation will come down. Otherwise, you're falsely resecting things you think maybe
Thinking
tumor,
that,
but they
yeah,
will not be
okay,
tumor.
Fine, okay. So now it is a high grade, low grade T1 lesion. So Dr. Pava, so how do you treat this patient now?
So the options of there is BCG and this high wave, but I prefer for BCG.
BCG, okay.
After discussing with patient.
Fine, I think with BCG we had a good talk, whatever, the uses and complications, but just to have just an opinion, Ganesh, so which BCG, how much you use it, and what are the complications?
So we have been using now 80 milligrams.
So we have been
induction.
handicapped with only one strain. So I think we published
Moscow
that one.
strain,
Yeah.
80 milligrams per induction, 6 usually, at least 5 out of 6 of the inductions.
But still we are seeing lot of side effects
And
even
maintenance.
with BCG, because they can say that BCG don't have side effects, but I don't believe in that. So Dr. Badrinath,
So I have a small.
tell me.
I mean, since I have shifted from TMH, I give my own BCGs and I see very less side effects.
Yeah, correct. Fine, because it is related to the quality of your BCG
I am very honest with
installation.
you, because I know the side effect in TMH, I know the side effects now.
So what do you think is the cause of side effects in TMH and not with you?
So there are many causes, but I think if we do the procedure well, I think Dr. Anand Raja had the talk.
No,
of the
what I
debate
feel
part.
is that the only reason what I feel is that it is done it is not like the Tata they are going to do something wrong.
Yeah.
Residents, what they do, just because there are so many patients, when they put it, then they just push it. It is installation, not injection. So we have seen residents doing it, okay, just to finish it faster. So that is the main
I
cause
think
of-
sometimes you should also look at what actually is happening in each institute.
And a very gentle catheterization, non-traumatic, and putting insulation very in a low
I
pressure.
also have to add a point what he's saying. Definitely BCG is very well tolerated. Apart from other things like residents are doing, just like communication with patient, better motivated, better communicated, and all those things are also important. If they are having little bit symptoms, we are treating promptly. Those things are very important.
But in spite of that, the strain what we have, we cannot use 120. We are using 80 only. The standard was 120. We just, we are using 80 now. Still, we have quite a good number of side effects. Might be mild, moderate, but in private setting, it matters a lot. May not be in a government setting. Yeah, that everything is over. I think I don't have any question to them. Anyway, I'll go fast for the next page. Next, this one. This is all about. Yeah, so I'll just give one overall view. This patient, 63-year-old, so the patient had high-grade G3, but he didn't follow up, and finally he landed up with muscle invasive TCC. So otherwise, performance status was good, and I can show the CT scan here. This one, don't see this one. This one, so you can see thickened the entire wall here like this. So I want to ask Dr. Francis. So what you're going to do for this patient now? So PET CT didn't show anything. I wanted to ask PET CT question, but forget about it. Yeah.
I discussed about, this is muscle invasive now, so the treatment option is cystectomy versus the option of conservation treatment.
Let me put it directly. Are you comfortable giving radiation to this patient?
Yes.
Okay. So when you want to give, what is your protocol? Because the word trimodal and we get confused.
T2 and T3 I am comfortable, T4 I am not comfortable because I haven't seen enough data for T4. So any patient with T2, T3.
So you give chemotherapy along with concurrent chemo radiation or chemo followed by radiation?
Neoadjuvant chemotherapy followed by radiation with concurrent chemotherapy. And the concurrent chemotherapy will be cisplatin or other agents depending on the renal function.
Fine. So Dr. Agrawal.
So we would definitely do a PET CT in a muscle invasive bladder cancer, and we would recommend 4 cycles of cisplatin and gemcitabine as neoadjuvant.
But what is your experience on dose-dense MVAC?
Dose-dense MVAC, we don't use it so much. We tend to use more cisplatin gemcitabine because of ease of delivery.
So many times I remember this dose-dense MVAC, more often it is discussed than given. Like interleukin 2, we used to discuss more in RCC, but not given. Same thing here. So it is like saying, yeah.
Yuvraja sir, I just want to make a point. Ravi here.
Yeah, Ravi.
So our medical oncologists, they would always give dose and back. One of the reasons is tolerance is equivalent as per literature in our patients also. The other thing is the cycles are too short. So the patients are ready for a re-evaluation and surgery within 6 weeks. Because it's only a 15 days gap that they give DDM-VAC as compared to GC, which is a much longer schedule. So for 4 weeks or 6 weeks, they finish the entire chemotherapy.
So how many cycles of DD-VAC you give?
3 cycles.
3 cycles.
Yes.
The data from the trial was 6 cycles.
Sorry?
The data from the trial was for 6 cycles,
yes,
not
but,
for 3
but
cycles.
our medical...
So that might be an institutional preference. There's no data for that.
So because it takes the same time, according to me, MVAC takes the same time.
Both are 3 months.
Anyhow. So I will ask Dr. Badrinath. So this is been practiced in US commonly, high dose dense?
If our medical oncology, if the patient can tolerate it, they will always prefer dose dense MVAC.
I think we also should change now because we always write gemcite, cisplat and send.
Yeah, that's true. Otherwise they'll give gemcite.
Thank you so much. And suppose if you want to give radiation to this patient, so what is that radiation? How many sessions and what is the dose you give? And one more question. Do you give only to the bladder, tumor, whole bladder, pelvis? How do you plan?
We treat only the bladder. We don't treat the pelvic nodes. And usual, Professor Chowdhury has published the data that now that 4 weeks is better than the prolonged treatment. So treatment get finished in 4 weeks rather than 6.
What is the total dose you deliver?
55 in 20 fractions.
So do you target the tumor area with a higher dose?
The entire bladder is treated. But there are centers which do in 2 phases, partial treatment to the entire bladder and then a boost to the tumor. That is also being used by many centers. But personally, I give the entire bladder plus tumor, same dose. There are many uncertainties. If you want to boost one area, then there are some uncertainties. But there are selected patients in whom it is fine to give a boost, but not all patients are suitable for that.
Thank you. I think we had a good discussion. Last question to Dr. Badrinath Koneti. Sir, what is your experience of doing cystectomy after this trimodal therapy?
Especially, I think it can be done. I prefer to do it robotically because the plane behind the bladder and the prostate is much easier to see and dissect. I don't think it's any worse than any other cystectomy, to be honest. Sometimes it's easier because the radiation has stopped all the bleeding and you won't bleed as much. Of course, sometimes there's more scarring depending on how the radiation field was. And one thing I will say, there's at least some data suggesting that you can do neobladders even post chemoradiation, and some of these patients will retain their continence. So it's not a complete rule out to do.
How much a percentage of patients go for this trimodal therapy in your practice? Now, is it increasing nowadays?
It is increasing, but I would say still probably maybe 10%.
10% of your patients go for. Yeah, Ganesh, you want to have.
We just heard that comment that T2, N0, whatever M0, we won't radiate the lymph nodes. We always operate. We do know in bladder cancer that nodes positive is a disaster. So I need a discussion. I mean, we should touch that point and then go ahead. Why not treat the nodes? Vedang, we need that discussion, please.
So I believe that even the pelvic
Why
nodes are
should we not?
irradiated.
I mean, we have discussed so many times in TMH. And second thing, which Vedang can put light, we changed our own protocol at TMH with the follow-up protocol. Vedang, I would like you to speak.
Okay, so before Vedang speaks, I'll put my 2p's worth in. So historically, we do not treat the pelvic lymph nodes with radiotherapy. There is one randomized controlled trial showing that there's no improvement in outcomes. All the data that we've looked at so far is based on treating the bladder alone with radiotherapy. None of the data that we've discussed so far today includes treating the pelvic lymph nodes, so equivalent outcomes with radiotherapy is based on bladder-alone treatment. Probably the reason why we get just as good outcomes as surgeons who do a lymph node dissection is because with the volumes and the techniques that we use, the pelvic lymph nodes get a dose of radiotherapy that is likely to be adequate to treat microscopic metastatic disease. So remember, these are all radiologically N0 patients. We're not talking about N1, N2 patients. Vedang?
So radiologically, N1 you would treat?
Yes, no question.
But anyways, you could answer the same question.
So not treating the pelvic nodes is a very British thing. There is a randomized trial that has shown that it doesn't help. But we treat the pelvis because we use IMRT, we use adaptive treatment, and I think this incidental dose thing may not be, I mean, there is an incidental dose to the pelvic nodes, but that is probably less so with IMRT and tighter adaptive kind of treatment. So we treat it, the additional toxicity is hardly there with the bowel, with IMRT. The Americans, I think they also treat all the RTOG, Shipley, MGH, they treat the pelvic nodes. And that's two different philosophies.
And I think the results are good.
Yeah, treating pelvic nodes is common now, right? For all muscle invasive bladder cancer. Indian thing now.
We treat all our patients.
Yes. I think Yuvraj, in our publication, the results are good, right?
Yes. Yeah. So we treat the nodes
Yeah, because it's very difficult as a clinician or as a scientist. You can removal of nodes improve survival, but we not radiating it, because if I don't remove the node, everybody will,
So Yuvraj, I'll tell you why it may have started. Treating the nodes when you're using 3D conformal treatment, even till 7, 8, 10 years back, would have been very difficult. But we use
presently
IMRT.
you can do it. Yes. Very nice. Thank you so much. Thank all the panelists. I think thank you so much.
Can I have a small question if it's all right?
Jaldi puchna.
Sir, question to all the panelists here. It seems very counterintuitive to me that when you look at the role of VIRADs or MRI, everywhere in the body, including in rectal cancer, now there's, they don't treat total neoadjuvant therapy where they don't treat, even small residues in the rectum based on MR imaging. Those small half-centimeter ulcers, they're able to pick up and are able to tell whether it's disease or not, and that's become the standard of care. So why not the same in bladder cancers? I mean, Dr. Yuvraj said that, he's checked the pathology twice. I would be very happy to know whether he checked the radiology twice with the second radiologist.
Correct. So now we have done almost around 13, 14, because we have got 20 patients study going on, we read. So just if I say roughly, the the comparison between a HPR and this thing is not very much. The reason why we are saying is that as a clinician, without muscle invasion, especially for smaller tumors, it's difficult to do cystectomy. So that is the reason we don't rely on MRI based just muscle invasion. That is the main reason. Suppose if there is a multiple tumor, carcinoma in situ, we don't bother about muscle invasion, it is fine. But that is the reason, and in addition to that, CT scan gives the entire picture of the urinary tract, and which we are all well versed with that. In future it may come, but as of now I feel that it should be selective in nature.
I think Anand, it will evolve.
Because even in our own pilot study, 20 patients, there are 8 patients with VIRAT2 pathology, all of them were non-muscle invasive. 8 patients with VIRAT 4 and 5, all of them were muscle invasive.
This is the classical example which I showed. 2 MRI specialists saw. The study is, both of them are blinded. Both are watching. But still, because they are also learning, most probably. Thank you so much.
So now we go to the next session, that is the adrenal and the upper tract TCC. So may I invite the chairpersons, Dr. Girish Nelivigi, Dr. Satish CT, and Dr. Preetham Dev. So I would request the chairpersons to introduce the next speakers and take forward. Thank you.
Good afternoon, everyone. Dr. Ravi Mohan is going to speak on adrenocortical carcinoma, and he's already to the podium. Will you start,
thank you.
Dr. Ravi Mohan? Thank you.
Thank you, Dr. Girish, and chairpersons for this opportunity, and SOGO for this opportunity. Moving on to a rare tumors, we've been discussing more common ones. So it's a rare tumor, and my job is mostly theoretical, so it has been prepared by one of my residents. Nothing to disclose. It's a rare malignancy, the incidence is very less, but it has slight female preponderance than males, and it has a bimodal distribution that it occurs early in the childhood or in the 5th decade. There are no well-established risk factors for ACC. However, in pediatric patients, there might be 80% of patients might have a germline mutation detected, especially the TP53 mutation. And it is associated with some syndromes like Leif-Romani-Lynch syndrome, Menn syndrome. I just want you to remember this syndrome so that if you have a patient or with one of the syndrome, you need to screen them for adrenal. And that's where, otherwise there are no specific recommendations for screening, but if you have one of the syndromes, then you must screen for that. Now, this is a typical case scenario. 48-year-old male presents with a dull aching pain in the right upper abdomen, and which was related on oral medications, associated with fever, not associated with fever, vomiting, history of loss of weight, and there are no typical symptoms of hormonal excess. So let us go into the evaluation part, and then I'll discuss what happened in this patient. So this patient had a 15 centimeter palpable abdominal mass in the right hypochondrium, no free fluid. Now, majority of the tumors are actually functional, so it is essential that if you have a large adrenal mass, 40 to 60% might actually, adrenocortical carcinomas might be functional. So about 1/3 might be non-functional, or they may present with tumor effect, but about 40 to 60% would be functional. So in the order of their occurrence, hypercortisolism is more common than virilization, than hyperandrogenism and feminization. So you need to screen for all these hormones. Now, if you have a functional tumor and a large mass, believe me, majority of the times it is more likely to be malignant tumor. So just beware for that. Now for hormonal test, for cortisol, a morning serum plasma cortisol level and an overnight dexamethasone suppression. These are two standard tests which are very sensitive, and they are elevated because this will be ACTH independent. So you need to do both the tests to prove that it is ACTH independent and cortisol is elevated. Now for androgens, you can test a myriad of androgen precursors like free testosterone, DHEAs, androstenedione, and these patients will also have symptoms associated with androgen excess. Now for hyperaldosteronism, these would be the patients who would be difficult to detect. They might just present with hypokalemia and hypertension, and you need to get a plasma aldosterone level and plasma renin activity, and the ratios are well defined that when you should suspect hyperaldosteronism. With respect to imaging, CT and MRI are the most common imagings which are very sensitive and the imaging of choice. Both imaging approach about 100% sensitivity for diagnosing adenocortical carcinomas. They can also detect adenocortical adenoma from carcinoma, and there are various criteria. Typically, adenomas are less than 4 centimeters, they are lipid rich and homogeneous with smooth margins. And ACCs are large heterogeneous region with irregular margins and calcifications. Then on CT, even in unenhanced, they might actually, the density might be 10 Hounsfield, which is higher when you start suspecting that it could be ACC. And they have a slow washout or an absolute washout percentage of less than 60%. That is the one when you think that you're dealing with the ACC. Now this is what the patient had, that 15 centimeter mass. You have a large mass with heterogeneous, large variegated lesion about 18 to 30 centimeters with the kidneys typically are pushed downwards and laterally, and there are no distant metastases. As the size increases, the likelihood of malignancy increases. There is no set role of functional imaging, so FDG PET probably doesn't have a role except in patients where you are suspecting it's a metastatic disease, or you've done or there's a recurrence following a radical surgery. That is when you tend to do PET scan, because then you might pick up some lesions. Percutaneous biopsy, again, it is very unreliable. Only you may consider it when you're suspecting a metastatic adrenal lesion with other lesions elsewhere. Otherwise it is not recommended. And pheochromocytoma must be ruled out before doing any biopsy. So TNM staging, essentially, it's again a very simple staging. It's essentially relying on a size of the lesion. The size less than 5 or more than 5, or local invasion or invading into other organs. That is where it is qualified as T1 to T4. So this is one disease which is surgical. So there is not much role of radiochemo, or not very well defined role of radiochemo as of now. Whenever feasible, surgery is the goal. And my next speaker is going to discuss in detail about how to do an adrenal surgery, so I'll skip that part. But more importantly, what is essential is that you must do a good preoperative hormonal workup and control them, because these are the ones that would determine the postoperative outcome. So if patient has any of the symptoms or any of the levels are elevated, they should be well controlled with proper medications before you go on to take for surgery. So we'll skip that. Surgery, remember that whenever possible, try to remove everything. Don't even an en bloc resection with multi-organ is better than leaving a disease inside. Even when removing of vena cava thrombus is recommended. So that is what surgery is, that you should do as almost everything what you can remove, because it is predominantly a surgical disease as of now. Role of lymph node is a little controversial, although there is a literature which says that patients where lymph nodes are removed, they have a better overall survival than when it was not removed. But then majority of the times people tend to not to do lymphadenectomy unless they are enlarged, and the templates are also not well defined. But then when you're removing a large mass and you see nodes, don't just leave it, just remove the lymph nodes also. This is what was done. This is the bed at the end of the resection. You can see the kidney nicely preserved and shifted down, and the entire mass was removed. And there's a cut section of the mass, bosselated, variegated appearance. So this turned out to be adenocortical carcinoma. Now, if you have a patient who has if you feel that you left some, or there's a recurrence, or tumor spillage is considered one of the important factors for recurrence. So if the patient is a good operative candidate and patient has a recurrence, go in and remove it again, because as I said, it's still a surgical disease to manage. For patients who are not a candidate for surgery are the ones who should be considered for radiotherapy. There is some emerging role of neoadjuvant chemotherapy. There's data from University of Texas where they've shown that with neoadjuvant chemotherapy for those lesions which are large enough or borderline for resectable tumors, they had when NAC was given, they had a 28 months of disease-free survival as compared to 13 months when no neoadjuvant chemotherapy. And the chemotherapy given was mitotan and etoposide cisplatin-based chemotherapy.
if you have not given neoadjuvant chemotherapy, adjuvant therapy is where one can give, especially when there is evidence of multiple lesions here and there, or there is evidence of recurrence and patient is not fit for any surgical resection. And adjuvant therapy is again based on mitoten based therapy. This trial of ADIVU, which first randomized trial on adjuvant mitoten in adenocortical carcinoma, it shows that adjuvant mitoten does not benefit significantly. Adjuvant therapy using mitoten does not have much significant improvement in overall survival in such group of patients. Again, as I said, adjuvant radiotherapy only for local control. It is considered when the patient is not a surgical candidate for resection. And as for all adenocortical carcinomas, surveillance is recommended that every 3 months for first 2 to 3 years, and then 6 monthly for the next 5 years after surgery. Now, there are certain things that if the patient has steroid profile should be carefully evaluated before an unexpected rise in serum levels, because if it's a functional tumor and patient has the recurrence, these are the ones they would actually, the recurrence would, the hormonal elevation would precede the recurrence. So it is good that if the patient has a functional tumor, you remove it, you can actually monitor the hormonal levels, and that would give you a clue with respect to recurrence. And again, as I said, if the recurrence is manageable for surgical resection, go ahead and remove the surgery. For stage 4 adrenal cortical carcinoma, where it is difficult to remove all of it, mitoten remains the only treatment option in such treatment. Here you might do a PET scan based on, and you can actually do a tagged PET scan with mitoten and treat them with mitoten. There is a randomized trial which shows mitoten with a combination chemotherapy may improve progression-free survival. However, it does not change any overall survival. And hormonal symptoms, especially in such situations of stage 4, needs to be controlled with specific medications, especially the steroidogenic effects can be controlled by ketoconazole, or mineralocorticoid effects can be nullified by spironolactone. So, thank you very much.
Sir, I have a doubt. For the endocrine evaluation, you yourself do it, or you send to an endocrinologist in your institute?
So for screening, we do it ourselves, but if the screen shows anything which is abnormal, we tend to send to endocrinologist for further evaluations. So for a serum cortisol, our resident would send. If it is more than 800, we would send it to endocrinologist for further evaluation.
And then, for example, a mass of 6 centimeter with a small node. So whether you prefer doing an biopsy for that or directly go for surgery? Because in the era of neoadjuvant, and you also have the lymph nodectomy to be done or not to be done.
So if it is a loco-regional, anything loco-regional should be removed. You should go ahead and remove the tumor along with the loco-regional disease as much as possible. If it is a metastatic thing, that was the one where I said that you should add with chemotherapy. We don't do a biopsy beforehand. Yeah.
Very excellent talk. The series of adrenals we had for last 25 years has taught a lot of great lessons. First thing, we do see this sort of entity in pediatric age group also. There are two peaks. One is sort of between 10 to 20, and we also see something on a 6th and 7th decade. We have about 4 patients, pediatric patients, and I thought they are not going to have good survival. But just good R0 is extremely important in these situations. Do that and they do very well without any adjuvant treatment. The one other point I wanted to make it, I think the pathologist has to be really, really good in differentiating between the benign and malignant tumors. Though we have different criteria, both for FEO and adenocortical carcinomas, first thing they're rare. They don't get to see these sort of specimens every now and then. So even grossing, understanding, and reporting is important because you want to tell what the horoscope is going to be, what's additional treatment. And the last point, because R0 is important, if the tumors are larger, and especially on the left-hand side, when they are actually sitting in the renal hilum, do not hesitate to do a nephrectomy along with that. That guarantees you R0 with lymph node dissection because that's the only standard of care you can offer as of today. So a few points.
Agree. I thank you for those comments, and I perfectly agree that you should not shy away from doing a nephrectomy as and when required. In fact, even involving a multidisciplinary team like a GI surgeon, if there is an involvement of bowel or a splenectomy, yes, I agree perfectly. Thank you. Thank you.
we'll call up our next speaker, Dr. Arvind Ganapalli. He's a professor of urology, like Marriott. He is going to speak about the approach of adrenal surgery. Over to you, sir.
Thank you very much, chairpersons. Thank you very much, the organizers, for this opportunity and allowing me on this stage. Over the next 10 minutes, I'll be talking something on the different approaches for adrenal surgery. So these will be the 4 points I'll be touching on. First, I'll talk very shortly on the surgical anatomy. I'll be talking on the choice of approach, technicalities, and take-home messages. I'll not be talking on the pre-op preparation of the patient in any of the adrenal surgeries. A bit of a very generic basic slide, but we need to understand the basic differences in between the takeoff of the right adrenal vein and the takeoff of the left adrenal vein. The right adrenal vein arises more on the medial side of the adrenal gland, and it is, say, a very short stubby vein. While the left adrenal vein is quite long, actually it is a friend of the surgeon. And one more important point I would like to point out is this particular left inferior phrenic vein. We will discuss it when we go to the technicalities. But a few more important points also are there as far as the arterial anatomy is concerned, is that the arterial anatomy is actually a mesh of arteries coming from 3 different sources. The left phrenic artery, the left superior adrenal branches, and some even coming from the aorta. This is the left intercommunicating vein I was talking about. As far as the location of the adrenal gland goes, we can see very pertinently here that actually a part of the adrenal goes behind the IVC. Very important when we are going to go with a transperitoneal approach rather than a retroperitoneal. That's why retroperitoneal approach on the right side is easier than the transperitoneal approach. While on the left hand side, you can see that it is more of a triangular gland, very snugly hugging the kidney. So straightway going to the approach. Broadly speaking, it is laparoscopic transperitoneal or retroperitoneal, laparoscopic standard or single port, robotic transperitoneal retroperitoneal, or robotic standard or single port. To put it very plainly, the choice of the approach would plainly depend on the surgeon preference, and the surgeon preference will depend on how he has got trained, and of course on the size of the lesion and the pathology of the lesion. So first we go to the open approach, and then with the help of an example, I would like to let you know that when to do it, how to do it, and where to do it. So just to give an example, this is a 64 years old male presented somewhere else with perspiration, headache, flank pain, investigated, found to be having a large adrenal mass. He underwent an open adrenectomy on the right hand side. This was the histopathology report. Of course, this was done somewhere else, and they have reported it as an pheochromocytoma, 11 centimeter tumor. The PAS score also they have reported as 11, more than 3 mitosis plus 2, and everything more in favor of an pheochromocytoma. Just within a month, the patient presented back with this big tumor, and as you can see here that it's completely pushing the kidney down. This would be an indication wherein we will definitely do an nephrectomy, as discussed by Ravi Mohan, that we will be doing a nephrectomy as well as an adrenectomy. But as we are going to talk about the approaches, the most amenable approach, most of the lesions are amenable through a flank incision or sometimes even an thoracoabdominal lesion. But large masses, bilateral masses having extension into the intra-aortocaval area, or large masses on the right hand side might also be dealt using an chevron incision, maybe even bilateral chevron. We go into the technicalities of the laparoscopy or robotic approach, both trans as well as retro. As I was saying that the approach can be chosen in this way. The surgeon preference, that is the key point. We would prefer to have an larger tumors to go more transperitoneal. Right side we would like to prefer to go more retroperitoneal because the vein would be just there in front of you, and the axis of the vein is critical whenever you are going to do an adrenectomy. And it again depends on what is the expertise and the training available. What is the role of imaging in deciding the approach? It gives us some idea about the feasibility. It decides the approach, retro or trans. It helps in planning the ports and mapping the vascular anatomy. Like here we can see an additional adrenal artery, or in this case you can see that the tumor is not just a tumor, but it's actually invading into the renal vein as well. So a number of information and idea can be gained through proper imaging. We'll go into the technicalities. As far as the ports are concerned, the port should be directed more towards the area of interest, and the obtuse angle should be directed more towards the adrenal gland. The first step, obviously, when we are going to do a transperitoneal approach would be the reflection of the colon. And it is very important here, as we can see here, is that the splenorenal ligament, as they say, very typically they have described it, that it should be taken down in such a way that the spleen and kidney should open up like a book. Because unless the spleen and the kidney are opened up like a book, you will not be able to gain an access to the adrenal vein. So both the leaves of the splenorenal ligament should be completely taken down so that the spleen falls apart and it's not seen in the view. So that would be the first step, regardless of whether we are going to do it on the right hand side or on the left hand side. Now, how do we tackle the adrenal vein on the left hand side? Identify the renal vein first. As you can see here, that this is the renal vein, and you can see the adrenal vein. And if one appreciates here that one can see this vein that is going down, and that is very critical, because in a laparoscopic approach that would be the intercommunicating vein, and if that bleeds, it becomes very difficult to control the vein as well. The extent to which the adrenal vein should be dissected is that you have to see the inferior phrenic vein or the intercommunicating vein, and good amount of cuff of tissue should remain on the renal vein side. So as you can see that good amount of cuff of tissue is seen here, and some amount of tissue is also seen on the renal vein side. But when it comes to the, after this, one more critical step would be separating the adrenal gland from the kidney. An important point that we have to remember here is that one has to remember that sometimes the branches of the renal artery also hug the adrenal gland and go over the upper pole of the kidney. So if you are too close to the kidney, there is a chance that you might actually enter into one of the branches of the renal artery. So that is one thing that one has to remember. A basic generic difference on the right hand side is that it is critical that you have an plane in between the IVC and the adrenal gland, because unless you find this plane, you are not going to find the SWAS. So the landmarks here are the IVC. You can see the SWAS over here behind, and then you can see that the adrenal vein, which is very stubby, and directly the takeoff is from the IVC, can be easily seen. Obviously, it has to be secured very precisely with the help of hemlock clips preferably, and keeping a good amount of cuff of the hemlock clips on the IVC side. We go to the technicalities of the retroperitoneal approach. As they always say that the port should be directed in such a way that the port should be, the angle of the obtuse angle should be directed towards the area of interest. And as the mnemonic goes that you have to always identify the big boys. So the big boys here would be the IVC, the SWAS. So always the IVC and SWAS should be horizontal. And the obvious advantage of the retroperitoneal approach is that you can very well see the renal artery here, the renal vein is here, and actually the structures are not coming in your way of dissection of the adrenal vein. So in fact, the procedure becomes extremely easy when you are going to go retroperitoneal, particularly on the right hand side, because the renal vein is exactly in front of you. One more important advantage of having an retroperitoneal approach is you can see that the hemlock clip appliers, they have got a very good angulation so that you can apply and secure the adrenal vein in a very nice way. So definitely retroperitoneal approach, and that too robotically, has got an advantage on the right hand side. So this would be the important take home message: identify the SWAS, great vessels and the renal vein. As far as large renal masses goes, you can see this meta-analysis which shows that actually if the size of the mass goes beyond 5 centimeters, the complication rate as well as the conversion rate both go on significantly very higher, to the tune of 25% and 30%. So one has to be very careful with the minimally invasive approach in these masses. So I conclude my talk with these few important points to remember while approaching adrenals with minimally invasive approach. One has to remember to aggressively mobilize the spleen and liver on either side. It is preferred to secure the vein first. Remember, the adrenal vein lies transverse in relation to the IVC, and it is medial to the adrenal gland. The choice of the approach depends on the size of the lesion, pathology, location, and the surgeon's experience and the expertise. And the identification of the key structures is very important regardless of whichever approach you take. So thank you very much for this opportunity, and I would like to take any questions if there are any.
Any question from audience?
Excellent presentation, Arvind. Very beautiful videos and you very good demonstration. I just wanted to add two small points. One is that whenever you are taking an adrenal tumor, normally whenever you are taking any tumor, you tend to separate the tissues from the tumor. But in an adrenal, it is preferable to separate the vessel from the tissue which is towards the tumor. What I want to say is that you should not stay very close to the tumor, rather you should stay close to the great vessels, whatever great vessel, whether it is IVC or aorta or renal vein or renal artery, because these tumors would always be very close to major vessels. And you have to separate the tissues from the major vessels rather than, and the second issue that I wanted to discuss regarding was intra-aortic cable. In intra-aortic cable, you should, I have done only open, I have not done any laparoscopic. One has to do a complete cattle brush, take the entire bowel out and put it on the chest wall. Only then one will get a good exposure of the aorta and the IVC.
Yes, thank you very much, sir. That point was very important. It's a very important point, sir. Thank you.
Just to take that point forward, I think it is always said that you dissect out the body from the pheochromocytoma, meaning that you don't want to touch the tumor. So exactly the same principle, though the vessels are very short. What I've started seeing a lot recently when the patients are coming for a second opinion, done laparoscopically or robotically, I think that these adrenal tumors and tissue is very friable. I'm sure everybody would agree. And unfortunately, those who should not have recurred, they have recurred because of the friability. So maybe, I think there is nothing wrong in the technique. You just have to sort of make sure it remains in the cocoon and just come in a proper bag without getting spillage. The spillage from a cystic tumor is different. Yeah. But the adrenal masses are very soft and friable. Yes. And that's why we are seeing a lot of local recurrences in the minimally invasive surgery.
That is exactly what happened in the case that I just showed, that it came back in 1 month.
Arvind, here.
Yes.
Here.
Yes.
So
yes.
you showed us that you were clipping the right renal vein. It's often very short. And unfortunately on the tumor side, you sometimes have very, very little length left. And then there's the slippage of the clip and troublesome bleeding. So how happy or comfortable are you to use an energy source here vis-a-vis 1 or 2 clips?
So here, as you just pointed out, that very small amount of stump was remaining on the adrenal tumor side. And actually the whole adrenal gland had got dissected. There was almost nothing left over this vas. So that's the reason why we decided to use an energy source. Otherwise, as far as possible, we would like to use a clip.
Arvind, 5 years ago, I had a patient. I was not sure whether this is adrenal or a renal tumor, but IVC thrombus. I do not know whether you had a chance to, we reported that. And in that case, absolutely we didn't know how to start. Because our diagnosis was renal tumor was not, renal vein was seen very well, but IVC, adrenal vein had a thrombus going into the IVCs into the, so did you have any chance to?
No, we don't have any experience on that.
Adrenal, that's one.
Yeah, thank you very much.
Thank you.
We'll go on to the next speaker.
We'll call up Dr. Vijay Agarwal, Senior Medical Oncologist from Asta CMI. He is going to speak about current position of neo-urgent and adjuvant chemotherapy and IO in upper tract urothelial cancer.
Thank you everybody for having me here. We're just going to cover over the next 10 minutes a very important, a rare topic, which is the role of chemotherapy in upper tract urinary malignancies. So we know from bladder cancer, and as with all rare disease, we extrapolate from common ones, and we know that the bladder cancer is more common than upper tract urinary cancer. And we know that in bladder cancer, neoadjuvant chemotherapy improves absolute survival, okay, in order of about 5 to 7%. And I think it kind of twists the curve, so to speak. But upper tract urinary cancer has its own challenges. It's a rare population, okay, so less than 10% of them are upper tract urinary cancer. Biopsy is difficult, and when we get it, the tissue is very, very scant. We've heard all morning today that it is difficult to stage, and upstaging and downstaging is quite common in upper tract urinary cancer once a nephroureterectomy has been done. Post-operatively, we expect the GFR to decline because the kidney is out and patients have had nephrectomy. And when we look at most of the data in literature, There is modest data on the role of neoadjuvant chemotherapy and possibly some data on adjuvant chemotherapy, and we'll go through them. So we know that post-operatively, cisplatin eligibility declines from 58% to 15% when we take a GFR of 60% as a cutoff for cisplatin eligibility. Now, this is one of the very early studies done by the MD Anderson group looking at the role of neoadjuvant chemotherapy in urothelial carcinoma. So it was a retrospective case analysis. So it was not a randomized trial, it was a retrospective case analysis. So patients who received neoadjuvant chemotherapy between 2004 and 2008, about 31 patients were compared to historical matched cohort of about 81%. And essentially they showed that neoadjuvant patients who received neoadjuvant chemotherapy improved both disease-free survival as well as overall survival, both in favor of those patients who received neoadjuvant chemotherapy. Coming to adjuvant chemotherapy, there has historically been a lot of controversy on the role of adjuvant chemotherapy in upper tract urothelial malignancy, and this was the data from the European groups looking at a retrospective analysis of over 1,500 patients from 15 centers across Europe, looking at patients with T2 to T4 upper tract urothelial malignancies post-radical nephrectomy, and did not show any difference in overall survival. So hazard ratio was 1.26, so no benefit with adjuvant chemotherapy. However, the Americans had a completely opposing view. So this was the National Cancer Database data from 2004 to 2012 of over 3,500 patients, and they essentially looked at T3, T4 disease and node-positive disease, upper tract urothelial malignancies, and essentially showed a benefit in overall survival for those patients who received adjuvant chemotherapy with a hazard ratio of 0.77. And the benefit was seen across all subgroup, irrespective of age, gender, stage, or surgical margins. So we have two opposing viewpoints. One from Europe did not show any benefit, and one from US showing a benefit, but both were retrospective case analysis. So the British people decided to sort this out. So they did a phase 3 randomized controlled trial across 71 hospitals in the UK, which was called the POUT study design. So all patients with invasive upper tract urothelial malignancies, T2 to T4 or any N was included in this study. Patients had to have had en-bloc radical nephrectomy. So at that point in time, lymph node dissection was not mandatory in the UK. So some patients had it and some patients didn't. And maybe that may be a confounding factor. I think we just have to leave it for the audience to decide. The initial idea was to take in 345 patients, but they closed the study at 260 patients because, as we all know, it is a rare disease and difficult to recruit into a phase 3 trial. So patients went on to receive post-surgery either platinum-based chemotherapy, which is gemcitabine and cisplatin if GFR was more than 50, and carboplatin if GFR was less than 50 and more than 30, versus surveillance only. The primary endpoint, this despite being an adjuvant study, the primary endpoint was disease-free survival, as the group felt that if overall survival was the primary endpoint, it would take forever to get the end results. So when you look at the disease-free survival, the disease-free survival was significantly in favor of those patients who received adjuvant chemotherapy, and an excellent hazard ratio of 0.45. The median survival was not reached in those patients who received adjuvant chemotherapy versus 28.9 months in those patients who were under surveillance only. And we saw a similar trend in metastasis-free survival. The three estimate absolute difference was 17% in the metastasis-free survival and 25% in disease-free survival. And the benefit was seen across all subgroups, irrespective of the nodal status, the type of chemotherapy received, the surgical margins, and the T state. So all groups benefited from getting adjuvant chemotherapy. When we look at the overall survival, like I said, the study was closed prematurely, so it's very, very difficult to read into overall survival. However, numerically, the data was in favor of those patients who received adjuvant chemotherapy, and I think with longer follow-up, we might get more clarity on the overall survival. Subsequently, a meta-analysis which included the POUT study was published in 2021 in European Urology. They looked at a total of 45 studies, and neoadjuvantly included 16 studies, and adjuvant chemotherapy included 29 studies. And they essentially showed that in those studies that had neoadjuvant chemotherapy, the benefit was seen in favor of those patients who received chemotherapy in overall survival as well as cancer-specific survival. And when you look at the hazard ratios looking at you're looking at 0.44 for overall survival and 0.38 for cancer-specific survival. So excellent hazard ratios. When you look at the studies that included adjuvant chemotherapy, I think there were a lot more studies looking at adjuvant chemotherapy, and essentially, again, the cancer-specific survival, the disease-free survival was both in favor of those patients who received adjuvant chemotherapy, and so was the overall survival. Overall survival hazard ratio of 0.77, again in favor of those patients or those studies who gave adjuvant chemotherapy versus who did not. And essentially, the authors summarized that neoadjuvant chemotherapy for upper tract urothelial cancer confers a favorable overall survival and cancer-specific survival as opposed to surveillance alone, and adjuvant chemotherapy confers an overall survival, cancer-specific survival, as well as disease-free survival benefit in those patients who received adjuvant chemotherapy. Now, so current evidence appears stronger for adjuvant chemotherapy purely because more number of trials were there, and more importantly, the POUT study, which was a level 1 evidence, was included in this study. So based on that, I think that it was decided that the authors concluded that adjuvant chemotherapy had a stronger evidence. Now coming to immunotherapy, now we don't have immunotherapy trials for upper tract urothelial cancers. However, this particular study, the CheckMate 274, which became the landmark study for adjuvant therapy for nivolumab in bladder cancer, so in these patients, they took a high-risk muscle-invasive urothelial cancer, both patients who received neoadjuvant as well as adjuvant chemotherapy, and randomized them to nivolumab versus placebo. And this study, when you look at the inclusion criteria, had a significant number of patients who had upper tract urothelial malignancies of both the urinary pelvis as well as the ureter. So they were included in the study, and the study was positive both for disease-free survival, an intention to treat population, as well as patients with PD-L1 positivity. But when you look at the subgroup analysis, the majority of the benefit was seen in bladder tumors rather than upper tract urothelial malignancies. However, the numbers were extremely small and difficult to tease out. However, FDA has approved nivolumab for adjuvant therapy in urothelial malignancies. That includes both upper tract as well as urinary bladder. So FDA approval is there, and in India, we also have DCGI approval for the same. When we look at NCCN guidelines for renal pelvis and urothelial malignancies, both adjuvant platinum-based chemotherapy as well as nivolumab is standard of care, or certainly recommended in these guidelines. And that is it from me. Thank you.
Any question from audience?
Any reason why neoadjuvant chemotherapy works better for bladder cancer than it is for upper tract UTC?
So based on the studies that we've looked at, it is not that neoadjuvant chemotherapy does not work better than adjuvant. I think both are effective. It is just that we have more data for adjuvant than we have for neoadjuvant.
Compared to bladder cancer?
Yeah, compared to bladder cancers, a lot of the patients...
It's the same tumor, isn't it? I mean, what's the difference between
There are lots of studies that have been done in bladder tumors because it's more common, and we have lots of level 1 evidence for bladder tumors. But there's been only one study, which is the POUT study, which was a level 1 evidence for any upper tract urothelial malignancies. So it's very, very difficult to recruit for patients into a level 1. But if you look at retrospective analysis, I think the benefit is seen in both of them.
Right.
Dr. Agrawal, can I comment on this?
Yes, please.
Ganesh, I think you made a very valid point. A long time back, there was a paper in the BJUI, the bladder cancer and upper tract urothelial carcinoma, they are disparate cousins. They are both genetically, morphologically, they are entirely different. Maybe we haven't understood much about upper tract TCC, which probably I will highlight a little bit on my talk, but that's the reason perhaps I feel they don't respond much well to NACT2 as compared to bladder cancer.
Vijay, here, may I?
Yes, sir.
One quick question to you.
Yeah.
Historically, carbo inferior to cisplat in urothelial cancers.
Okay.
Do you still currently find that this is true, or are you increasingly comfortable also using carbo as much as you would do cisplatin?
No, for bladder cancer, we stick to cisplatin.
For upper tract?
For upper tract, so if you look at the POUT study, they included both carbo and cis, but 75% of the patients ended up having cisplatin, and only 25% of the patients ended up with carboplatin. And the carboplatin was only given if the GFR was between 30 and 50. So in my practice, I would certainly push for cisplatin rather than carboplatin, because overall in urothelial malignancies, even in metastatic situations, It has been shown repeatedly that cisplatin is better than carboplatin. And the other problem we face when we're combining platinums with gemcitabine is thrombocytopenia, which is more common with carboplatin than it is with cisplatin. So we end up with a lot of dose reductions when we combine gemcitabine with carboplatin as opposed to cisplatin. So we try to stick to cisplatin where possible.
I just have a question. In your clinical practice, a patient with upper tract TCC with avid lymph nodes on a PET CT, pre-op PET CT, would you advocate for neoadjuvant therapy or adjuvant therapy?
So if for larger tumors, so T3 node positive, I would advocate for neoadjuvant chemotherapy. Also, if I'm worried about reduced GFR post-operatively, I would advocate for neoadjuvant. More importantly, I think given the checkmate study that has been there for nivolumab, I think giving neoadjuvant chemotherapy surgery followed by nivolumab would probably be the best way forward for these patients, particularly larger tumors, node positive ones.
Fine.
Thank you, sir, for the excellent presentation. We call upon our esteemed speaker, Dr. Makarand Kochikar, for his topic, Management of Upper Tract TCC, what to do and what not to do.
Good afternoon, everybody. Thank you, organizers and the scientific committee of SOGO, to invite me to talk on what to do and what not to do in the upper tract TCC. Greetings from my hospital, Siddhivinayak Ganpati Cancer Hospital, where I've been working for the last 25 years. We established uro-oncology services there. And also the new venture we have just recently launched about 3 months ago, where I've taken up a job of a patron director and head of the Department of Urological Oncology, and it is a great center to work with. Now let us understand the upper tract TCC first before realizing and before commenting on what to do and what not to do in upper tract TCC. We all know the upper urothelial carcinoma, 90 to 95% arise from the bladder, 5 to 10%. But as Dr. Ganesha just talked about, do they behave same or are they disparate cousins? Let us have the facts here. The tumors in the renal pelvis and calyx are as twice common as in the ureteric tumors. The ureteric tumors more common in the distal ureter, as we all know, than the mid-ureter. They recur and progress anywhere in the urinary tract. The recurrence in the ipsilateral kidney is 84%, and that's why a lot of people talk about doing aggressive approach like nephroureterectomy, and multifocality is seen in 44%, and you have a chance of 1.8 to 5% in synchronous and metachronous tumors. The risk of contralateral metastasis always or recurrence persists even after the age of 5 years, and the recurrence in the bladder occurs, we'll know about 20 to 47%. And majority of them are invasive, and that's why we keep on talking about nephroureterectomy in our patients. And a peak incidence is about 70 to 90 years, 3 times more common in men as compared to sort of women. And we should also know there is a familial hereditary upper tract TCC, which is linked to hereditary null polyposis colorectal carcinoma, and this information we all should know. And here, the statistic, the female patients, I think we need to take a more aggressive approach. They're half likely to be diagnosed. They're relatively worse survival. They smoke less, but hormones-wise and genetically, they do bad as compared to the man itself. This point I was driving here, and the current guidelines also suggest that you should screen these patients. We're talking about evaluation, what to do, what not to do. And I think it is important. Look at the Amsterdam criteria. They have come in AUA guidelines. Lynch syndrome is rather underdiagnosed, and this is one of the highest rates of undiagnosed genetic disease in urological cancers. And I'm sure, though the entity is very less known as such, I think we should screen these patients, or at least we should ask the history in our patients as such. Second, about aristocolic acid, we have done some original work along with Sharif Sariyat here. We had negative studies, I'll mention at some point later on in the talk. So in evaluation, what to do, what not to do, I think we are going to do all the investigations, but also look for, apart from sporadic, suspicious hereditary upper tract urothelial carcinoma, and which are the patients aged less than 60, personal history of Lynch syndrome, related like cancers, first degree relative with Lynch spectrum cancers, and 2 first degree relative with Lynch spectrum cancers. If that is the case, I think we should do evaluation and screening of these patients. And what do the EAA guidelines talk about it? Yes, these two entities, aristocolic acid and Lynch syndrome, they are definite there is evidence of 2A, but the recommendations are not that strong. But I personally would like to screen those patients. Obviously, what to do? We do flexible ureteroscopy or rigid ureteroscopy to the diagnosis, the right thing to do. Biopsy is always tricky because you always get a small tissue. You need to have expert pathologists who should be able to tell you a low grade or high grade, which is so crucial in stratification, and sometimes taking a brush biopsy doesn't help in these kind of situation. Ideally, people should resect it like this, but I haven't seen many centers who have that kind of gadgets to resect it, but it's very difficult. People try and fulgurate it, use baskets to take tissue, but you don't see what is going in the wall itself. Maybe the new optical imaging would help you to look like what we are looking at virides and other things. We can look at whether ureteral sort of wall is involved in these patients or not. So in summary, what to do and what not to do with EAA guidelines, yes, do all these investigations and just make sure the added imaging like CT and everything is done. What about PET scan? It has promising sensitivity and specificity, so certainly I think it has a role. Also, what about molecular classification in upper tract urothelial carcinoma? Yes, there are 5 subtypes are known, but it is entirely unclear whether we can use in day-to-day practice or not. Risk stratification, how do you decide the treatment? You know the low risk, you know the high risk. Unifocal disease, a small tumor of less than 2 centimeter, negative cytology, low-grade biopsy, non-invasive imaging, certainly these patients should be a conservative treatment. But if you have multicentric disease, more than 2 centimeter disease, high-grade lesions, high-grade ureteroscopic biopsy, local invasion, hydronephrosis, previous cystectomy, these are the patients going to fail very quickly, and variant histology, these are the patients categorized into the high risk. Standard of care, we all know, do nephroureterectomy. As I said, they are multifocal, high recurrence, low incidence of contralateral tumors, and you reduce the frequency of check ureteroscopies and imaging, which are so unreliable in these kind of situations. A standard nephroureterectomy with a bladder cuff, another patient with a bladder cuff. But I tell you, the train is here. You really should get a good core of a vesicular junction and a core of a bladder. Many times we see patients who are coming back with the lesions in the bladder, which are in the short segment of the ureter, which is about 3 to 4 centimeter. So that portion is never taken off with whatever minimal invasive and other surgery. So make sure that intravesical portion is completely taken off. What about lymph node dissection in the upper tract TCC? And I think it's important. You need to do a good lymph node dissection. What about template? Look on the right side. You see, if you have tumor in the renal pelvis and the upper ureter, you need to do a template like this because this is the maximum landing, intra-aortocaval as well as a precaval and retrocaval. As long as the left side is concerned, when you have lesions in the upper and mid ureter, you need to do sort of a para-aortic and intra-aortocaval. You go down subsequently in the mid and lower ureter, you need to address the pelvic lymph nodes also, and you have to do a meticulous job. After doing nephroureterectomy, is imperative that you give one single instillation of mitomycin C within the perioperative period within the bladder or pararubicin. There are comments about doing minimal invasive in sort of radical nephroureterectomy. These are the retroperitoneal disseminations are known, and just avoid entering in the urinary tract. Direct contact with the instruments, closed system should be there, because larger tumors you will have definitely worse outcome if you don't do a proper job, and these are the recommendations. Now, what about, conservative treatment of upper tract TCC? Obviously, yes. So where do we do conservative treatment? Conservative treatment is done in patients who have TA and patients who are having ST1, which are a low grade, not for a high grade. This is high grade. You don't do conservative line of treatment in these kind of patients. And what are the different things you do? There are indications like if you have unifocal tumors, low-grade tumor, non-infiltration, patients in a compromised situation, solitary kidney, bilateral synchronous tumor, inferior renal function. I think it's important that we need to sort of address these patients and give them subsequent chemotherapy to have a normal renal function. Now, what do we do? I'll show you the examples rather than showing a table. This kind of patients, you can do RIRS or PCN and then do laser these lesions. You can do, this is a calaceal lesion, we can do sort of a lasers, holmium lasers. You can do even a partial pilectomy if it's a low-grade disease. Though it's a large volume, you can excise the renal pelvis. You can do upper polar nephrectomy for a solitary kidney. You can do segmental resections with a good margin. But important that you have a clear margins, you have lymph node dissection, good anastomosis, and if required, you need to do a Boari flap. This was a distal ureterectomy in a solitary kidney with a cuff taken, and then do a Boari flap of these patients. Obviously, you need to do a lymph node dissection, even for a conservative line of treatment when you do segmental dissections. What about doing sort of BCG or mitomycin C? There is a level 3 evidence. Whatever you say, the JJ stent or reflux, that is not going to reach the renal pelvis. So what has come out now? This is a Urogen, which has come with a mitomycin gel. You put an open-ended catheter, squirt the gel, keep it there for some time, and just take it out, and it's coming in the market very well. Follow-up imaging important for conservative treatment of upper tract TCC. You need to do check ureteroscopy every 3 months, and these are the guidelines after nephroureterectomy as well as conservative line of treatment. Last couple of slides about metastatic disease, what to do, what not to do. I think use gemcitabine and dose as MVAC 4 to 6 cycles. And it's important that this patient should be maintained with avelumab, and that is evidence in EUA guidelines 2022. And I think they do respond very well, and they do very well in case if you put them on maintenance. And this is all supported if the patients are not sort of fit for cisplatin, and what do you give as a second line of treatment. Last slide, what to do and what not to do. I think this is poorly understood disease, very rare entity as such. Try and get involved with international collaboration. This was the international collaboration we had with Larry Claus as well as Shahrukh Shariat. They have done a lot of work, especially Shahrukh Shariat, on role of aristocolic acid, nephropathy, and developing upper tract TCC. We contributed about 25 patients in our center, and this was completely negative study. We didn't find any changes in the renal pelvis and renal parenchyma, those patients from upper tract TCC, while these people found a significant sort of association with these kind of medications as such. Though it's a negative study, it's going to get published soon. And also, I think we haven't understood much about the genetics, the molecular biology, and I'm sure Mahul is going to do the next talk as such. Get involved. That's Jonathan Epstein, another big name in uropathology. So if my answer to what to do, what not to do, understand the disease very well, evaluate it properly, screen them for sort of Lynch syndrome and other things, and at the end of the day, we need to learn more and more about this upper tract TCC, and that's in a nutshell. Thank you once again, SOGO, for kind invitation.
So thank you for in-detail presentation. Sir, I have few doubts. One is most of the time we get negative biopsy or biopsy saying dysplasia. So in those cases, like how do you manage, and then do we want a second biopsy, or can we go ahead with a nephroureterectomy?
I think, as I mentioned to you, the instrumentation and the caliber with which sort of we actually go in to take a biopsy, we almost likely that you are not going to get positive yield. The best way is to actually going to go explore or rely on imaging instead of that, and then take it further. You see a small lesion, you've done repeated biopsy, you are suspecting malignancy, maybe go in, excise, send it for a frozen or proper histology, either do re-anastomosis or a re-implant or a bovary flap in these kind of situations. So maybe you have to go in and take a proper tissue for a proper histopathology.
And second thing, how confident are you in your practice that after taking a cuff of bladder cuff, instilling and mitomycin in an immediate post-op period?
Not immediate. I think allow the bladder to heal.
Yeah.
Okay, maybe in 1 or 2 weeks' time you should do it, but you should not miss out on that. And again, forgetting these patients for regular check cystoscopies. Very, very important. The other distinction point I'm making here is many times you have large tumors in the ureteric opening, sitting in the ureteric opening, causing gross hydroureteronephrosis. And many times it's so difficult to differentiate the tumor in the bladder going into it, or it's a lower ureteric tumor coming into the bladder. Sometimes it can happen. And that's why you need to have a proper imaging. Make sure there is no tumor on the upper side before you actually do a cystectomy in these kind of patients.
You mentioned regarding the minimally invasive or organ conserving surgeries like pilectomy, cholecystectomy, apopole nephrectomy. Is it, do you advocate it practically, or do you think it's
only in a compromised situation where you have a solitary kidney, elderly patients, you don't want to knock the kidneys out for that kind of lesions and put them on hemodialysis and transplantation. So these are very, situations and a compromised situations where you offer that. And you don't offer for large, bulky lesions where the disease is going to be extensive, because they're going to fail definitely.
Thank you very much. We end this session. We thank all the speakers and the organizers for inviting us.
So, as I have been told, there is a running tea. Anybody who wants can go outside and have tea and join us again. And another announcement, those faculty members who have not taken their plaques can please take it from the registration desk from where they took their certificates and the bags. And with that, we go to the next session. Now this is localized and metastatic renal cancer. So may I request the chairpersons to join us, Dr. G.G. Lakshman Prabhu, Dr. C.N. Patil, and Dr. Saurabh Vashisht. So, Dr. Patil and Dr. Vashisht is there. If I can request you to introduce the speakers and take on the session, please. Thank you.
Good evening, everybody. Myself, Dr. C.N. Patil. We have this session on localized and metastatic renal cell carcinoma. And nowadays, it's very imperative that we understand the molecular biology of the disease. It's not only the anatomy and the staging which dictates the treatment. It's very imperative that we understand the molecular biology of disease. We have with us the first speaker, Professor Mahul Amin, who is going to talk on molecular markers and comprehensive genomic profiling in RCC. Over to you, sir.
Good afternoon, everybody, and thank you to the organizers of SOGOCON. Talking about molecular pathology in a urology audience is obviously a daunting task, so I'll try to make it interesting. I'm going to start from a historical perspective and try to take you to where we are today. 1880s, a decade of technological advances. The light bulb by Thomas Edison, the phonograph, the telephone by Graham Bell. And so why are we talking about all these things that we absolutely need today and have made amazing changes in our life and starting in 1880s? And the reason is that that was the decade in 1875, on December 7th, the first nephrectomy for a renal tumor was performed by Dr. Lagenbusch. 3 prior nephrectomies had failed, and this was the one that had a successful postoperative course. However, the tumor was accidentally disposed prior to examination. At least that's what was officially stated in the records of this tumor. So what I hope to do is to make a convincing case that appropriate pathologic and, of course, judicious molecular characterization of renal tumor specimens is the cornerstone for the best multidisciplinary management of renal cell carcinoma. In 1975, renal tumors were very simple from a histologic perspective, really clear cell carcinoma and granular renal cell carcinoma. And actually, when you looked at the outcomes of these 2 different types, they were overlapping because we were really talking about tumors that had overlapping clinical pathologic spectra. In the 1980s, the same time that we were talking about that classification, if you look at patients with renal cancer, what did we know about them? Enigmatic clinical behavior, proclivity for metastatic disease, and so the patients had a choice of nephrectomy. If they had metastasis, depending on metastatic behavior, then they had a choice of immunotherapy with all its attendant complications. So really the renaissance of understanding of kidney cancer pathology from the molecular perspective came in this era of 15 years where very careful light microscopic examination under the microscope and some very good cytogenetic correlation as well as immunohistochemistry, tools that we use in pathology all the time, led to further refinement of just that clear cell and granular renal cell carcinoma into 5 types of renal cell carcinoma. So this was 1997. At the same time, if you look at the treatment of renal cell carcinoma, 1977, just removing part of the cancerous kidney, laparoscopic surgery, 1991, cryoablation, and really the game changer beyond just surgical removal and immunotherapy was the Human Cancer Genome Project. And you can see in the next 15 years, we had the first FDA approval of here tyrosine kinase inhibitors, here mTOR inhibitors in 2006, 2007. We have got mTOR and tyrosine kinase inhibitors in 2009. Furthermore, we start seeing the impact of immunotherapy, CTLA-4 inhibitors, and now we have combination therapy. So very rapidly from nephrectomy immunotherapies, the understanding of molecular biology has changed the approach of aggressive kidney cancer. But nonetheless, from an oncologic perspective, it was still the histology that dictated if you have a clear cell, you're likely to respond to certain pathways. And so understanding this, for example, chromophobe carcinomas have mTOR mutations, and so kind of targeting based on histology was really the most sort of preferred approach when you look at 2005 to 2015. So let's go to 2016, where the previous edition of WHO came up. As you know, there's a new edition right now. And from 5 types, we go to 13 types, and these are listed here. So you can see, obviously, there's an expansion of the types of the, renal cell cancer. And as I'm just mentioning, this year, a couple of months ago, we released the new WHO classification of renal tumors. Here it is. And there is a very unique category of renal tumors that is molecularly defined renal cell carcinomas. These are renal tumors that just morphology alone is not required, is not adequate to confirm the classification. And so we've gone from 5 to 10 to 17 types of renal cell cancer in just a matter of 2 decades. So where are we in the current status of classification, and what's the impact of molecular? The contemporary classification is based on combined morphologic and molecular paradigm. The different subtypes we know of renal cancer, why do we have these 22 subtypes? Because they have very unique histology, immunohistochemistry, a very unique molecular signature, and very unique clinical aspects. But most importantly, we know that while morphology works in the vast majority of cases, it is not alone insufficient to correctly diagnose at the individualized patient level, and therefore there is need for complementary testing. And let's just take a look at the NCCN guidelines in terms of, say here, stage 4 disease, clear cell histology versus non-clear cell histology. And you can see that if it is a patient with stage 4 with clear cell histology, there's a clear line of therapy which differs from non-clear cell. So understanding just clear cell versus non-clear cell is important. We also understand now the combination checkpoint inhibitor. So I'm not going to the details, but just to give you why this molecular classification is going to be important. So the central issue now with the 22 subtypes of renal tumors is that, 21, 22, is that even just the basic clear cell versus not clear cell is very difficult sometimes, and you need an experienced pathologist. Here are all tumors with a clear cell type histology. However, we can see that they're all different types, including an epithelioid pecoma, angioma, lipoma, translocation carcinomas. So all tumors that are clear are not clear cell carcinoma. And here's an example of a clear cell carcinoma. Here are tumors that are not actually clear. They're all pink, but they're all flavors of clear cell carcinoma. And here are pink cell tumors, and each of these pink cell tumors have very unique syndromic and other associations that are very critical in understanding, and we do need molecular classification for these tumors. So the histologic characterization of renal tumors is complex and difficult due to marked overlap in histologic patterns. I've just shown you just a flavor of that. And that while the vast majority of these tumors can be correctly diagnosed by experienced pathologists, histology is alone not sufficient. And pathologists have several tests to assist in the diagnosis. So how do we approach renal cell carcinoma molecular analysis in 2022? For the most part, pathologists will do a gross examination, they'll do immunohistochemistry, H&E, and can diagnose 85–90% of the cancers. Often we need clinical correlation. For example, this is a patient with multiple cutaneous leiomyomas. We have other now methodologies such as FISH, or fluorescent in situ hybridization. We do chromosomal microarray, NGS, mutational analysis. So when do we need this whole repertoire of tests that are available? I just want to make sure that one understands that molecular tests are not required in all cases. Molecular tests should be ordered with a clinical question in mind. It's just not like, I don't know what the test is, so you need to do a molecular analysis. And that ordering the right molecular test is key, and the same biomarker may be required. For example, ALK rearranged carcinomas, you can detect it by immunohistochemistry, you can detect by FISH, you can detect by sequencing. So there are multiple different ways that you can look at the same molecular alteration. So what are the ways and times that we need molecular classification? So for diagnosis, if you have these kind of tumors, we can use FISH rearrangements. I'm not going into the different types, but to tell a papillary versus translocation carcinomas, we can use gene rearrangements and amplifications. Clearly for rearranged carcinomas, we can do NGS fusion analysis. And very important for unclassified carcinomas, when one doesn't know what types of carcinomas one are dealing with, we often use mutational analysis. And what I've done is provide you here with the genes that are involved that we can detect with these classifications. I'll need just 2 or 3 more minutes, sir. From a prognostic perspective, this is not an area where I would advocate molecular classification, but again, different types of renal cell carcinomas, we can do mutational analysis, and there are certainly, when we identify certain mutations, they confer an adverse prognosis. I think clearly from an oncologic perspective, metastatic disease and unclassified high-grade renal cell carcinoma are clearly very important indications for molecular analyses. You can do targeted therapies. You can see here the targets and then the therapies that are associated with them, and immunotherapies and testing for immunotherapies and the markers that can be associated with immunotherapy, immunohistochemistry, or NGS. And here's a list of the potentially actionable molecular targets. Finally, we also need molecular analysis, and this is a whole area for genetically associated renal cell carcinomas. And this is an area that I think urologists are not as familiar with. We believe that up to 3 to 8% of renal cell carcinomas are genetically predisposed, and there are even NCCN guidelines of when to do molecular classification. A young patient, bilateral multifocal, family history of renal cell carcinoma, et cetera, and certain histologies that need molecular testing. And clearly, these are the targets that we can identify by next generation sequencing. So you might think, okay, so we understand we need to do this molecular testing. Here's some very important information from the Memorial Sloan Kettering Cancer Center. They looked at 254 patients with stage 3 and 4 kidney cancer. These were unselected, they just all were tested. 5.5%, so within that 3 to 8%, had renal cell carcinoma syndromic associated genes, and another 11% had inheritable cancer associated genes that could be targeted. So just showing that you had almost 16-17% of tumors where this germline testing had important implications. In fact, for non-clear cell carcinomas, more than 20% had a germline mutation in which there was a direct impact on systemic therapies. So really, here's a summary. Again, I'm not going into the details of this, but clear cell papillary and which are the pathways, and based on histology, which are the therapies that are available, including FH deficient carcinoma, ALK rearranged with ALK inhibitors, SMART deficient with proteasome therapies. So what I hope we understand with this, and it's a very brief presentation, is that we are not only going to use histology, but molecular analyses to guide these patients with kidney cancer into appropriate therapies, including newer targeted therapies. So in conclusion, the take-home message is that we have stretched the limits of morphology and light microscopic classification, and it's not that it is adequate in all cases, and so we do need molecular testing. Molecular testing is often driven by multidisciplinary teams, particularly oncologists, and pathologists in the audience, and even the urologists need to understand when that these molecular, what are the molecular or clinical clues that help us to triage the molecular testing, which are expensive and resource indicated. And finally, judiciously perform molecular testing is essential for the right diagnosis, accurate prognostication, therapy selection, and active surveillance. With that, I hope I gave you a brief overview of why molecular testing has become very critical in kidney cancer.
Yeah, excellent presentation. I just want to know one question. Apart from the clinical criteria which you have told, which are the indication for molecular testing, is there any specific histopathological criteria also after which we should go ahead with the molecular marking? Number one. Number two, can these molecular marking be done effectively in the preserved slides and blocks, or at that same time, if there is a disease progression, patient will require a rebiopsy?
So excellent question. So the first one is in terms of, can you repeat the question? I just want to make sure.
You have told that apart from the young patient and multiple tumors, it should not be done. But so, is there any specific histopathological findings where it should give you a lead that you should go ahead with the molecular?
Yeah, and yesterday we had a whole session on this where the pathologists were there, and there are several histologic features that we can just identify and say these are highly suggestive of. But none of these, you do need germline testing, you need the clinical information, etc. So pathologists being aware of the clues is very important. The issue is that you require really sophisticated, someone who's really specialized in renal pathology, because most pathologists, and they are looking at general pathology in India, though there are some subspecialized centers. To understand these nuances is not something that I think most pathologists are familiar with. But with experience, we can diagnose SDH deficient carcinomas, FH deficient carcinomas. These are all clinically very relevant with associated very high-grade disease for their partners. And in terms of the tissue stability, almost all these tests can be done on paraffin-embedded tissue. The issue is if you have metastatic disease in the primary, of course, and you're looking for targeted therapies, I would prefer that you use the metastatic. If you can get access to the tissue. Of course, if you can't get access, we'll use the primary. But in general, the metastatic tissue is favored.
Thank you. Thank you.
Thank you.
Any other question?
Thank you.
Thank you, Professor Amin, for excellent insight in molecular understanding and improving outcome. Now I'll tell something in advancement of technology and how surgical aspect can improve outcome in small renal masses. So just a customary slide. So assume I have a patient with a mass of less than 4 centimeter size. So in next 8 to 10 minutes, I'll talk how we can improve the outcome, surgical outcome, by means of technological advancement and understanding the surgical nuances. So the aids to improve outcome will focus on the pentafecta outcome, and I'll discuss in the subsequent following headlines like how further imaging may help in improving outcome, how surgical aspect like radical versus partial approach, intraoperative aids that can improve the outcome. So if we see for last few years, there are lots of talk about 3D reconstruction or 3D printing model as well as 3D virtual models. So each of these models, this is sorry. So we can see this is a 3D printed model, physical model, and this is a virtual model, and this is a augmented reality. So why 3D image is important for us? If you see, many research has been done that understanding of the dimension perception by retina and the brain is much better when we see the 3D image. So 3D printed models, it looks like this, and it helps in cognitive fusion in the intraoperative time, though the augmented reality is not possible with the physical model. We have made this physical 3D model, and this model was made with polylactic acid, and we have presented this in IGU 2020. And the virtual model is made by specialized software using the DISCOM image of CT scan or MRI, and they are interactive models, and you can use as a cognitive fusion as well as real-time fusion, that is augmented reality. So just to give you an overview how you can use this model. This is not going on. Sorry, this video is not going. Basically, you can see different structure with this virtual model and it rotates. So I don't know why this video is not. Not opening. It's okay, fine. So you can use this virtual 3D model with Tile Pro Robo image guidance, and you can use as a augmented reality, and you can see it during operation. And we have, when I searched the literature, there are good number of recently published literature, and they said it improved the operative time, warm ischemia, and blood loss, and also the long-term outcome in terms of eGFR and fewer post-operative complications. So augmented reality as well as this has a functional, definitely better functional outcome, but probably some oncological outcome as well. So if you don't have a 3D model, at least you should have a good reconstruction to get less surprises during the surgery if you are using robo or laparoscopic. And also you should discuss with the radiologist on the console, that really helps. And there are several CT-based scoring systems. So it has been seen that they can predict the intraoperative as well as postoperative outcome in terms of warm ischemia time, operative times. And C-index found to be the best predictor of the warm ischemia time. So this can be used for perioperative planning. And as we all know that intraoperative ultrasound is a very useful tool for understanding the tumor margin depth and also to confirm the optimal clumping, especially in a selective clumping scenario. And it is a standard tool. And this is more useful in the cases of endophytic as well as complex hilar masses. And this is a fancy tool, that is Firefly. It has been proposed to have a benefit to increase the margin positivity, but evidence does not support it. So I came through a newer advancement, that is radio-guided occult lesion localizing technique using technetium radioisotope and intraoperative gamma camera. This is especially useful for endophytic masses. Only one literature is available, so I don't know much about it. Now I will go to the surgical aspect. So whether robo is good, lap or open is good. So the first article which has been published by Indianapolis group in 2015, and they found the renal function preservation is same across all three modality. But open partial nephrectomy offers faster operative and lesser ischemic time. Subsequently, the other literature also suggests that in open technique, the operative time may be shorter and less warm ischemia. However, the complication rate, blood loss, and greater parenchymal preservation has been seen with robo. So, when I searched about robo versus lap, so the literature is gung-ho about that robo is much better than lap. However, there is a recent meta-analysis which showed that robo is equivalent to lap in terms of perioperative functional and oncological outcome, but better than open. So evidence is very confusing. So I don't know what to conclude from the evidence, but my take is that whatever ways you are comfortable, you should go with that. If I have access to robo, though I am doing a lots of partial, laparoscopic partial also, but I will go for robo. And in selective scenario, I will also take the challenge of my open skill in a very selective cases. So if I ask to the audience, in this case, whether you would like to go for a partial or radical, where the opposite kidney is normal in a 60-year-old male. So I think there are few of the surgeons, they would like to go for radical instead of partial. So if you see the outcome in radical versus partial, this is only one meta-analysis that showed that partial nephrectomy has an advantage in terms of all-cause mortality, serious post-operative adverse effect, but this is a very poor accrual, and this they have taken all the localized disease. So T2 disease or T3 disease, they have probably went for radical nephrectomy. So I think this study was biased. So if I see the guidelines in a small renal masses, the partial nephrectomy is preferred, but the complication rate is little higher than radical nephrectomy. However, the oncological, and there is some benefit in terms of reduce the risk of CKD. But all-cause mortality and overall survival is probably very doubtful to say that it's improved by the partial nephrectomy as per the current literature. So radical nephrectomy has a role, yes, definitely, especially in a complex renal mass when the opposite kidney is normal and there is no imperative indication. So trans versus retro. Retro has its own advantage in terms of posterior located tumor, and the literature said that it reduces the duration of surgery and early recovery and less hospital stay with a cost of high learning curve. So probably robo and probably the retro and trans having good results. If retro has been done in expert hand, in some selective cases it has some advantage. So enucleation versus enuclear resection. This is my new addition to my knowledge after seeing so many literature that supported the enucleation is a very good technique as compared to enuclear resection. It reduces the blood loss, preclude to entry into the collecting system, and facilitate zero ischemia time, especially in hilar tumor and hereditary multiple masses. This enucleation is very useful. So I went through all the recent publication to 2020, 21. They are very favorable for the enucleation as compared to enuclear resection. So in our experience, out of 302 partial nephrectomy cases, we have done 15% enucleation, and the local and recurrence and long-term outcome is as good as the enuclear resection. Worm ischemia time, as we all know, the traditional safety is 30 minutes, and each additional 10 minute increase in worm ischemia increase the risk of AKI. However, only one good meta-analysis available on this, and they said the quality of evidence is so poor. So currently, they cannot conclude that any worm, coal, or zero ischemia is better in compared to each other in current evidence. So I'm not going through this slide, and you can sometime do off clump, and probably that is definitely helpful to reduce the ischemia time, because and in a selected cases we can do off clump, like we have recently done a off clump, though it looks little messy during surgery, but the outcome is very good. So, and good renography is also very important. I am not going in depth of that to have a good outcome. To conclude with 3D printing, especially the augmented reality as well as intraoperative ultrasound definitely has a role to play. Though partial nephrectomy is preferred, but in selected cases radical nephrectomy may not be an overt treatment. The robotic partial nephrectomy may be preferred, but all other approaches has their own place in having a comparable long-term oncological outcome. Retroperitoneal approach may have some advantage in expert hand, especially the posterior tumor, with at the cost of a tougher learning curve. Enucleation is useful at least in selected situation without compromising the oncological outcome. Though long-term effect of prolonged ischemia is not known, but we should aspire to minimizing it, and we should embrace and keep updated with newer technologies. Thank you. And I would like to acknowledge Dr. Raghavan sir, Anup Kumar sir, and Dr. Bakshi sir for helping me with some slides and this presentation. Thank you.
Any question?
I just wanted to make a comment. Sanjay, you said that enucleation is, in your review of literature, it's a good modality. I agree what literature says, but the issue is, enucleation is good for clear cell, it is good for chromophobe, but preoperatively we don't know what the final histopathology is going to turn out. Whether it may turn out to be sarcomatoid, which is very bad, and medullary again. So if there is a strong suspicion of non-clear cell, radiologically if the tumor margins are not very clear, then one should not go for enucleation. Enucleation is a good option for one Hippel-Lindau disease, family history of one Hippel-Lindau, you definitely go ahead. But otherwise, if there is any irregularity, then one should take a wide margin.
Yes, sir. I have mentioned that when the capsules are well delineated on radiological image, you can go for. But if there is a doubt, you should go for enucleation.
Could I add to this enucleation thing? I think whether to do enucleation or not, it's very clear on imaging. Rather than on pathology. Pathology doesn't play a role. Most of the time it's imaging.
You have to take a decision preoperatively that you will go for a
and invariably, even when you find that there is some irregularity at the margins, you will find that the planes are well preserved. Because RCC or these renal tumors are well encapsulated tumors, unlike some of the other tumors in the body. So they're eminently
play the video.
This thing amenable to enucleation. I think that's and margins are always clear. Margins are always. You don't have to do frozen section or histopath to rely on that. Absolutely on table, you know that the margins are clear.
I think apart from the hilar tumor where you can preoperatively decide about the enucleation, in rest of the cases it is a peroperative findings which will going to decide whether we should go for enucleation or enuclear resection or resection. Thank you.
Well taken, sir. Thank you.
Can I ask you a question, sir?
Oh, sorry, sir. Sorry.
Would you say that your techniques of 3D printing, AR enhancement would be more useful for somebody who is going to do robotic and laparoscopic surgery, but does not actually play a role if you're going to open partial nephrectomy?
All the literature currently available in this 3D virtual reality or augmented reality is in minimally invasive. But in open, when we had made a physical model, so we felt that physical model helps in understanding the anatomy, perception of the anatomy better, at least for the resident. We have taken a scoring of with the models, and we have done good number of open cases during that period. And the scoring of understanding the surgery by the residents are much better seeing the physical model.
Thanks.
So I have a question with Dr. Raval. What is your opinion about doing anatrophic nephrotomy?
I'm there.
Yeah.
I'm not going anywhere.
Yeah. So what is your opinion about doing an anatrophic nephrotomy for taking out the totally endophytic tumor? There is one video has been published on a YouTube where instead of doing a resection from outside, they have done a anatrophic nephrotomy and then open the kidney like a book and take out the tumor and then close it again.
See, I have never done anatrophic nephrotomy by robotic, or maybe in open I have seen once in Vellore for doing the stone disease. But for endophytic tumor, as you said, probably that's a good idea. And endophytic tumor actually depends where it is.
Yes.
If it is, in the situation where anatrophic will help, then definitely
So basically
go ahead.
it was a total hilar tumor, and they identified that doing cutting from outside, it will going to cause a more parenchymal loss and will going to have more complications. So they have done a nephrotomy and then take out the tumor entirely and close it like a partial nephrectomy.
That's a good idea, but I'm yet to do that. Thank you.
Yes.
So we have earlier done that at TMH in an open surgery, and the patient has got well-preserved GFR. In fact, he was also a urothelial cancer patient in whom the right kidney was affected with a papillary type 1 finally after that. Secondly, Dr. Mahendra Pal from TMH has sent a video to the Intuitive also with a robotic similar thing what you say. I think you must have seen that video. So he's put something like pearl oyster technique, and that patient apparently, I'm not in TMH, but that patient is doing excellent.
Actually, their explanation was the same, that there is a less parenchymal loss.
So as you demonstrated with your hands, it was not a complete bivalving of the kidney. With an ultrasound, that area was noted. A certain segment was on the Brodell's, so-called Brodell's line was incised till you saw the tumor. Once they saw the tumor, it was enucleated and then it was sutured off.
No, that you are right, but what I am talking about, they have actually bivalved the kidney, open the kidney, take out because it was a large endophytic tumor. And according to, I'm forgetting the name of the surgeon, but I will forward you.
And what is the question?
So the question is this, that has he any experience about this or not? I was asking to Dr.
These are the two cases which I have seen, and it's good. Long-term results will have to wait.
We have published one case from Asian Institute of Nephrology and Urology, that is a posterior radial nephrotomy for posterior hilar tumor, where you do the Gilbert dissection and open the, along with the lower calyx, just open the renal parenchyma at the medial lip and completely remove the tumor, enucleate the tumor. Finally, it came out as hematoma.
Yeah, thank you. We'll move on to the next talk. New kid on the block is BRT for small renal mass by Dr. Shankar Shiva.
Hello, I hope you can all hear me. I'm talking to you from Melbourne, Australia. My name is Shankar Shiva. I'm a radiation oncologist at the Ben McCallum Cancer Centre. Thank you very much for the invitation and the opportunity to speak to you today. I'm talking about the use of SABR for primary RCC. So there are several options for primary RCC, as we know. Partial nephrectomy is one of the potential standards and has the ability to treat perihilar tumours and large tumours, but it is requiring of an anaesthetic and is invasive. Thermal ablation techniques such as cryotherapy and radiofrequency ablation can sometimes avoid general anaesthetic, being percutaneous approaches, but still is unable to treat perihilar tumours, large tumours and non-invasive tumours. In this context, stereotactic radiotherapy or SBRT or SABR, they're all the same thing. This may have a potential advantage in being non-invasive, has a capacity to treat perihilar tumours, larger tumours than T1A, and is a non-invasive approach. There is a classical concept, though, that renal cell carcinoma is radio-resistant. And this has been something that's been in classical teaching, not only in radiation oncology, but across a lot of oncology. This type of concept has been debunked as far back as the 1990s, where investigators at the Stanford University did a cell survival assay looking at cell kill with two of the most common human renal cell carcinoma cell lines, the A498 and CARKI1 cell lines. These investigators were able to show that in this cell survival assay, where dose of radiation is on the x-axis and the surviving fraction of cells was on the y-axis, and that's a logarithmic scale, that in typical doses of radiation, which you use 2 grays or less in a classical clinical setting, there's not that much cell kill. There's actually a shoulder on the cell survival curve. But at larger doses per fraction, at 6 gray and above, these are logarithmic cell kills. And this may give an explanation for why that the use of radiation therapy in the stereotactic era has become much more prevalent. This is a broad overview of the timeline of stereotactic radiotherapy for renal cell carcinoma, which is actually quite old. The first reports of fixed frame stereotactic radiotherapy were coming from the Karolinska Institute in 1995. 8 years later, there were the first reports of using SABR for targeting primary renal cell carcinoma in the same institution. And in 2008, there were reports also of SABR for primary RCC in the functionally solitary kidney. Ourselves at the Peter MacCallum Cancer Centre instituted our program for stereotactic radiotherapy for primary RCC in 2012. And I'll be speaking in a bit more detail about the international consensus statement from the IROC group, the International Radiosurgery Oncology Consortium of the Kidney, which was instituted in 2016. At the Peter Mac, we commenced a program with the trial called Fast Track, which stood for Focal Ablative Stereotactic Radiosurgery for Cancers of the Kidney. Our technique was non-invasive, but required dual vacuum immobilization. This is basically vacuum immobilization of a bean bag underneath the patient, and then a type of shrink wrap over the patient's torso to help them keep still for delivery of treatment. This is delivered totally non-invasively and whilst the patient is awake. We had in that initial phase 1, phase 2 trial, a total of 33 patients with 34 kidneys treated. We'll take note that the average mean tumour size was 49 millimetres. This is not a small renal mass cohort. Most of the tumours were T1B and above, and the histological grade, I should say, was typically, most of the patients were histologically confirmed, and most patients had histological grade 2. And most patients had clear cell, which is representative of the cohort. So of the 33 patients and the 34 kidneys that were treated, the median follow-up in this cohort that was reported in the BJUI was 2 years. One patient had a grade 3 treatment-related toxicity, which was fatigue, and this patient had bilateral kidney tumours that were treated at the same time. And this patient went from riding a bicycle up to 100 kilometres a week to spending 3 weeks on more or less on the sofa. 6 out of 33 patients had no treatment-related toxicities at all. And this was quite remarkable because 18% of the patients really mentioned that they had didn't really realise that the treatment had even been delivered. The freedom from local progression at 1 and 2 years, which are the pre-specified time points, was 100%. This was a medically inoperable cohort, and despite this, the overall survival at both 1 year and 2 years was relatively good at 100% and 92%. Following some of this data and data from other institutions, a group of interested international institutions put together a publication called the International Radiosurgery Oncology Consortium Consensus Statement for Approaches in Stereotactic Radiotherapy for Primary RCC. This is a multi-center, meta-analysis that was including multiple institutions across Europe, Japan, Australia, Canada, and the US. In total, our initial analysis pulled 223 patients, and we'll make note that the average age was older than is typically reported for patients with primary RCC at 72 years old. The pathological confirmation rate was 85%, and this is more or less concordant, or perhaps even a little bit better, than what is normally reported in the thermal ablation literature. And again, the average tumour size was larger than is reported for thermal ablation at 44 millimetres in size. Most patients have pre-existing chronic kidney disease, CKD class 3, with the mean of EGFR being 59 mils per minute. So in this cohort, the 5-year cancer-specific survival was 92%, and the 5-year local control rate was 98%. For our first publication, we looked at both the renal function outcomes as well as part of the analysis. And I mentioned that the average patient had a pre-existing renal dysfunction. At last follow-up, the mean reduction at EGFR was 5.5 mils per minute, and 6 patients, or 2.7% in total, underwent dialysis. Our second publication from this cohort looked at outcomes specifically in the larger RCC cohort. This is T1B and above, those patients that cannot typically be treated very well with thermal ablation. We found that size is prognostic for distant failure, but not predictive for local failure. These are cumulative incidences of failure with death as a competing risk, where we have local failure on the left-hand side showing similar outcomes for both tumours that are less than 4 centimetres and greater than 4 centimetres in size. In terms of any failure and distant failure, which is the middle and right panels, there is definitely a prognostic significance for having a T1B tumour and above, and this is borne out by increased risk of distant failure. The third publication we produced was regarding the solitary kidney. And this is, again, as an overview, renal SABR is performed in very few specialised institutions around the world. This analysis was looking at 9 centres that was able to have pool data on solitary kidneys from the IROC consortium. IROC centres were allowed to include patients who had RCC histology and serial enlargement, 1 to 5 fractions of treatment, and greater than 1 year of follow-up. Exclusion criteria was previous radiotherapy to the abdomen, recent TKI therapy, or other active or prior cancers. When we pulled this data, we had 81 patients with a solitary kidney as opposed to 142 patients with primary RCC in 2 kidneys. When comparing both of the cohorts, the solitary kidney cohort had a similar loss in renal function as compared to the bilateral kidney cohort, although 6 of the patients in the bilateral kidney cohort underwent dialysis in the long term. This is because the patients that we see with a solitary kidney having had a prior nephrectomy tend to be younger and fitter, whereas those patients who are medically inoperable and have 2 kidneys in situ tend to be patients who are more comorbid and have other pre-existing conditions that may contribute to renal impairment. The SABR for the kidney seems great, right? So how do we actually compare to other treatment modalities? And there's a little cartoon saying, did you read my paper on confirmation bias? And the reply is yes, but it only proved what I already knew. This analysis is an analysis of cryoablation versus radiofrequency ablation for the treatment of renal cell carcinoma, and a meta-analysis of these 2 techniques. This publication had 427 patients with cryotherapy and 426 patients with radiofrequency ablation, and this is quite a bit larger than the experience from the IROC consortium at 223 patients. The median follow-up was 18 months for the cryotherapy and radiofrequency, and this is quite a bit shorter than what was reported for SABR, which is surprising because a common comment is that there's not long-term data for SABR, but in fact, stereotactic radiation has similar or longer outcomes than is typically reported for renal ablation. The mean age for the thermal ablation cohort was 64 years as compared to an older comorbid cohort for the stereotactic radiation at 72 years. The average tumour size was much smaller for thermal ablation at 2.5 centimetres for cryotherapy and 2.7 centimetres for radiofrequency ablation as compared to 4.4 centimetres for SABR. Despite these and the negative features for the cohort that's receiving radiotherapy, the 5-year cancer-specific survival rates are 87% to 90% in large series of thermal ablation and very similar to what we see with SABR. This is capped off by a meta-analysis that we performed looking at the role of SABR from multiple studies, and this is published in European Urology, looking at 26 articles in total that were eventually included in the meta-analysis. This is a forest plot for outcomes. The majority of studies had very good outcomes. there were some patients who had, some of the series had poorer local control, particularly the first few that were addressing very large tumours, greater than 10 centimetres in size. In terms of grade 3 and grade 4 toxicity rates, typically this is reported to be very low at 1.5%. This is basically being hospitalised or having a permanent injury from radiation. This is very low at 1.5%. And the average loss in EGFR is reported in these studies to be 7.7 mils per minute. The current state of play in 2022 is 9 prospective clinical trials of stereotactic radiation for SABR, and this is higher than any partial nephrectomy or thermal ablation approach to date. So the summary and take home is that, in my opinion, SABR is safe, effective. It is currently recommended in the NCCN 2022 and ESMO 2022 guidelines for primary renal cell carcinoma that's not suitable for surgery. Inoperable larger T1B primary cancer, again, not suitable for thermal ablation. And RCC in solitary kidneys, not suited to partial nephrectomy. I'd like to thank you for your attention, and thank you very much again for the invitation to speak to you today.
Thank you. We shall go to the last talk of this session, role of adjuvant therapy revisited. We had the role of, sorry.
Shankar, can you hear me?
I can.
Thank you for giving the talk. I know it's late on Saturday night there. What would you say, in which patient would you say SABR is not appropriate in a solitary renal mass? Would you exclude some patients, rather, barring size of, 8 or 10 centimeters?
That's a very good question. I think one of the main things I would potentially talk to my urologist about is the ability to do a safe partial nephrectomy with minimal nephron sparing. I think that's the main issue there. A lot of the solitary kidney tumours that we see, and that's probably a bias in referral patterns, are the centrally located endophytic high complexity renal score type tumours. And in fact, we have a very low threshold at our institution to be referring these patients for SABR.
Okay, so the central endophytic tumours, you wouldn't? Okay, thank you.
No, I would. I think that's a really good option for SABR. Those tumours that are difficult to perform a partial nephrectomy on with the high renal complexity scores are perfect for us.
Okay, thank you.
Yeah, thank you, Dr. Shankar Shiva. If there are no more questions, we'll move on to the next talk. Over to you, sir, Dr. Vineet Talwar.
Thank you, chairpersons. And slowly we are moving from small primaries, and now the role of adjuvant. Sorry. So this is adjuvant therapy revisited, because initially we thought that we could give TKIs as an adjuvant therapy, but then there were some drawbacks which I would like to allude to. So adjuvant TKIs, you found that there were a host of trials about 5 to 7 years back, and amongst all these trials we found that the STRAC trial, which used sunitinib for 2 years, that was the one which was positive. This was for T3 or T4 lesions and node positive lesions. But again, when you saw this, this was the disease-free survival only. So in 2017, FDA approved 1 year sunitinib in the adjuvant setting. However, because of limited benefit and the toxicities, inconvenience of treatment, the real world use was limited. So when you weigh the toxicity versus the benefit, you found that it is recommended as adjuvant, which will be more likely for younger patients who have a higher anxiety about the disease recurrence and a high threshold for toxicity, so that they can bear it. And after this, there was a meta-analysis which was done, and the meta-analysis was the data from 3 available clinical trials of adjuvant VEGF TKI versus placebo, and they do not support the use of adjuvant TKI therapy as a standard of care after nephrectomy. And more so because, as you can see, the confidence intervals were approaching unity, and they were crossing that, whether it was the disease-free survival or the hazard or the OS ratios. So adjuvant TKI at this time is not recommended for routine use post-nephrectomy. If that is so, then what about the use of immuno-oncology drugs in an adjuvant setting? So this was the trial, the Keynote 564 trial, which had a 30-month follow-up in which patients who were histologically confirmed clear cell RCC and 12 weeks post-nephrectomy, and they had no previous systemic therapy, they were randomized in a 1:1 fashion for pembrolizumab every 3 weekly versus placebo. The primary endpoint in this case was the disease-free survival, and the secondary endpoint was the overall survival and the toxicity indices. And the patients who were in this, they were the intermediate risk, that is T2, T3, high risk, that is T4 and node positive, and there was another group that was the M1 NED, that is M1 disease in addition to the primary tumor at diagnosis, and which had undergone a complete resection along with nephrectomy or within 1 year after nephrectomy. So you had these three criteria in which the eligibility criteria was taken into, and we found that the disease-free survival in the intent to treat population, there was a difference of about 7% when you see the DFS, and the hazard ratio was 0.63. And also, if you find that if you see across the key subgroups, you have the age, you have the sex, you have the ECOG status, the regions, that is the Americas, the European Union and the rest of the world, the tumor grade, whether it is 2, 3, 4, or whether it is the PDL1 status, whether it is CPS less than 1 or CPS more than 1, it was found that across all these groups, it was beneficial in terms of the disease-free survival. But when you saw the overall survival, you find that this graph, it starts diverging by about 25 months when you compare it with the placebo. Although in this case the hazard ratio is 0.52, the comparison did not meet the criteria for statistical significance in this analysis. And the reason for this is that it required about 200 events, and that have not occurred till now. So that is why the overall survival is in limbo. But at this point of time, we have a good DFS to give us as a marker if you have to give these immuno-oncology drugs in adjuvant setting. So hazard ratio 0.54 because of the fact that the censoring was beyond 2 years and the events were not significant, that is events of about 80 or 90, should be about 200. The overall survival is not mature as of now. If you talk of the safety profile, you find that the all-cause adverse events were seen in most of the patients, and in 2 patients it led to the death, and in about 10% patients it led to the discontinuation. But it was seen that overall the side effect profile was similar, which was seen when you use these immuno-oncology drugs across the group strata. So to summarize, this was the first immunotherapy drug in renal cell cancer to achieve an improvement in the disease-free survival. Goal of the adjuvant therapy is cure. So no difference is overall survival noted as yet. The reason being that I told you it was the events have not occurred till now, so we got to wait for that. And we need a longer follow-up. Greater than 50% of patients may not be benefiting from this and could be cured by surgery alone. So this could be another argument against the adjuvant treatment in these patients. 20% of patients had to discontinue because of the adverse events. So you have to give this drug for almost 1 year in those patients who are relatively fit or may be cured without the drug alone or probably with the drug alone. And even when these patients relapse after a period of time, immunotherapy combinations result in a cure in about 30% of patients. So you have 50% of patients who get the DFS benefit in these set of patients, But there are another 50% of patients who might do better if they are bereft of this treatment. And along with that, you have around 30% of patients which can be salvaged. So 50% plus 30%, that makes about 80% of patients which could come in the foray of treatment if you don't give this drug. More so because you've got a DFS benefit only, the OS benefit is not there. The M1 resected patients, so this was the new category which was there, the M1 NED group of patients. They were very high risk, and if the patients are very anxious and consider adjuvant therapy, then probably these are the patients which can get the best benefit and not the ones which are T3 or T4 or node positive. And we all know that 50% of the patients benefit in this group, but 50% don't. Unfortunately, in RCC, there is no biomarker at this point of time which can sift out which patients would do the best and which patients would not do the best. Meaning thereby, if you look at the finances from the Indian point of view, if you subject a patient who's already in an adjuvant setting and you inflict on him a morbidity without a biomarker and you find that 20% have to discontinue the treatment, and over and above that, you find that you can salvage another 30% of patients at a later date when they relapse. So I think it should be taken with a pinch of salt. So at this point of time, this is the data which we have. There are a lot of trials which are in the pipeline which are still going on. So if you talk of the role of adjuvant treatment in RCC, it is this trial with this immuno-oncology drugs. And I think we should wait for the overall survival to get the best benefit out of the drug. I thank you for your patient hearing.
Thank you, sir, for that succinct talk. It's very interesting, but as sir rightly said, we need to wait to put it to use in clinical practice in the adjuvant setting. As of today, there is no role for adjuvant therapy in the clinical practice. If there are any questions, we'll take the questions.
Thank you.
Thank you, sir. We'll move on to the next session.
So from the adjuvant setting, we'll be going on to the metastatic setting. And this is a panel discussion where there would be a reiteration of all the treatment paradigms which are available in the metastatic RCC. And I would request Dr. Sahu to please take over as the moderator and introduce the esteemed panelists.
Good evening, everyone, and thank you, organizers and Dr. Vineet, for extending the invitation. So may I invite the panel, Dr. Tarun Jindal, Dr. Amandeep, Dr. Ram Avinav, Dr. Prasad Narayan, and Dr. Vikram. As it is evident, we have a balanced panel which has two uro-oncologists, two medical, and we have a radiation oncologist. So I have tried to pick up topics and few questions which would involve a multidisciplinary approach. Yeah. Okay. We are missing one. Prasad is not there. Okay, that's fine. So we have a case, and let's go to the case, and for the next, can I have the timer on also? We have 40 minutes. Yeah, please. So it's a 58 years old, a clear cell RCC resected 4 years ago, no evidence of metastasis. The imaging revealed multiple pulmonary nodules, bony lesions, biopsy of the lung lesions confirmed the metastatic clear cell RCC. The creatinine was normal, other lab reports, I'll come to that, not exactly normal. And the PS was 1, mildly symptomatic for dyspnea on exertion, nothing much to tell about, otherwise really not much symptomatic. For pain, which the patient had, we gave radiotherapy for pain reduction. So this is the hemoglobin. We have a 13.2 within normal limits, a TLC borderline just touching the upper limit of normal. Neutrophilia was there. Platelets were on the upper side, and we have a corrected calcium, and which was within normal limits. So, Dr. Ram, anything more you want? through the, for this case?
That would be enough, sir.
Okay, and all of us agree that we have all moved on to the IMDC criteria and no one is using MSKCC. I presume that, and I'll skip this for the interest of the discussion. Okay, so now this I'll skip and I'll come down to, for this case, I'll come down to my surgeons. Do we need a nephrectomy or can we tell that it is now dead and we do not need a saturated nephrectomy in such cases? Can you please come in? Yeah, please.
So this case, I believe, was already operated. So this is a recurrence.
I understand. In such a case.
So cytoreductive nephrectomy per se after the Carmina trial is slightly questionable. But again, I would like to risk stratify the patient. So if it's a good risk patient, I would still be keen to offer him a nephrectomy. Not per se with the purview of a cytoreduction, but yes, a nephrectomy just to palliate the chances of him having future symptoms. But if it's an intermediate or a poor risk candidate, I would be very skeptical about offering a nephrectomy upfront.
Okay. Any change in the opinion, like say there's a risk score of 1, we see people do advocating in risk score of 1. What is your take on that and do we have evidence to back it up?
Yeah, so for good risk, there is no doubt. We can definitely consider upfront cytoreductive nephrectomy. For intermediate risk, we have an option of upfront versus deferred. But for patients who have just 1 point on the IMDC score, you can still offer them an upfront cytoreductive nephrectomy.
Okay.
See, a lot of our patients might not meet that normal hemoglobin count of 12, you know. Very routinely we find that our patients have 1 or 2 points down.
That's why I put the hemoglobin at within normal.
Exactly. But when you look at them, they are perfect surgical candidates.
Okay.
So on a case-to-case basis, some patients with intermediate risk cancer with 1 point on that score could still benefit from an upfront cytoreductive nephrectomy followed by systemic therapy.
If I play the devil's advocate, because this is the area, because for favorable, all of us agree that it should go to a multidisciplinary and saturated nephrectomy should be given as an option. That can be deferred, that's a different thing. Number 2, for the intermediate, low intermediate, let's say 1 score, do we have any data to prove that it is beneficial? Because the Carmina trial, when the data came out for the 1, also it was not in the risk group which was showing any benefit. So, and in such cases, would a uro-oncologist be comfortable with the medical oncologist giving a systemic therapy? The response is good, and then offering a deferred as the certime showed us.
Yeah, definitely. So our level 1 evidence points towards doing a deferred instead of an upfront.
Okay.
But there you might still find a patient who has that kidney mass and probably 1 lung lesion, but falls in 1 point intermediate, and you can get rid of both lesions. You can still just give the surgery, render him no evidence of disease, and he might not even require adjuvant therapy later on.
If I come to the radiation oncologist, and we had a talk on that, and there's beautiful data evolving on it. So do you want to leave this case to the uro-oncologist and not take it up with the SBRT data coming up?
Actually, no, because SBRT data is just, it's not randomized. It is just based on the trials done in certain centers. Even now, surgery would be a good option as compared to radiation.
The point I wanted to make up, and if you look at the bulk of data, I'm a medical oncologist. I would not push for a radiation oncologist to do the SBRT, but I would look at it the way that if someone is medically inoperable or does have a risk score to go for surgery, the data is quite good, now looking very promising. And I think as doctors treating uro-oncology patients, we should be also discussing, at least for the patient who are medically inoperable. That's my point which I wanted to point through. I'll just skip the slides because most of us agreed on it, but the point, it is very clear that if you look at the Carmina trial, and this is where it is, if the risk score is 1 even, there was no difference and no benefit of giving for a saturated nephrectomy in such cases. Only the favorable, there is still a point of offering saturated nephrectomy. Delayed saturated nephrectomy, I think we pointed out, and I think the panel did agree that that is an approach which most of us would agree to, and we have data, although there is, we can criticize this trial for a lot of reasons, but this is the best data we have for a delayed, and even the Carmina also had the delayed nephrectomy data which showed again the survival was better because the prognosis was good. Okay, so we'll shift gears little to oligometastatic, and then we'll go to the frank systemic disease. So in oligometastatic RCC, any one of the choices, surgery, how common do you offer surgery? If yes, whom and when? Can any one of you take it?
If it's a disease, if it's a single met or a met which is amenable to resection, I would definitely offer him a surgery.
Let's assume a case which had undergone a nephrectomy and has relapsed within 9 months. Would you still go for such patients, or would you wait for a disease which has a longer disease-free survival?
No, I couldn't get your question. So the nephrectomy has already been done.
Already been done. You have 2 mets in 1 organ or 2 organ, which you could dissect, but the relapse has happened within 6 months of your primary surgery. Does the time interval from the relapse make you decide on cases?
Yes. So if the relapse has happened, say, it's an arbitrary time duration, but if it has happened within a year of me doing a surgery, then definitely I would consider it as an aggressive disease. So rather than treating that surgically, I would rather shift him towards the
Okay. So you would still choose your oligometastatic depending upon the risk factors and the course of the disease. That's what the point is.
Yes, certainly.
Any other point, Dr. Amandeep?
Yeah, so nothing.
For oligo.
Yeah, so biology would score rather than what you can go in and resect.
Okay.
Yeah.
So I was reading a very good approach, and this is a trial for radiation. The rapport trial from the 30 patient data from MD. It's a 30 patient data, but the one thing comes out that if you have oligometastatic disease and you can do SBRT to it, it differs the systemic therapy by approximately 1.5 years. So a patient would not be bearing those toxicity and is disease free and would require a systemic therapy for 1.5 years. Are you comfortable with this approach? If it comes to a multidisciplinary, will you push for such an approach?
In fact, there are now trials to show using immunotherapy and SBRT having a combined beneficial effect.
Yeah.
So I would feel that combination of both when there is an oligometastasis would definitely add into the benefit of the patient's outcome.
So you would be more comfortable to give the SBRT and then we start with the immune checkpoint inhibitors. Okay. Dr. Ram, are you comfortable with that, or because this data, I think if it is proven and longer trial is going on, if it proves that it can delay the onset of systemic therapy and with SBRT on, it really would make a difference to a patient's life. That's what I think is going to be a point, because active surveillance is also coming in into this data of stage 4.
Yes, there are 2 aspects to it. One is, we used to think that if something is locally addressable, just address it and let the disease progress and then initiate them.
Yeah, I understand. The approach is okay.
So on the other hand, we now have, as the last speaker mentioned, we have adjuvant data. Even in high-risk RCC, you are now considering using early checkpoint inhibitors.
Okay. So you are more comfortable with that?
At least in some patients, that probably you should initiate early therapy.
Okay, on this part, I would like to conclude that oligometastatic, we have to differentiate, as the surgeons here rightly pointed out. If it's an early relapse, one would refrain from doing a surgery probably, and if it is there, radiotherapy comes in a big way, and if you can approach it and do a SBRT and do a complete SBRT, it is much better. There are 2 ways you can do it. You can follow it with the immune checkpoint, because the immune checkpoint inhibitors response is considered to be superior, but this data I think warrants something that you can defer systemic therapy, and if that can be done, I feel it just gives a good quality of life to the patient, because these drugs, what we use as medical oncologists, does have its own side effects. Okay, so now we come down to the case. We have an intermediate score. I'll put it very comfortably that there were 2 risk factors for this. So this case which we discussed was intermediate score. So coming to a medical oncologist or anyone in this in the house also, any takers for active surveillance for a patient, let's say for this case, if he would have been asymptomatic and just picked up on a routine surveillance. And do you practice? Does anyone even in this house practice active surveillance? And if yes, which are those patients who should be put into active surveillance?
Generally, this is not probably one of the patients who we would select for active surveillance. Because
so who are those patients whom you feel are candidates for active surveillance?
If a patient has a renal tumor, which is less than probably 2 centimeter, and patient is frail and old, by surgery or local therapy.
Question is metastatic disease.
Yeah, it's a metastatic.
Yeah.
I'm talking of active surveillance in a metastatic RCC.
Sahu, I'll tell you, if you listen to Dr. P.B. Desai's lecture, he used to always tell, never treat a small metastatic disease in a patient, because you will make him symptomatic. Now, if a big tumor with a small metastasis in the lady who is 76-year-old with a comorbidity, I'll just do the nephrectomy and follow her up. Okay. So they are special situations.
I think the data is evolving, and there have been 2 publications in 2020, 2021. One of 52 patients and one of a larger series of 500 odd patients. And that has been published in 2021. One good thing is coming up, and even in the ASCO educational book it has come up in 2021, very clearly mentioned that you should be choosing patients, especially for the group of 0 to 1 of the risk score. And patients who have less than equal to 2 sites of metastasis. There is an option of going for active surveillance, and patients sometimes on average do not need systemic therapy for at least 1.5 to 2 years. And even in this trial, they've seen the patients who have progressed but are still asymptomatic, they could still defer the systemic therapy for 6 months. So what I'm pointing out to the house, there is an option, and in this bigger subset of data, around 30-35% of patients were still went on without systemic therapy for approximately 2 years. So this is a concept I think all of us to evolve. Yeah, please. You first and then the panel.
Yeah, so there was an offshoot from the Carmina study, and the intermediate one, sometimes behaves like a good risk. Yeah. That was, and in those, if you have this kind of a situation, probably you can include survival.
So that's why 0 to 1 is what I told, and less than equal to 2 sites. If you take more than 2 sites or higher IMDC, the survival is much worse. Yes, please.
So, see, I understand trying to delay systemic therapy to avoid systemic toxicity, but if you have 1 or 2 meds which are amenable to local therapy either by a VATS or an SBRT, even if they are asymptomatic, would you not want to chase them and get rid of them?
SBRT is totally in. I'm not talking of that. If there is something beyond oligometastatic and which is not amenable to local treatment and patient is asymptomatic, would you offer surveillance is what the question is.
So if you cannot get rid of it locally, would you give systemic therapy is the question.
If it cannot get rid locally or asymptomatic, if we are offering it to patients of advanced disease beyond oligometastatic, I think that will be eligible even to those subset of patients. That's my take on it. Okay, so we move on and come to the real depth of what it is. All the data is known. I'll pick up 5-6 points on which we should be discussing. So, Dr. Ram, this patient can afford everything, so finance is not an issue. We'll not speak about finances. And in the intermediate stage, which is your option of your agent and why?
There's no clear answer to this. That is the first point. So if the patient is asymptomatic, which like you said, he had a bone met and it is now treated.
And you do not want active surveillance.
Correct. So I would prefer ipilimumab and nivolumab combination for these patients. This is because of we can avoid the toxicities of the tyrosine kinase inhibitor. And there's no direct comparison between all these drugs. So we cannot point out that this is better or this is better.
So let's make it more simpler. We have approvals for IO-IO combination, the Ipi-Nivo, what you told. We have approvals for 3 TKI and IO combination. We have also, we can use our sunitinib and pazopanib, which is most commonly used in spite of it not being good in the intermediate risk. So how do you choose and pick your patients is what I really want to know.
So first point, patient is not symptomatic, I would prefer double IO-IO combination.
Okay.
And when we compare the 3 drugs, Len Pembro, Axitinib Pembro and Nivo-Cabo, probably the best progression-free survival and response rates are the Pem and the Len.
Okay.
It seems to be having the best progression-free survival.
The clear data. Yeah.
And by a cross-trial comparison. That also has the highest side effects.
Okay.
Next, Nivo-Cabo, second highest progression-free survival rates, and probably in between Axitinib and the Lenvatinib. Probably the most, toxicity-wise, the most favorable drug, and by cross-trial comparison, which has among the 3 agents the least progression-free survival is pembrolizumab and Axitinib. So we'll have to choose. It is an option. It'll have to be discussed with the patient as well what they choose, because there is no straight answer to this, whether they prefer better side effects or they want to have the best response.
So you wanted to come in? No. Vineet sir, any points on this before I move on to how we choose these agents?
No, he has very rightly put. I just like to add that there's no clear-cut answer I would go more on the symptomatology of the patient. If the patient is symptomatic, you want a quick relief, then probably you will have a TKI with IO. IO plus IO you can give, but then this would be a niche situation where I would like to check the PDL1. The PDL1 is very high, then definitely this patient is going to benefit. Regarding the Cabo-Nivo, the latest data is the depth of the response, defines the final outcome. So the latest sub-stratification is PFS 1, 2, and 3. But that won't apply to this patient. So the broad delineation would be what the patient's symptomatology is and what is the PDL1.
Okay. So coming to PDL1, Dr. Talwar, is there any real data to push that PDL1 should be done, then only you choose IO? And is that being proven on a prospective basis?
No, I was just saying that if you have to choose between Ipi-Nivo versus the
so
other three,
that might help you in choosing the patient.
This would, give a rudimentary.
You wanted to say something?
Yes. Another point I wanted to make is patients with bone metastasis, cabozantinib seems to having a better control duration than the other drugs.
I think I will not be okay with this statement because on a scientific basis, the Cabosan data was not a data which I'll put it on par with these data. Lot of criticism, small data is something which I feel that's how it should be. If someone cannot really afford cabozantinib, I'll put it for a high risk or intermediate risk. If that's all, I'll do that. It is probably superior to sunitinib. That's where it will stop. The best thing about IO is what I feel is the longest follow-up. It is beyond the longest follow-up among all the four came out first. 1/3 of the patient are still progression free after 4 years. So the plateauing of the curve really comes in if you're thinking of a cure or a prolonged survival without anything. That is the IO-IO combination. That does not happen in probably the IO-TKI when you see the curve still coming down. The point number 3 is the differences is that Dr. Vineet told, if it's really symptomatic, you would want something of a good response and then a TKI IO really scores, and you clearly, Ram pointed out that the lenvatinib and the pembro, although the survival is the shortest, has shown the highest response rates. So I think that is where it is. So now we move on, and if you look at it, the negative point about IO is again the response rates. The progression of disease were around 25%. So 1/4 will progress. So in a symptomatic patient, you will not like to do this. This is what it is. The plateauing of the curve really happens in IO combination. Okay. So very important question, because except for the except for the pembro and axitinib, which had a point of 2 years, how long a patient who responds on IO, would you comfortably go on IO? Would you stop at 1 year, 2 years for everyone, or would you continue for a patient for, let's say, cabozantinib and nivolumab?
I would consider stopping the drug immunotherapy by 2 years.
So you would, by principle, stop it and consider the options after the relapse. That's
After
what
the
it
relapse.
is.
It's not by any clinical data, just that if they have a very good control, I would consider stopping and giving them a break.
Okay. Here I'd like to very clearly tell you that the trial data, except for the axitinib pembro, which stops at 2 years, there are data which really goes on continuing the IOs. But most of us and most of literature believes that 2 years is a good time where you can stop, and some of these patients might not require a drug for quite some time. Okay. A very important point, relapse. Within 1 year or within 5 months or 6 months on a combination, and relapse, late relapse. Do you differentiate your patients and do you treat them differently? Let's say a patient on an IO-TKI, pembro and axitinib fails within 6 months. How would you treat a case?
So you're asking about second line therapy?
Yeah, sure.
So there are 2 options which are currently available on this. Cabozantinib is one option, and another valid option would be lenvatinib, everolimus.
Okay.
And depends on what agent we use in the first line. If you had used pembrolizumab and axitinib, probably both are options.
Okay. Okay. So basically the data is about 3 drugs, lenva, everolimus. You told the only thing I point out is that phase 2 data. It is not a phase 3. The others are phase 3. We have axitinib data, which very few people speak about, but the data of axitinib also there in a short patient after immune checkpoint failure, and the responses were good for 45 to 50%, which is a good response rates. But cabozantinib has a very good strong data, and this has been a superior drug. So as per the data, axitinib is there, cabozantinib is there, lenvaeverolimus is there. Just because the lenvaeverolimus is toxic, is the most toxic among all these three, that's why, but people in medical oncology forum have used this combination quite, and people who use it are very comfortable. But the point is, the dose reduce it, that's something of a concern, because the data here was very different on a particular dose. So the options, what the guidelines tells you or probably push you is that take a single agent TKI, that will be lesser toxic, but if you are comfortable lenvaeverolimus, you can do that. Also one more agent which you can choose is the lenvatinib with pembrolizumab combination. That data is also there in immune checkpoint failure. That is also a very active regimen. Any talk on the HIF-2 alpha inhibitors? No? Okay, just a point here. If you look at it across trials, this is a data which has a very promising, and this data is probably going to mature with lot of the combinations in next 1 to 2 years. You're going to see lot of this data coming up. Whatever data we have looks that this drug will probably occupy a space in the second or third line or fourth line. This is there to come, and that is what it is. The response rates are decent, 25%, but the prior immune checkpoint was around 80% or more. That is something because we have lesser data on drugs after immune checkpoint inhibitors. And the lot of this data which is coming with the HIF-2 alpha inhibitors are with this combination. Any comment on this? IO-IO combination after frontline IO?
We can
Means
consider.
after a Nivo failure, I would like to go for a Nivo EP.
Yes. So there is data that after using single agent therapy, probably adding ipilimumab might actually be.
Have you done that?
I've done for one patient.
And are you happy?
I'm not happy.
Vinesh sir, what is your take on it? Would you offer it to your patients on a nivolumab progressed within 6 months to add the another IO, a CTL4, let's say, and see what it is there?
More than 1 year, yes. 6 months, I would be
Very short time.
skeptical.
Okay. There are 3 trials actually, and all of these were published nearly the same time, 19 to 2020. The problem is that the response rate are a dismal single digits to upper 10 to 12%, and the CRs are absent. And this is not a very active regimen. That's why it does not come very up in the recommendation. You can do it for the one-off patient, but it is not actually very much in a popular regimen because the activity has been very, very poor. So for third line, you have, because all of us are, the patients are getting fitter, they're getting better, they're also coming to us with deep pockets. So there's a lot of money left even after 2 lines. So now see what is the third line. What do you think? You have failed IO, axitinib, you have failed cabozantinib. What would you do now?
So whichever drug is remaining.
Please tell me that drug.
Tivozanib is one drug which you never use. If axitinib and cabozantinib, lenvatinib, everolimus can be used. Or you can consider re-challenging.
Len and Eve.
So actually there are, the TiVo3 is what you spoke about. That is probably the best data as of now, the number of the patients, and even it is active post-immune checkpoint inhibitor failures. There is also the everolimus and lenvatinib combination. That's also data on sorafenib. But I think few of our patients, less than 20%, 30% would be eligible for this third line. Otherwise people are not that eligible. Just last question, because I know we have been cut short by 10 minutes, but I will take this as a last minute, because I want to finish what Dr. Vineet started. Adjuvant therapy, Ram, are you convinced about the Pembro data? Would you give it to your T4 or N1 patients?
I would probably consider for T4 and N1 disease.
Let me play the devil's advocate.
But it is not for all patients.
No, I want to tell you, you don't have a mature OS data, point number 1. The PFS, if you look at the extract, is exactly the same PFS. It is hazards 0.68. You have both the drugs as the hazard same. There is no OS survival data. You are giving 1 year of immune checkpoint inhibitors. You don't know what to do after the failure if the patient fails. So in such a setting, would you be convinced to give this patient at this point, or would you still wait till the OS data is mature and wait and then give it, because you don't know what is going to happen if they fail after the IO?
Yes, I would still stick to that. If it is T4 and N1 disease, I would not still worry about what I would give after they fail on immunotherapy. Rather, I would try to maximize the disease control in the first place.
Okay.
And then, if the patient relapses, then I would think about what needs to be done.
I'll stop. Yeah, you want to say something? Then I'll stop.
I think best subset would be
M1 disease. But that only had 5% of patients in the subset. So I end here with a thought, which is my thought. I am not putting up across to the panel. The STRAC, if you look at it as a pure data looking part, 0.68, 0.67. That's the data on the PFS. Although we cannot compare both the drugs because immune checkpoint are much more active, all of us know. But the problem to me looks like the OS data is still not mature. The problem to me looks like more after what happens if the OS data is just marginally significant and patient fails. What is the drug? Because the data which is there, that there is nothing much to do after IO fails. You have just left with 1 or 2 TKIs. So with that thought, I will just end my session and just think of that advanced RCC is just not a medical oncologist forum. It is going to be a multidisciplinary. I feel gradually the bulk of data is coming from the radiation oncology and their role is going to increase. We need more aggressive radiation oncologists in the panel. SBRTs are going to increase in the future. Surgeons will be there. Let Carmina, let Sartime tell anything, but surgeons will be there in the advanced RCC also. But still, I feel it will be a medical oncologist home run when it comes to advanced RCC. Thank you. Sir.
Biomarkers would be a key later on if we find...
Definitely, sir. Anytime we find a biomarker, nothing like it. Once the biomarker is in, as in lung cancer, we change things, we are going to change in RCC also. Thank you. Yes, sir. Sir. Sir, please.
IVC thrombus or renal vein thrombus, they have resected it out. Even in those cases, don't you feel adjuvant may be beneficial?
The question sir is asking is if there is a thrombus which the surgeon could really resect and that we take care is the R0 resection, a tumor thrombus is taken away, would you give immune checkpoint inhibitor? Ram.
For high-risk patients, I would generally prefer...
The question is very clear. You define the high risk here.
So IVC thrombus, which is completely resected, will be an R0 resection. I would consider it as a high-risk disease.
Okay, I would still be skeptical because of the reasons I told you, but I think he has a point. But as per the criteria which I remember for the keynote trial, they did not have this criteria as any of the risks. They either had T2 or any one of the other risk factors which they told, or T4, N1 or M1 as I told you. These were the criteria which they put up as high risk. So, but yes, tumor thrombus, I'm not sure, sir. I'm not sure. Anyone in the house, if they can tell something about it. But I'll be still skeptical of adjuvant immune checkpoint from the point of the OS data is still immature. Thank you. Thank you, sir. Thank you, panelists, and thank you, organizers. Thank you.
Thank you. We come to the next presentation. The chairpersons are the same. Radiation Technology as an Enabler in Precision Medicine, Present and Future by Dr. B.S. Ajay Kumar. Dr. Ajay Kumar is radiation and medical oncologist, executive chairman of HCG Enterprises. Chairperson same hai matlab. Dr. Lakshman Prabhu, Dr. Saurabh Vashishta. Sir, आप बैठ जाइए. I think I invite Dr. Sudhir Raval sir as the chairperson for this session. And Dr. Ganesh Gopal Krishnan as the chairperson.
Just to introduce Dr. Ajay Kumar, he is though a doctor turned entrepreneur. I have had the long relationship with him since way back before 2007, and when actually the SCG was a different hospital. His chain of hospital has grown like anything. He is primarily radiotherapist, and he is very keen on developing cancer care in the country. And he had hospital in Delhi, which is now closed. Then he's making another in Gurugram. So, and he worked in MD Anderson way back when he was actually a radiation oncologist. And then he came back to India and he started this hospital with the chain of the hospital. And he's going to talk about precision radiation technology as an enabler in precision medicine present and future. Dr. Ajay Kumar, please.
Thank you, Rahul. Thanks for the introduction and thanks for having me here. And I hear it's been a very good conference and congratulations to the whole team. When you look at, first of all, as a 45 years in oncology, I always like to start saying that I am not an expert in oncology. When you look at the way oncology has progressed over the years, we talk about at one time radical surgeries were done. I know even in urology, we know how radical surgeries were done across. And speaking of general surgeries, mastectomies, colostomy, laryngectomies, from that day we have now come to targeted surgeries. And also when you look at radiation or medical oncology, everything is becoming targeted. Less you do, better it is. So particularly in radiation oncology, now we have, when we started radiation oncology, even in India in early 2000, cobalt was widely used. And you all know it was treating more normal tissue than tumor sometimes. And a lot of side effects, and worldwide, as evolution happened into radiation oncology, precision oncology, how do you target? Today we are not only talking about highly precision radiation oncology targeted, but we are also talking about technology inculcated with genomics, and how we look at future is really how quickly we can treat, how fast, so that precision, only the tumor is treated and normal tissue is not. And this is the crux of any radiation oncology. What is the dream ticket for radiation oncologists is give maximum dose to the tumor and zero or no dose or very minimal to the surrounding tissue. If you can achieve that, of course, radiation becomes the state of the art. And that is why today we use the terminology such as radiosurgery, hypofractionation. As you all know, in the past, we use radiation, even now traditionally we use for 25 fractions, 30 fractions, 35 fractions boost. Why was this done? Because we thought normal tissue is also getting hit and the normal tissues should recover. And in the process, obviously some of the cancer cells also recover, and that is why we have never been able to achieve the type of end goal we want in radiation oncology. But with the advent of IMRT, of course proton therapy has been there for a long time, and I won't be discussing much about it except to say proton has been very useful, but it's a huge machine where the Bragg peak exit and entry dose is not there, but it has limited uses even as of now. But fortunately, alternatives have developed, which I will discuss a few things today, whereby we can equally achieve the same goal. And when we look at adoptive therapy, when you look at flash therapy, all of that, in a matter of days or even seconds, we can deliver the treatment and achieve the same outcome without affecting the normal tissue. Take, for example, prostate. When I started my training of prostate cancer, we used to see so many side effects, bladder, rectum. So patients actually were more concerned about the side effects and the treatment. So there were a lot of protocols on neutron beam therapy. So many protocols were done to give maximum dose to the prostate whenever. But today, with the advent of precision radiation, IGRT, now SBRT and all, hardly any patients get any side effects. In fact, in our system, if anybody gets any side effects, we audit to see why the side effect came. So it is expected to be zero side effects, and even the exit dose is very minimal, particularly you use a technology such as cyber knife and all. So that is how we have managed, and along with that has come digital. For example, digital PET scans, precision planning, centralized. I will just run through some slides to show how this is going to just give you a glimpse of what is happening and what can happen in future. Obviously, there won't be much details except to show, this is showing how radiation has evolved over the years, and how today, one of the things we are doing is how adaptive radiotherapy. What that means is every day I can monitor the tumor. using AI, which is not just future, which is happening now, which will happen even in a few months in our own HCG, where we can know what the tumor is responding. Accordingly, we can shrink the tumor, we can increase, or we can even reduce the dose depending on how quickly the response happens. This will be the future research of, one is radio sensitivity index. What that means is all tumors don't require the same dose in all human beings. And we don't know even the Indian genomics. Whatever protocol we use today is all Caucasian protocols. So when we look at Indians and when we look at the genomics of the Indians and tie it up to the response, in future, what will happen is the dose of radiation may become less on individual. So individually targeted. For example, in targeted chemotherapy and all, we use certain dose for certain height and weight. Similarly, based on the genomics, what we call as RSI, in future, we will be looking at that kind of treatment, and that is a protocol we are all very excited about. For example, a prostate cancer in person A may require only 3,000. They can go into remission and they can have equally good result, outcome, whereas if somebody may require full 7,000. So this is how we will differentiate based on the genomic indicators using the microarray system. So we all know tomotherapy has evolved, lot of things have happened in the last 10 years, and Radius Act where highly precision and planning has been delivered. And for one of the things I want to take a minute talk about is the evolution of, say radio surgery with cyberknife, where it is so precise in our own experience in the last 10 years, hardly any side effect occurs, and even a disease like prostate can be treated by 2 or 3 fractions, radiosurgery. And we have to now evaluate, there has been a lot of reports where the outcome will be the same, particularly in early stage prostate cancer, with can it be given, particularly in certain individuals, low grade, where we may be able to get similar outcome without going through major surgeries or major radiation. The idea will be to do a randomized trial between the two to see whether there are equally good results when you compare apple for apple. This is again showing some of the how complicated treatment planning could be, how precision. So in future, as we move towards this, it will be more and more precision. What that means is less and less normal tissue and more of the tumor only, and managing the exit dose entry. So that is why what we do today is do a centralized planning. So there is clarity, there is efficiency in the planning. All the patients are getting the same amount of expertise, whether they are located in Nasik, Bangalore or Delhi or Cuttack, doesn't matter. So this is how, using cloud technology, we are able to bring about precision medicine. This is again, as I mentioned, how artificial intelligence can be used. So we start collecting data for our Indian population. In the past, what happened? We never collected data. The problem in the Indian cohort has always been we never collect data for various reasons. To get data, follow-up data has always been difficult. But with the advent of EMR, the advent of digital health, now we are able to collect data online, live. That kind of data is going to help us in the future to tailor-make what should be the right treatment for somebody, and again monitor the side effects. So one of the things I want to say here, take-home message is, there should be zero tolerance of side effects. They should be nil. If a person develops any side effects, the obvious reasons is it technical, is it geographical, or is it the tumor biology, which is very rare? So we need to assess what is happening, why the response is not happening, or why the side effect is coming. So this is to show how adaptive therapy can be done with precision, where the exit dose is minimal and personalized, and it is AI driven. What that means, as I collect data for an individual, it will automatically contour differently as we go forward. So based on that patient and future patients are also, tumor volume is done, treatment planning is done accordingly. So it's an ongoing AI system which we are all excited about as we move forward. And of course, usual CT planning, PETS planning will all been. One of the hallmarks of future, and future is here now, is to make sure there is efficiency in the system but centralized planning. cloud-based, whereby same experts across, for every patient across. For example, in HCG, we do about 3,000 patients treatment every day. All the 3,000, except maybe few exceptions, are planned centrally. And this kind of centralized planning is true adaptive therapy in a way where we know what is happening, what are the side effects, what is the response also to the therapy. Based on that AI form, we can calculate and see the algorithms to see what should be the right treatment as we go forward. And of course, it has other reliability and also the cost reduction and performance. All of this can be watched. And another, of course, is the radiation. As we do radiosurgery, we begin to see what we call as episcopal effect, where radiation, when you treat a particular tumor, surrounding lymph nodes also regress. And this also combined with rad immune therapy, immunotherapy becoming hot issue now, particularly like renal cell carcinoma, to some extent prostate, where we are looking at also where PD-L1 has been positive in a lot of our patients, BRCA being positive. I think these people will respond differently with rad immune therapy and can get more definitive. So this kind of individualized treatment is what is going to be the future. And another idea where I want to throw in here is the radionomics. When you look at actually a patient, let us say with prostate cancer, MRI, PET scan, or a PSMA scan, and look at even the metastatic disease, one of the things we should really look at is the matrix of this mathematical calculation, whereby just looking at this, we may be able to say, this is an aggressive tumor or this is not an aggressive tumor. So based on that, along with the adaptive therapy, along with the genomics, we may be able to, and methylation studies, we may be able to say what kind of treatment should be given for what kind of patients, even with the prostate cancer or neuroendocrine component in a prostate cancer, grading, or renal cell carcinoma. For example, we all know, nephron sparing radiation can be done, radiosurgery. These are all the exciting things for the future. So this again to show decision support system, how machine learning, I know we talk about future, the future is now, can be initiated, and we are very proud to say we have initiated some of these ongoing basis to look at who requires what treatment and assess the response. The data becomes the key here. For us to collect the data which we were lacking in the past is really the future as we go forward. And the last one is really what I mentioned, flash therapy. Flash therapy is in progress. All of our units can be incorporated with the software to flash therapy. If that is done, which will be in near future, with or without proton, I think it will be a giant step in the forward, where the patient can come, lie down for seconds and be done with the treatment. No more 5 weeks, 3 days or any treatment. So flash therapy could be the future, where we can use phenomenally high dose in a matter of seconds and get phenomenally good response at the targeted level. So it could be good for any kind of cancer. Neurologically, of course, it can make a big difference how we treat prostate. I mentioned about the genomic driven treatment. I just wanted to show this, how gene sequencing and we do TSF 500, how we can analyze, and based on that, how we can decide who is radio resistant, who is radio sensitive, and how much dose to give, when to add drugs along with it, targeted drugs, when not to add. All of this can be decided on an individual basis. All of this really leads to value-based healthcare. Obviously, patient outcome is the most important. Going forward, one of the requests we have, and we think all centers should do, is to measure their outcome. Why does a patient come to institution? Because they think that is the best outcome. So we have to measure the outcome, whether it is urological, head and neck, breast, doesn't matter, and publish those outcomes as we go forward, as an inter-institutional study or as each individual institution we have to do. Again, virtual hospitals, tumor boards are the future. And I think this is how future will look as we go forward. With these few things, and of course research and research academics are very important. Today we always talk about we are a private institution, we are academic, we are research. All of that is out of the door now. You have to be private, public, doesn't matter. And I have written a lot of articles about there's no difference between private, for-profit or non-profit. It is really comes down to how deeply you are involved in research, how deeply you are involved in academics, so that you could do the right thing for the patient at the right time. So research academic ecosystem, driving outcomes and making sure these are published at the right places. So India has a great opportunity today to really look at becoming a leader in the world. And one of the things we have to do, when we can run various institutions in the world, we as oncologists, I think getting into research, planning and publishing at a global level will certainly put us in the map. And we are damn good doctors, we treat the patient well, but we lack in collecting the research, and that is the future for oncology for India if you do the research and academic work. Thank you very much for giving me this opportunity. Thanks a lot.
Thank you very much, Dr. Che. I don't think anybody would disagree with whatever you have said today. And as you were talking, my mind goes back to many, many years ago when radiation was using cobalt, and we used to see patients coming with all the complications related to the bladder. And now I think if we take an opinion poll from all the urologists sitting here, they will say that the number of patients with problems related to their bladders as a consequence of therapy that you're talking about is very minuscule. So obviously there's a huge progress in this, and I think ultimately as a community, surgeons, oncologists, radiation therapists, we all need to sit together and decide that where we as surgeons stop using the knife and use something better for the sake of the patient, and what you said, is absolutely paramount. And I think that the future is going to be phenomenal for the patients who are going to have cancer with this multidisciplinary approach. So thank you very much for this wonderful insight into what's the future holding for us.
Thank you very much. Thanks for it.
Thank you. We go to the next session. I invite the chairperson, Dr. Bharat Rangarajan. The first speaker in this session is Dr. T.B. Yuraja. The topic is genetic testing in prostate cancer, why it is important not to miss these mutations. Dr. Yuraja is professor and head robotic surgery, uro-oncology at KDH, Mumbai.
Thank you, Ganesh. Good evening to all of you. When Raghu gave this topic, I was just wondering whether I am capable of doing justice to this topic. But nonetheless, I think many of medical oncologists there, Dr. Amit is there, so he will give more information on this. So before going to this topic, I thought, so let us just revise our knowledge on genetics. We know that little off subject for surgeons. So let us see some definitions. So genetics is a general term. There are specific terms, terminology, but we use it so many terminologies here. It is a study of genes, genetic variation and their role in inheritance. However, when the word is used as genetic testing, it is used only for inherited mutations in healthy cells. In other words, any cell of our body, if you take, that will be a positive for genetic test. So the word genetic test has been used extensively across, but actually the actual meaning is only for inherited mutations. Whereas the word genomics is a new term where we study persons, the entire genome, interaction with these genes with each other, like cancer and diabetes. So when I say this genomic study, generally we identify we can identify even the single gene or even a multiple gene. So that is the current definition. And we also see there are two types of mutations happens with us. One is germline mutation, as I told you earlier, mutation in the gametes transferred to the offspring. But only thing is that again, as I told you, starting from buccal mucosa to the blood, any cell will give us some result. Whereas somatic mutation happens only after fertilization. That means only the affected part is tested and it is positive. That means somebody says somatic mutation, it is always acquired, it is not inherited. So when we say whole genomic sequencing, so we test around 20,000 genes at once. That means we are capable of doing, because thanks to the current the computerized testing, so we can identify any mutations in our body. But however, we know that in cancer, the cause of cancer is around 150 genes. across cancer. And to be specific, in prostate cancer only we have defined 15 genes. So that is how we have to understand what we are testing. We are testing generally. So when we say it is a 15 genes, these are all generally acquired genes, so they are all somatic mutations. When you see this picture, we get confused. So a lot of things going on here, background theoretical knowledge, but this is the cause of cancer. These are the pathways, but these are the hallmarks of cancer. All this resistant to cell death, inducing angiogenesis as a result of genetic mutation in cancer cells. So our job is to identify them. So as a cause of cancer, we have 4 classes of genes: proto-oncogenes, tumor suppressor genes, DNA repair genes, programmed cell death. Any one of these genes undergo mutation, it causes cancer or genetic disease. So we are interested mainly in DNA repair genes in prostate cancer. When you see here, so there are so many pathways, as I told you, but we are interested in DNA repair genes, that is BRCA1 and BRCA2. Mutation in BRCA1, BRCA2 are all somatic mutation in cancer cells. And usually this is associated with prostate cancer. So in prostate cancer, and as we told, it is a DNA repair genes. So suppose if you just recollect your knowledge on DNA, so there are many things happens. So one is that single strand break. One is the break in the single strand or a double strand break. And then we have the additional mismatch, base mismatch, as well as bulky edits. These are not very important for us. We are interested in single base as well as double strand break. But whenever this happens in a normal cell, the DDR gene, that is DNA damage response pathways activated, and then the cell will be repaired on its own. But when there is a mutation in these genes, so that the cell cannot repair on its own, so that's how we are targeting this gene. So that is how the knowledge why we have to do this gene test. So if you see here, then attempted DNA repair by single strand break in the response of PARP inhibitor resulting in DSB. Otherwise, so normally it gets cell survival because the PARP pathways so get activated and they get repaired themselves. But in the cancer, if there is a genetic defect, then it will cause cell death. So that is the reason we are going to inhibit that, so to prevent, to cause cancer cell death. So dysfunctionality of one of the DDR pathway is vulnerable, and synthetic is a lethality approach. So normal function cell, PARP helps. Loss by one gene, PARP helps, but if it is a BRCA1 and PARP, both are damaged, then only we will get the results. You can say cell death. Otherwise, you have to inhibit both of them. So when we see these PARP inhibitors, so generally, so the incidence is very less according to the literature, but recent literature shows in a different way. I will just show you. These are the BRCA1, BRCA2 mutations, and these mutations are there both somatic as well as germline. Germline mutation, if it happens with BRCA1, BRCA2, it is a hereditary prostate cancer. If it happens in a somatic way, so usually double attack will be there. If the patient has got a germline also with one parent and an additional another attack in the later in the age. So we get prostate cancer, colon cancer, and breast cancer. So HRR pathway is the major mechanism for detecting and repairing the DNA, and any HRR mutation. HRR pathway is a normal pathway. If there is any mutation, so then we have to block it. So PARP inhibitor came as one of the agent to treat metastatic prostate cancer. So it is a it is a HRR gene inhibitor. So if you see here, so there are 15 genes here, out of which BRCA1, BRCA2, and to certain extent ATM mutations are taken care of. So why test for genetic alteration? Because to detect the familial risk of cancer. And then we know that if there is a mutation, this patient don't do well. And then we also, it indicates an aggressive disease. And genetics also say that it is a marker for PARP inhibitors. And tumors can develop in the context of germline or somatic gene alteration. Remember that even in a germline mutation, you can get a tumor. As I told you, one hit and double hit. So one hit will be the genetic one, and the other one is somatic hit, and both of them it happens. Then the patient gets cancer tumors. Then what are the options of genetic testing in prostate cancer, which we never heard as our students. When we learned it, genetic test is only just a short note. But now we are using it for the patient. that is really a major advance which has taken place in prostate cancer. What we can do tissue testing, you can see here, and then we can do whole body testing. When we do tissue testing, you can either detect germline as well as somatic, but in whole blood testing, the blood testing is usually for germline, whereas circulating DNA is for somatic. So there are 3 samples which we can use: tissue, blood, and a circulating DNA. So if you see here, so this is how it happens. So these are the tissue blood cells, and blood cells are usually for germline, whereas the circulating DNA, when we identify it, is for somatic testing. And different testing strategies: tissue tumor testing, which is with a fresh tissue or usually paraffin blocks, highly sensitive, or we can do germline mutation with a blood. So the both primary and metastatic tumor samples, it may be a primary or it may be, because it shows the same pathways or same mutations. So primary tumor or a metastatic tumor, it remains stable even when the disease spreads in the different organs. BRCA2 is the most common HRR mutation which happens. So almost 50% are derived from germline origin. Origin is from germline. And if you see here, so we are seeing almost BRCA1, BRCA2 positivity tune of 10 to 12% in Western population. But in our population, we have started testing this in the last 2 years, but positivity rate is only 1 to 2%. Classification criteria: when the test report comes, we have this type of reporting, either pathogenic, indicating that this is the cause of the cancer, and non-pathogenic or uncertain. So this is how we get the report. Factors affecting selection of testing algorithm. So adequacy of the sample is very important. We have to get a good fresh paraffin blocks. So that is the reason at the diagnosis of metastatic prostate cancer, when you do histopathology, so we always get a test done, because when the blocks become old, then the quality of the blocks will not be good. So we will be unable to do somatic mutation study. So this profound study, which checked the BRCA1, BRCA2 or a PARP inhibitor. So that PARP inhibitor, what we use is olaparib versus physician choice. So they did a randomized trial, and let me go to directly to the endpoint. It met a primary endpoint that significantly improved progression-free survival by BICR in patients with alteration with BRCA1, BRCA2. You can say significantly. So almost to the tune of 6 months difference in survival with this medicine. And this is a oral molecule given in the dose of 600 milligram BD. And then, as I told you, so in Western population, so now they are testing along with BRCA1, BRCA2, ATM, CDK and PP2, and almost 27% incidence in these type of mutations. So in these patients, even in a profound study, so they did a circulating, the circulating DNA was not a part of this study, but later on, retrospectively, they studied value of circulating DNA, because they were unable to get the tissue blocks from various patients, and it shows promising results. Now, even a circulating DNA is a promising test where we do it routinely for our patients. As I told you, just to remember, 15 gene panel of HRR. So usually main important are BRCA1, BRCA2 and ATM, and others are, you can make out there are other almost 12 genes. So even a olaparib in patients with alteration genes is got a very high activity. The question is that whether we have to do for everyone, we have to do for everyone, because that knowledge has to be there. And then as the disease progresses, so that then you can have different sample from metastatic sites. Only thing is that the tissue from the bone will not be useful for us, because it doesn't show, it is very difficult to extract DNA from bone metastasis. So HRR gene alteration in primary and metastatic tumor is almost the same. So the algorithm is that get a tissue block, get it done. If you don't have, then you go for a circulating DNA. Avoid using any blood for germline mutation at this level. So this is what we generally practice in clinical setting. So thanks to the company AstraZeneca, which is marketing olaparib, they do this testing free of cost. Otherwise, if you want to get it done, it is around 17,000 to 20,000 rupees for the patient. But generally, it is covered by them, so they do free of cost and for every patient. So the NCCN recommendation added genetic test into that protocol, and any patient with a tumor, so they consider tumor testing for HRR mutations, as well as in metastatic, even in a regional mets or even a metastatic setting. In both settings, all patients should undergo genetic testing. So thank you very much for your patient hearing.
Thanks, sir. That was really a wonderful talk, because I think a very, very complex topic has been broken into small bits. Very, very understandable. I think a very difficult topic presented extremely simply, covering every aspect of genetic testing. So I'll just add a question. In your practice, are you, you're of course practicing in a high-income hospital. Are you testing everybody for somatic mutations? Are you testing everybody for germline mutations? And what would you recommend for, low middle income sort of patient population?
No, as of now, if the patient can afford, then only we do it. But we advise for everyone with metastatic prostate cancer, at the time of diagnosis, get the test done. Generally, I'm not doing for N1 disease. For metastatic hormone sensitive prostate cancer, we are doing it. So generally, out of the, if it is outside this company, then it is around 18,000 rupees, they can afford it. And otherwise, routinely we have started doing it. So now we are collecting the data, where are we? But I think we might have done till now. So recently we started in an aggressive, but I think around 30-35 patients, only 2 patients are positive. The question is that, so we are wasting that amount of money, only 2 patients are positive, and whether these people can afford this molecule. Molecule is very expensive. So that is the reason, so we are a little bit skeptical. Thanks to, so even, there are other molecules which are coming up with based on genetic alterations.
So I think we are moving towards testing slowly but surely. One question from the audience, if there is any, otherwise we'll move on to the next session for lack of time. Yes, there is a question.
Thank you, sir, for that wonderful talk. So how would that information benefit you? You are going to wait till these people become castrate resistant and then give Lynparza?
So now there are 2 trials. They are going to add this molecule even before that. Okay. So in future it is going to be useful for that patient, because otherwise you have to undergo repeat biopsy to get that information. Yes. So when you have this thing sample with you, you just get the test done and keep it like that. Okay. Like that's the reason.
Thank you.
Thank you very much, sir.
Thank you.
For want of time, I'm sure there are many more questions, but want of time, we will move quickly to the next session. The next session is on immunotherapy in advanced and metastatic urothelial carcinoma. The talk will be by Dr. Mohammad Nasir, who's a senior medical oncologist with special interest in immuno-oncology. He hails from Bangalore, and he will take us through a very important and upcoming topic of immunotherapy in urothelial carcinomas.
Thank you, sir. Thank you for such a nice introduction, and thanks for having me here. My topic of today's presentation is a newer paradigm in the management of advanced urothelial carcinoma. Now, after radiation, after surgery, if the patient has a metastatic disease, then there is a significant role of PD-L1 inhibitors in the management of urothelial carcinoma, and this is what I'm going to cover in the subsequent slides here. So this is the disclaimer by MSD, and talking about the epidemiology of urothelial cancer, it is the 10th most common cancer and 13th leading cause of cancer-related deaths. So mortality, it stands around 13th in both the sexes worldwide, according to the 2020 data. The ratio of the mortality to incidence is approximately 0.37. So if we see where it is more common with respect to incidence and mortality, in the pie chart we can see that Asia, the incidence is about 36%, whereas in Europe it is about 35%. And the incidence in North America is 16%. So in Asia it is almost 36%. And mortality wise also, with respect to number of cases, the mortality rate is also high. In Asia with 42%, and in Europe it is 32%. So globally, with respect to predominance in males and females, it is 4 times more common in men than in women. And the incidence of bladder cancer in between up to 74 years is highest in Southern Europe. whereas in Oceania, the risk is relatively less. That is what we can see in the pie chart. So coming to the Indian data, it is the 17th most common cancer diagnosed, and among the leading causes of cancer-related death, it stands 21st. So in both the sexes, in all ages. So one of the study by Mishra and Balasubramaniam, in which a population-based cancer registry graph, which you can see here, the incidence and mortality rate in India was discussed. So this is the incidence rate in the major metropolitan cities in India as well as other cities. Delhi stands with the highest incidence of 7.4 per 1 lakh patients, and the mortality is also 1.7. Whereas Mumbai stands second with Mumbai stands third with 4.1. Kolkata is 4. Thiruvananthapuram almost 4.9. So other major incident states are cities are Mizoram. Bangalore has an incidence of 2.4 with a mortality of 1.0. Chennai and Bhopal equally have 3 each. So this is the incidence rate which we see, which we have seen in our population-based cancer registry. And in one of the study where they saw the projected number of cases which are going to be seen in another 10 years, like 2025. We can see that from 2016 onwards, 16 to 2020, there has been a progressive increase in the number of cases. So start with like almost 18,472 cases in men and 4,853 in women. So it has gradually been cumulative. So if you see in 2020, there are almost 20,000 cases in men, and women there were 5,000 cases. So cumulatively, if you see, it is going to increase in 2025 with almost 23,000 and odd cases in men and 6,000 in women. So, so this projected number says that the number of cases are going to increase in future. So, talking about the staging, disease biology and prognostic factors, this slide might have been discussed in the earlier sessions also. So, we have 3 major divisions in urothelial cancer. The first one is a very early non-muscle invasive cancer. The second one is muscle invasive, and third one is a metastatic disease. So in the muscle invasive, non-muscle invasive, the tumor is confined just to lamina propria up till T1, whereas in the muscle invasive there is involvement of superficial or deep muscle, and going beyond outer muscle involving the perivesical tissue. In metastatic disease, it involves the adjacent tissues or the organs. So this is with respect to the primary tumor site. And the grading was grade 1, grade 2, grade 3, which has been modified by WHO in 2004 to PUNLMP, which stands for papillary urothelial neoplasm of low malignant potential. So most of the non-muscle invasive are neoplasms of low malignant potential, whereas majority non-muscle invasive and some of the muscle invasive cancers are of low malignant potential. So according to the latest criteria, it is either low grade or high grade or PUNLMP. So with respect to prognosis and stage-wise survival rates, we can see the bar graph that in situ cancer has a highest the 5-year survival rate, whereas localized disease has a survival of about 70%, whereas regional disease, when it involves the lymph nodes, it is about 37.5%, whereas distant metastatic disease, the 5-year survival falls to a very dismal number of 6.4%. So we can see a sudden drastic fall in the 5-year survival as the cancer progresses when it becomes advanced or metastatic. In the non-muscle invasive bladder cancer, the prognosis depends upon how frequent it is recurring or how it progresses to muscle invasive bladder cancer. And most of the 75% of the cases, they present with initially non-muscle invasive disease. In Europe, according to the age standardized survival rate in the bladder cancer, it is approximately 70%. And in the US, the 5-year survival rate has increased from 4 decades, for the past 4 decades, from 72 to almost 79%. So what are the different treatment modalities with respect to management of the disease? In the non-muscle invasive disease, which is an early disease, if the operating surgeon feels it's a suspected low-risk tumor, an immediate installation of intravesical chemotherapy after tuberty is advised. And post-surgery histopathologically, if it is a low-risk disease, then we go for cystoscopic surveillance. Intermediate risk disease, depending on the size and the grade, we go for surveillance as well as intravesical installation of BCG for 12 months. If it's a high-risk disease, then we go for surveillance plus intravesical installation of 36 months of BCG. And in very high-risk disease, or if it is BCG unresponsive, we can offer radical cystectomy. Whereas in muscle-invasive disease, where there is more role of medical oncology, and the patients, if they are unfit for cisplatin-based chemotherapy, which could be because of the comorbidities, radical cystectomy with pelvic lymphadenectomy is the offered treatment. But if they do not want to go for cystectomy, then we can offer the multimodality therapy of CTRT and followed by immunotherapy maintenance. For the fit patients who can tolerate chemotherapy, we go for systemic chemotherapy followed by cisplat, followed by either surgery or CTRT. So this is one more slide talking about systemic treatment options. So in the muscle non-invasive, we have intravesical treatment. We can go for BCG, mitomycin, or intravesical gemcitabine, docetaxel, and then maintenance pembrolizumab. Or in the muscle invasive or locally advanced or metastatic disease, the first line is systemic chemotherapy with cisplatin being the first choice. If the patient is cisplatin ineligible, we go for carboplatin and gemcitabine. If the patient is platin ineligible in himself or herself, then we go for systemic immunotherapy, which is pembrolizumab or atezolizumab if they are PD-L1 positive. There is a concept of switch maintenance after giving systemic chemotherapy in a metastatic disease. If there is a very good response to platinum-based therapy, then one can go for maintenance avelumab. And if there is a progression on the above-mentioned first-line disease, then we can go for immune checkpoint inhibitors in the second line, which is pembrolizumab, nivolumab, atezolizumab. There is a targeted therapy, especially for FGFR alterations, which is erdafitinib. Presently, this drug is not available in India. And if it goes beyond this, beyond second line, then we have an antibody, N4 tumor vedotin, which is used in the second and subsequent lines of therapy. So what are the prognostic factors in the second line therapy? There was a study in Journal of Clinical Oncology published in 2010. They identified pre-treatment prognostic factors for overall survival in the second line patients. They had 4 subgroups depending on the presence or absence of the prognostic factors, which was either anemia less than 10, liver involvement present or absent, and ECOG performance status more than 1. Depending on the risk factors, they were categorized as risk 0, 1, 2, 3. And we can see that the median overall survival reduced from risk factor 0 of having 11.5 months to almost 2.4 months in risk 3 group. So more the risk factors, the prognosis is going to be not good. Then there was in the earlier era, about 20 years back, there were many non-randomized chemotherapy trials when the patient progressed on the primary modality of treatment. So many drugs were used, starting from taxane, docetaxel, paclitaxel, nab-paclitaxel, cabazitaxel, and then vinflunin is one drug which is effective in bladder cancer. Then there is gemcitabine, pemetrexate. These were the single agents which were used, and there were a combination of drugs are also used with docetaxel, nifosamide, paclitaxel, and gemcitabine. So the inference of this slide is that all these were done in a difficult setting and they were not properly randomized, and multiple undersized single agent studies were of scarce success, and the overall response rate was very less, 0 to 28%, and the overall survival was just around 7 to 8 months, and all of them had a very poor outcomes. And then there were randomized trials where the clinical benefit, overall response rate, progression-free survival, and overall survival was assessed. So the randomization arms were like combination chemotherapy, either 2 weekly or 3 weekly, and then there was a study with vinflunin and best supportive care. This study brought into the role of systemic chemotherapy having an advantage in PFS and overall survival. Then there was a study which tested cabazitaxel and vinflunin. Then there was a study by nab-paclitaxel comparing paclitaxel. So there were a combination of studies also, like docetaxel, vendatinib, docetaxel, ramucirumab. So all these are combination of systemic chemotherapy with targeted therapy, which had a control arm of systemic chemotherapy only. So most of them had not a very great progression-free survival, and the overall survival was not significant. So we can see in the right-hand side of the slide, almost all the studies had overall survival which is not very significant. So it's just a general overview of the second-line setting. In the old era, we were using single-agent cytotoxic chemotherapy. Taxanes were more commonly used, and there was small-size trials, and because of the heterogeneity of the population, there was limited efficacy of the results. And then there was randomization era where they tested a combination of drugs and then combination of chemotherapy plus immuno-targeted therapy. And they came to know that vinflunin is a drug which demonstrates better overall survival compared to best supportive care. And all the targeted therapies were tried, but they did not do very well because they were not selected in one particular group where targeted therapy could have done well. So this is where the biomarker selection is important. And there was also the concept of maintenance therapy after if the patient has a better systemic response to first-line systemic therapy. Then now it is the era of immuno-oncology. Depending on the PD-L1 expression, we have PD-L1, PD-1 inhibitors, which have a very good response rate. The important aspect in PD-L1 inhibitors is that they have a very long-term durable response. Durable response means they have a response for a very long period of time. If the patient responds well, they are going to do well. So this is a slide where the responders and non-responders is been depicted. Responders generally have an immune environment, which we call it as tumor microenvironment, which is more favorable for immunotherapy. So they have an expression of PD-L1, which is a surface marker, which is a programmed death ligand. So more expression of PD-L1 says that the patient will do well with immunotherapy. And there are CTLA inhibitors also. These are also important expression factors which are tested before starting immunotherapy. In the non-responder group, we can see that the lymphocyte is quiescent, doesn't express PD-L1 and CTLA4. And there are immune suppressive environment, which is brought about by myeloid-derived suppressor cells. So we have to have an immune proficient environment with high expression of PD-L1 rather than immune suppressive environment for the treatment. So I'm going to discuss about Keynote Trial 045, which is a phase 3 second-line clinical trial in the management of advanced urothelial cancers. The clean inclusion criteria here were that the patient has to be histopathologically diagnosed urothelial carcinoma of the renal pelvis, ureter, bladder or urethra, predominantly transitional cell histology. And the disease should have progressed after a platinum-based chemotherapy or the recurrence within less than 12 months after perioperative platinum-based therapy. And the patient should have not more than 2 prior lines of therapy and with a good ECOG performance status 0 to 2. So they were randomized 1:1 with either immunotherapy, pembrolizumab, 200 mg IV every 3 weekly, or the investigator choice of therapy, which was paclitaxel, docetaxel, or vinflunin, whichever the investigator was comfortable. And it was continued until was to be continued until 2 years of pembrolizumab treatment, or until the patient had unacceptable toxicities, or if there was a progressive disease, or if the investigator decides that we need to stop the further treatment. And they were stratified according to the performance status, hemoglobin level, liver mets, and time to last chemotherapy. So the primary endpoint was overall survival and the progression-free survival according to the RECIST 1.1 criteria. And the secondary endpoints were safety, how was the overall response rate, and the duration of response. So the enrollment started in November 2014 till November 2015. These are the different endpoints when the study data was assessed. So in 2016, there was this 14 months follow-up data, and subsequently in 2017, there was a median follow-up of 27.7 months. So these are some of the, it's a busy slide where some of the baseline characteristics were assessed. The median age were more or less stratified with a smoking status, present or former smoker. And most of the patients were ECOG performance status 1, and time since chemotherapy was less than 3 months in both the less than 3 months for both the groups, and most recent therapy, whether it was neoadjuvant, adjuvant, first line or second line, they were equally stratified. And a number of risk factors were also calculated, and all the parameters were stratified. So the initial data with a median follow-up of 14.1 months, we see that the overall survival for pembrolizumab group compared to chemotherapy group was about 10.3 months versus 7.4 with a significant p-value and a good hazard ratio, 0.73. And at the 12 months, the percentage of the patients, almost 43% versus 30% of the patients were doing well. And the progression-free survival had a hazard ratio of 0.98 with a median PFS of just 2.1 months. So in immunotherapy, we understand that they don't do really well initially, but on an overall long-term basis, they do well. That's why we have a better overall survival compared to PFS. And the overall response rate is also better in pembrolizumab, 21 versus 11. And the duration of response is also better in the pembrolizumab arm with a 12-month estimate of 68 versus 35%. So this study was further followed up for another 5 years, and the results are depicted here. And the median time from the randomization to cutoff was almost 5 years, and it was done on October 1st, 2020 with a follow-up of 62.9 months, where they found that initially assigned 270 patients, 266 were treated, 25 had completed the treatment with the immunotherapy arm, and 11 patients were in complete remission. There were multiple reasons for discontinuation. Progressive disease was the most common. In the chemotherapy arm also, among the 275, 255 were treated, and almost all discontinued treatment at the end of 5 years. Progressive disease was the most common reason. And if you can see this curve, we see the separation of the curves, which begins as early as almost 6 months, and there is a better separation of the curves in about 12 to 24 months, and we have a continuation of separation up till now 62.9 months. So the median overall survival was 10.1 compared to 7.2 with a good hazard ratio. This forest plot curve says that the overall survival was better in almost all the subsets, irrespective of the age, cisplatin or carboplatin. Irrespective of the platinum, they did better. And liver metastasis present or not, they did better. And anemia or not, they did better. And with respect to visceral disease or risk score or PDL1 status, if the PDL1 positive was more than 10%, they did well. So almost all subgroups did better on immunotherapy. And the PFS, which I told you, immunotherapy doesn't have a very good PFS. So the progression-free survival was 2.1 months compared to 3.3 in chemotherapy with a hazard ratio of 0.95. And the objective response rate with respect to the two entities, pembrolizumab had an objective response rate of 22 almost, and chemotherapy of 11. The response is best assessed by a CR, complete response or partial response. If you see, it is 21 compared to chemotherapy, which is 11. So stable disease is also a response. About 17% were under stable disease in pembrolizumab arm, whereas chemotherapy, they were 33% of the patients. So the duration of response is also an entity which was a secondary endpoint. So they found out that the duration of response was also better at multiple intervals like 12, 24, and 36 months with a separation of the curves. Pembrolizumab had a median duration of response of 29.7, chemotherapy of just 4.4 months. So if you see the best overall response rate with respect to complete response or partial response and the stable disease, we see that there is a very good separation of the curve for patients who are on CR and a partial response rather than stable disease. Stable disease, they do initially well, but later there is progression of the disease. Immunotherapy, what we need to understand here is that they come with immune-related adverse events, which are unlike the events of chemotherapy. So more important adverse events here are fatigue. The patient has pruritus. The patient has more of nausea. Whereas in chemotherapy, you have more of alopecia, febrile neutropenia, very low counts, and peripheral neuropathy. So this is a representation that pruritus, fatigue, nausea, and decreased appetite were more common in pembrolizumab arm, whereas here in chemotherapy arm, alopecia, febrile neutropenia were more common, and grade 4-5 adverse events are also more on the chemotherapy arm. And the severe immune-related adverse events, they are very much peculiar for immunotherapy. So these are skin reactions, severe skin reactions, and some are grade 4 or 5 also. Hypothyroidism, pneumonitis, hyperthyroidism, and colitis. So these were commonly seen. These are mostly immune-related. And one more entity of pancreatitis is also an important side effect of immunotherapy. So NCCN guidelines says that the second-line systemic therapy for locally advanced or metastatic disease, after the participation in the clinical trial, pembrolizumab, with respect to the above data mentioned, is the treatment of choice, is the preferred choice rather than systemic chemotherapy. So in conclusion, the 5-year follow-up of Keynote 045 says that there is improved overall survival, overall response rate, and duration of response compared to chemotherapy in patients with advanced platinum-resistant cancer. The overall survival was 10.1 versus 7.2 months. A response was 22 versus 11, and a better duration of response of 29 versus 4.4. The safety profile also, pembrolizumab did better with chemotherapy. The treatment-related adverse events were 62 versus 90% compared to chemotherapy, and the grade 5 adverse events were also less. So it is a better tolerated drug. So this is consistent, the 5-year data is consistent with the 2 and 3-year follow-up, and that led to approval of pembrolizumab as a treatment of choice for a platinum-resistant refractory urothelial cancer, irrespective of the PD-L1 status. So the health-related quality of life of pembrolizumab versus chemotherapy was also assessed in this trial. So the curve says that the global health-related status of the quality of life score was about the median months of betterment was 3.5 months versus 2.4 months with a hazard ratio of 0.72. So pembrolizumab had chemotherapy had earlier deterioration in the global health-related quality of life compared to that of pembrolizumab. And with respect to different functional domains, not only the global health-related status, physical functioning, role functioning, emotional functioning, cognitive and social functioning, all the parameters, pembrolizumab did well compared to that of chemotherapy. And change from the baseline to week 15, worsening of the particular signs and symptoms like fatigue, nausea, vomiting, pain, insomnia, and other frequent side effects, pembrolizumab did less worsening compared to that of chemotherapy. So all these said that pembrolizumab is a better, very well tolerated drug. And we see that at 15 weeks, pembrolizumab with 31.2% and chemotherapy with almost 21% had a deterioration, and there were higher rates of improvement associated with the pembrolizumab in almost all functional domains, and lower rates of deterioration were observed in the pembrolizumab group. So the EORTC quality of life criteria also had testing of these two drugs in different functional domains. In all the previously mentioned functional domains, similarly was tested, and they found that pembrolizumab did better compared to that of chemotherapy. Not only the functional domains, but also the symptoms per se, pembrolizumab had caused less deterioration of the functioning. So in conclusion, for the health-related quality of life also, pembrolizumab is a better drug with improved health-related quality of life compared to systemic chemotherapy, and combined with superior overall survival and lower rate of adverse events. All of the data suggests that it's a new standard of care for the management of refractory urothelial cancer. Yeah. Thank you for the patient hearing.
Thank you. Thank you, Dr. Nasir. That was a very exhaustive talk on urothelial cancer, right from epidemiology to the latest on immunotherapy. Just one question, a lot of immunotherapies are coming in this arena. Is there any biomarker that would guide your therapy in the first line for immunotherapy with avelumab, or in the second line with immunotherapy with any of the other agents?
If it is like a metastatic disease, we do a PD-L1 testing. But if the patient is platinum ineligible, then only if the PD-L1 is positive, then we go for immunotherapy. The preferred choice of drugs are here pembrolizumab and atezolizumab for me. And if the patient is doing well post the systemic chemotherapy, then I would like to put them on avelumab, irrespective of the PD-L1 status. In the second line therapy, we have a very good data of Keynote 045. Pembrolizumab will do well irrespective of the PD-L1 status.
So if we have one burning question, we can take that, or else we should move to the next session as we are running a bit behind time. Thank you, Dr. Nasir. There seems to be no questions from the audience. So we'll go to the last session of the day. The session will be taken by Dr. Aditya Pradhan, who is the Director of Urology and Renal Transplantation at the Max Super Speciality Hospital. Sir has also special interest in prostate cancer. So he will be taking us forward on the role of GnRH analogs.
Little late in the day for a mundane topic like this, but let's do the honors. So we are talking about ADT, and that too in high risk. So what is really high risk first and foremost? So this, the EAU grid actually helps us to understand best. High risk obviously is anything grade group 4 and beyond, but also high volume 2 and 3, which sometimes we tend to forget. High volume 2, 3 also can be high risk. What does the current guideline tell us in terms of what we are doing and what is changing? Nothing much has changed in the way we work up a patient, whether we're looking for that the primary or for metastatic survey. It's standard. We're doing a clinical exam. We're doing the PSA, looking at the dynamics. We're doing a PSA doubling time. Obviously, we're trying to see his overall fitness and also life expectancy. And then you do the requisite imaging. All this we are all doing. And then we stratify the patients, as I just mentioned, into high risk or a subgroup which is even higher in risk. Those who have more than one of the high risk factors, that is T3, grade group 4 or 5, and PSA more than 20. If there is more than one of these factors, he is very high risk. So what has changed in the most recent edition of the NCCN for this group? So I would actually highlight by if you look at this, which is, yes, for a patient who is a high risk, we need combination therapy, we know that. It's not only radiation or surgery, it's radiation with ADT, and now we're going beyond that. How? We're intensifying ADT by adding either abiraterone or docetaxel, and we're adding 6 cycles to that. So we seem to realize that for a high risk or very high risk, the systemic component is probably more important to address than the local component. So I think this is what is changing in our understanding when we treat patients of high risk cancer, and this is now in the latest edition of the NCCN up on this. Well, after primary therapy, what next? So we have done a prostatectomy, and then there is a PSA recurrence or there's a PSA persistence. How do you look at? So the basic steps start with what is the risk. You look at the doubling time, and you look at the pattern of metastasis, and then you see if the patient has got metastasis distally or is negative. If it is no distant metastasis, it's only a biochemical recurrence, he may be advised to go for EBRT or external beam RT along with androgen deprivation therapy. In a metastatic disease, obviously, we have been through so much of this, and I don't need to repeat it. For radiation recurrence patients, what do we do? So again, the risk stratification, as I just mentioned. The additional thing we try to do here is look for local recurrence in terms of imaging like an MRI or a PET, and then decide whether this patient has on a TRUS-guided biopsy a local recurrence with a good survival. Then he may be a candidate for local therapies like cryo, HIFU, etc. If your TRUS biopsies are negative, so here's a patient who has no obvious recurrence on your metastatic workup, you may obviously like to wait and then start with ADT later. Now, some studies which have been done on this subject earlier. So this is combining androgen deprivation therapy with brachytherapy. This is a study done a little earlier, about 200 patients, where they were treated with brachytherapy using iodine 125 or the palladium seeds. One group received hormone therapy and the other did not. The overall biochemical survival, overall freedom from biochemical survival, which was the endpoint chosen, was about 68%. But there was a big difference when radiation was added. They tried to also look at give more radiation made a difference, and yes, it did. The patients who received a higher dose, they had better overall survival, as well as those patients who were in the intermediate risk group, they did better. The conclusions from this was a retrospective study, and they concluded from the data that the outcomes were best when you gave a high dose radiation to the intermediate risk patients along with adjuvant hormone therapy, and it gave a significant difference at 4 years, amounting to almost 94%. How does external beam RT work with this? So this has been studied for many years. Bola's articles have been numerous on this, and the duration of therapy use has been varied from 6 months to 3 years, but all of them uniformly showed improvements in survival. So adding adjuvant therapy indefinitely. Now this is something probably we don't very commonly use, but there is data telling you that indefinite, that means starting right at the outset and continuing, has probably definite advantages in terms of survival and the freedom from progression. What about neoadjuvant? Again, very briefly discussed, but probably all of us have concluded from these so many studies done on the subject that as of today, neoadjuvant therapy prior to any radical prostatectomy does not have a definite clinical role so far. At least the guidelines do not accept it. We know this particular topic that how do you achieve your ADT versus surgical castration is. What are the differences? I don't think I need to repeat this now. A little bit has been touched already by earlier speakers on the debate where the antagonists work better than the agonists. There are some differences basically on the way the drug acts. The antagonists definitely have an earlier onset. So degarelix, if you're using it as a molecule, would within 3 to 4 days reach a castrate level. You don't have to deal with flares, but you need to deal with local reactions. So as a clinician, when I have to choose between either of these two agents, I would look at the cardiac profile of the patient. If he has got a cardiovascular risk, I would preferentially treat him with an antagonist. If I need to treat a bulky disease, a patient who is likely to go into obstruction, I may probably start off with an antagonist and may probably switch later. This is on the drug for which we are speaking, which is Zoladex. Zoladex is one drug which has been tried extensively, and these are two trials which I'm just mentioning, where Zoladex was used to look at the addition of Zoladex benefiting a patient where radiation was used. So adjuvant Zoladex with radiation, 10-year cancer-specific survival, much better with the combination at 47% versus 22%, and the mortality also was significantly lesser. So you can achieve up to a 40% reduction with the use of Zoladex in addition to radiation in this study. What about this trial which looked at high dose radiation combined with Zoladex given it long term versus short term? The results at 5 years disease-free survival had a significant difference when you exhibited Zoladex right from the beginning and continued it indefinitely, the trial I just mentioned earlier. So I'll conclude this talk by saying that as of today, for the high-risk patients when we are dealing with them, we still don't have evidence that neoadjuvant hormone therapy works. We have good evidence to say that hormone therapy works well with radiation. And between the two agents, agonist versus antagonist, the antagonists achieve a faster level, but you need to deal with certain drawbacks of the drugs, and therefore agonists still have a very strong role to play in our therapy. Thank you.
Wonderful, sir. Short and succinct, and you finished nearly 4 minutes before time. So I think we can have a few questions from the audience also.
Sure.
But let me just set the ball rolling with a question. You rightly pointed out that, regarding the duration of androgen deprivation therapy, for both the intermediate and the high risk, there are trials that are from 6 months to 1.5 years, to 3 years, to lifelong. This is, all over the board. So, but the recommendations are around 1.5 to 3 years. Many of us use 2 years. So, what do you see from this, very, very varied evidence? What is your take, continuous or a shorter duration?
I would say that initially we were tended to go longer. Probably because the radiation arm itself was not very strong, and therefore we tended to hit them more systemically. I think today the trend is changing. Many of our radiation oncologist colleagues are happy to stay on 6 months and leave it at that.
Both intermediate and high risk.
For the intermediate risk, I would not say that for the high risk. I mean, specifically, I will speak for intermediate risk.
Thank you. Any other questions from the audience?
Audience, any question? Thank you, sir.
One question.
Yes, there is a question. There is a question.
One question.
Yes, Rajesh. Sorry.
Yeah, patients who develop biochemical recurrence after radical prostatectomy, who are going to receive early salvage radiotherapy. So, how long do you give ADT?
So, in terms of salvage therapy, the short-term chemotherapy is ADT is what is being looked at, and there are now many centers who will actually not give ADT. They would simply give single-arm radiation and wait. I have seen some data on that, and they show equivalent results. In fact, they do monitor, the testosterone levels to see how they're behaving vis-a-vis the PSA, and they found that it is probably not required. So if you have got a very good radiation backup, they may be happy not to exhibit ADT at all. I've seen that happening.
So just to add to what sir said, where there was too many high-risk factors, and probably then they give hormone. Okay. Now the duration of hormone in early salvage radiation, if you are asking, that was a radicals thing. Yeah. In that only the first part has matured. The second part, the data has not matured. So that will come in, I think, sometime in 22 late or 23.
But the RAVES RT data is suggesting go lesser and lesser.
Okay. Okay. Yes, we have a radiation oncologist.
Perfect person around.
Get a few data is clear. If multiple risk, as you said, give 6 months.
That is what I said.
6 months if you have multiple risks. Yes. If you have just 1 or 2 risk factors,
then we use the RAVES data.
Two is the data.
For that we use the RAVES data.
RAVES is not very clear about it.
So I'll have one pointed question. Like if we have early salvage RT today, will we give 1 3-month dose? Will not give, we'll give 6 months.
See, what my experience is, I will not get one risk patient. Then you people do not send me. If it is multiple, you send.
One risk
At
patient
that time, I'll use 6 months.
One risk patient you will get only when it fails a little later. That is why we call early salvage, that other terminology.
Then I will use 6 months.
6 months, okay. So let's see, but the radicals data is yet to mature on that basis.
Yes, sir.
That's controversial actually. Early salvage, it is controversial, but it is published, so let us be clear. Let us not end up with saying controversy.
I think you also, Ganesh, I think you also need to see what point you are going to intervene. Are you going to wait for the 0.2 or are you going to come earlier?
No, 0.1 or something.
0.1 or in fact even earlier if you got
nowadays
yes,
and those rising values.
And another question, sir, last question. Regarding the cardiovascular risk factors vis-a-vis GnRH agonists versus antagonists. So we've been like classical teaching is antagonists are better, but again now goserelin is better. I mean there is no difference with goserelin. So what is the confusion all about?
There is no confusion. In fact, the antagonist score proven on RCTs. Prospective data exists today. There's an Israeli study, though small in number, which has shown you categorically that if you have a person with pre-existing risk factors and you need to actually look at them, then right from the beginning of the study, the curves separate. Agonists versus antagonists, the antagonists do better. That you have now level 1 evidence. So personally, if I have to start therapy, ADT has to be started. I would actually seriously start only on Degerlix, see how the patient is responding. And most of our patients have some cardiac risk factors.
Yes.
You would have some lipid disorders, Very
Yes.
common to have patient who's had a prior angioplasty, and now you're treating him. So in this kind of patient, you want to put in an agonist at the beginning, I think would be probably not so safe.
Not so safe. Yes, sir. Because one of your slides shows cardiovascular doesn't have any difference.
That is basically, well, you're sitting in an industry-sponsored session. This is
Okay,
what
sir.
Zoladex would like you to
Okay.
believe. But I don't believe it personally.
Okay, sir. Got it.
Aditya, can I have a question with you, please? Have you actually looked at the cause of death in the patient who's on the agonist in our country to say that it was cardiac? Have you actually looked at it? Have you done autopsies? Have you said, I mean, he died of prostate cancer, but what was the cause of it? Was it actually cardiovascular? Or are we just aping what the West is telling us?
Where is the data to tell us that, sir? We don't have that data.
That's what I want to know. Are we just taking
We are
something?
simply extrapolating Western
Answer
data
that.
or Israeli data.
I don't have an answer to that, but I distinctly know that Dr. Amit Joshi, who is our medical oncologist at Tata Memorial Hospital, he is collecting retrospective data on that. It's going on since something like 2 years. So we should get some data. I mean, he's collecting of all metastatic prostate cancers, whatever has been the ADT.
Fair enough.
So I think that
So,
was a
thank you
wonderful
so
end
much.
to tonight's session. We had three very interesting talks, starting from the genomics to going on to immunotherapy in urothelial cancers and ending with hormone therapy in prostate cancer. So over to the organizers for...
Yeah, thank you so much, Dr. Bharat. It was nice. And we have the last talk, one of the abstract presentations, which has got a prize. Two of them will be presented actually tomorrow when the program is slotted. But since Dr. Ravi Mohan is leaving early morning tomorrow, we are having his presentation today.
Very nice to have.
Dr. S.K. Singh, I have requested sir to be on the chair.
I think good evening to all ladies and gentlemen. We really appreciate your patience. I may be for another 10 minutes.
For 2 minutes.
Another 2 minutes, okay, right. So that's very good. So it's a very crisp and precise. This is very nice that SOGO has created this competitive scientific atmosphere so that people can present their, innovative work. And then the encouragement is by awards. So the 3 papers have been again chosen as the best paper. And Dr. Ravi Mohan, Professor Ravi Mohan has to leave tomorrow. So one of his PhD candidate has worked on the topic that aldehyde again receptor. So he will be talking on that. So only 2 minutes. Yes. So for 2 Professor
Thank you,
Ravi
sir.
Mohan.
So to this audience, any basic scientists in the audience? That makes it 1 minute, so that can be fast. So, variant histology we all know, and we've been struggling that we don't have a good marker and they behave very aggressively and so on and so forth. So, my PhD student, he actually came up with an idea that ALDH isotypes, which are very commonly present in many solid tumors and has been reported in urothelial tumors, but never been seen in variant histological subtypes. And so we wanted to see whether this ALDH isotype has to do anything with variant histology. And why we selected ALDH? Because there's a drug which is very active against ALDH isotype receptor blockade drug, which is easily available. So if at all it goes on to that level, we might actually have a therapeutic benefit out of it. These are the material methods. Since there are no basic scientists, for want of time and food, we will skip it. So we identified 47 patients in this duration with variant histologies, and out of this, 47 total patients whose entire data was available. 34 were variant histology. The age group of presentation was almost comparable between the variant and MIBC group. Males dominated. And all these brown areas which you see is the ALDH isotype, immunohistochemistry of the ALDH 1/2 and ALDH 1A3. And you can see almost all the tumors are lighting up brown except for a few micropapillary tumors. So we found that as compared to conventional MIBC, ALDH 1A3 especially was overexpressed in the variant histology significantly more than the conventional histology, conventional type. And even the percentage ALDH 1-2 expression was significantly more in variant histology than the conventional types. We also found, surprisingly, that in the conventional group, ALDH was expressed only in the cytoplasm, whereas in the tumor, in the variant histology, it was expressed both in cytoplasm and nucleus, which needs to be explored further. The implication of that has to be explored further. With respect to survival curves, we found that patient, both in conventional as well as variant group, the expression of ALDH did change the survival outcome. So those patients who had ALDH expression, whether the conventional or variant group, had a poorer outcome. So this is what these graphs are showing essentially. So from this we concluded, and I stick to my promise, that ALDH overexpression can serve as a prognostic marker in probably both conventional and variant types, but then there is something in variant which is not seen in a conventional group, maybe which needs to be explored in future. Thank you.
Yeah, Professor, everyone, just one point, one message. I would like to again make you add. Does it have clinical implication maybe in the future, translation medicine?
Yes, sir. So as I said at the outset, we have ALDH receptor antagonist which is there in the market, and it is in the sideline. It is not being used very commonly. Somehow, and the Department of Pharmacology and Histopathology, they actually came up with an idea that this molecule targets ALDH. If we go on to prove that it has an implication in the expression is good in TCC, and the second phase of the study is actually to do an in vitro experiment to see that if we block that receptor, are the cells going to die, and what is the outcome. So if that comes true, and the third level of experiment is to do a mice experiment, that we create a mice model and develop a tumor and actually give the drug. So this is how it is planned. This is the first objective which is being presented here. So if that comes true, yes, it would definitely have a translational outcome.
So do we have a drug actually? Do we have a...
We do have a drug. I don't want to disclose it to
no problem. And secondly...
There is some medicine which is used for some other indication has got this.
I think we'll leave it here, sir.
Okay, you don't want to reveal.
So there is one small question.
Yes.
Doing this particular test, I don't mention the cost also if you want, but is it too costly? Since the study would be funded actually.
So this is a IHC on the tissue. So it was done by a standard kit.
Right.
So it's about 30K for 40 samples. So that's what.
Yeah,
that's quite cheap.
Dr. Ganesh, what happens? The drug is very common because he has asked me not to tell.
No
I'm
problem.
too much vocal.
We don't disclose
I
the
think
drug.
we'll
You
come
are
up.
perfect.
Yeah. So
let's not keep on having these markers, and
very
sometimes
cheap.
it is very expensive. That's why.
No, this medicine is very cheap. Like we have been using autophagy inhibitor, that is hydroxychloroquine tablet, and then we could say during again the pandemic of the COVID. Okay, why you are afraid? We have been trying. This one is very safe. Don't be afraid. So hydroxychloroquine is a common drug. What is he's going to use is a very common drug, not very cheap. But same time, it has got this quality.
Ravi,
and can
if I
have
ask
another
one more
indication.
question, sir is going to tell me the drug. Bye.
Thank you.
No, I will not. Thank you. So thank you. I think
thank you for the opportunity.
We have made it very interactive.
Thank you.
And Dr. Ganesh, now mic to you. Thank you very much.
Sir.
Thank you.
Thank you so much. Thank you AV team for being there for the whole day. Thank you so much, and thank you everyone who is there right now here, because it's been a whole busy day and a tiring day. There is dinner and cocktails outside. I think after some time. Is Vignesh there? Yeah, Vignesh, the time of dinner, like 7:38. Dinner cocktails time.
So already it is 7:30, so it cannot be 7:30.
Already ready?
10:15.
So 10-15 minutes it will be ready. People who want to go have a shower and come back, please. The swimming pool is also on, you can carry on.